We are Healthium, a leading global player in medical devices, creating access to precision medtech for every patient globally. Our passion for R&D, stringent quality control, and sharp focus on next-generation technology has resulted in 52 patents in India and the US, and enabled us to get US FDA, CE, and ISO approvals. We are the largest independent manufacturer of surgical suture needles in the world, the first in India to manufacture bioabsorbable implants and contribute to 50% of India's suture exports. Across the globe, surgeons use a Healthium product in 1 in 6 surgeries to ensure superior surgical outcomes. This is our legacy, born from passion, precision, and a quest to create medical devices that simplify usage for surgeons and benefit patients globally. In our quest for innovation, we have created products of superior design by combining our key understanding of the market with new generation technologies. Presenting the next generation endo cutter stapler from Healthium that combines precision articulation, single-handed operation, and versatility of using one handle for all types of cartridges. Healthium endo cutters create an optimal B-staple formation, even in varying tissue thicknesses, and ensure optimal hemostasis, support wound healing, and prevent necrosis by ensuring adequate perfusion to the edges of resected tissue. The strong titanium staples withstand pressure under situations of high tissue load. The sequential staple height cartridges ensure calibrated compression, low tissue stress during compression and clamping, and enhanced perfusion to staple line. Lateral tissue fluid diffusion during compression results in less force to fire. Healthium endo cutters offer optimal wound healing even in organs with variable tissue thicknesses. Healthium endocutters use a unique technology that ensures optimal B-staple formation at the near, mid, and far end of the stapler, regardless of tissue thickness, and hence offers superior staple line integrity. The sturdy and ergonomic handle ensures single-handed operation, precise articulation on both sides, and a simple loading mechanism ensures a superior user experience. Healthium Next Generation cartridges come in 3 different types and 24 variants to address all tissue types and organs. Look for our ordering information. Guns in 3 sizes and straight and articulating reloads in different sizes. The result of precision and design excellence, Healthium's new generation linear cutters for superior surgical outcomes. Healthium linear cutters ensure optimal hemostasis, support wound healing, and prevent necrosis. Healthium linear cutters offer uniform staple compression, resulting in an optimal staple line with well-formed B staples, irrespective of tissue thickness and/or structural complexity of the organ. Healthium linear cutters fire with uniform firing force across the staple length, ensuring well-formed B staples. The floating cartridge and inbuilt mechanism prevent accidental firing. Healthium linear cutters offer easy and confident firing action with an ergonomic handle, secure grip, and an adjustable ambidextrous firing knob. Healthium linear cutters offer the highest 5 variants of stapler cartridges in blue and green to address tissue length and thickness. Look for our ordering information. Healthium's new range of next-generation endocutters, linear cutters, and reloads are complemented by our circular and hemorrhoid staplers. Across 18,000 hospitals in India, these products bridge market need gaps and continue to make life easier for surgeons, assisting them to provide desired surgical outcomes. This is what we call precision with a purpose. Healthium.
rename ഇല്ലേ?
വീഡിയോ
Morning, Dr. Hiramat.
Good morning.
I think yesterday went on reasonably well.
We'll be just talking initially.
Hello. Yeah.
Yeah, the flow, I will just tell you the flow, how we have planned.
Okay.
See, I will be inviting the family members, the associate members, and the president. And after that, a small video will be played. And the order goes like this: the president will be called in to speak. After that, Dr. Muralidharan and Dr. Chandrasekhar, Chitra Institute team. And after that, Dr. Sivaraman and Dr. Tyagraj Murthy, who have expressed themselves, they would like to speak. And any other members also can speak subsequently. And last 5 minutes will be given to the family members. And again, we'll be winding up with the video play.
Perfect.
This is the plan. Because I have to finish by 9 o'clock.
Yes.
I have to finish by 9 o'clock. Yeah.
Morning, Dr. Chandrasekhar.
Hello, good morning. Good morning, Hiramat.
Good morning, sir. Morning, Dr. Muralidharan. Good morning, sir.
Heramat, I just spoke to Sundar's wife, Bonnie, and they should be logging in.
Sure, sir. Sure, sir. I request everyone to unmute their mic, sir. When we are speaking, only let us mute. We will start. Darshan. Niranjan, you there?
I'll just call Puni and just remind her for a second.
Darshan, can you put the first slide? Yeah. Chandrasekhar, can we start, sir, or wait?
Yeah, I just called. She is logging in, so I'm sure they are busy with a lot of visitors today, Saturday morning. So I'm sure she is. I just called her, so maybe just a couple of seconds we can wait to see.
Sure, sir. Chandrasekhar, when you put your audio on, lot of disturbance is there.
Maybe the fan. I'll switch it off.
Yeah, please. Yes, it made a difference.
Made it different. Yeah.
We will start, sir, as they join. Is it?
I think so. I think if you're hard pressed for time, I think CME has to go on. You can start. I think they will be joining anytime. Yeah.
Yes.
Sure.
Good morning, dear members and friends. Good morning. We are gathered here to have the condolence meeting of Sundar Ramanathan, who passed away recently due to a prolonged illness. We'll have 30 minutes meeting, and we have requested the family members. His wife and two daughters are joining shortly. And we have made a small video on Dr. Sundar Ramanathan, which will be played. After that, I would request our president, Dr. Chitra, to speak a few words, followed by Dr. Muralidharan, the past president, and Dr. Chandrasekhar, his colleague at GKNM, and Dr. Sivaraman, Dr. Tyagaraj Murthy, Dr. Bashi, Dr. Merwal will follow accordingly. After that, by ending, we will be asking the family members to speak a few words, and the video will be displayed again. Please put the video on, please. I request 1 minute silence before the president. Thank you. Over to Dr. Nair, please.
Good morning, dear friends. We are gathered here today on a very solemn occasion to remember our dear friend, Dr. Sundar Ramanathan, who left us for his heavenly abode a few days ago. At the outset, on behalf of the Indian Association of Cardiothoracic and Vascular Surgeons, I would like to offer our deepest condolences to his family, his wife and 2 daughters whom he left behind, and pray to God Almighty that he gives them the strength to bear with this incomparable loss. Dr. Sundar Ramanathan, apart from being a very proficient cardiac surgeon, was also a very active member of the association and served as its executive committee member for 3 years. His term ended this February at the last IACTS meeting, and that was the last interaction I had personally with him when he handed over charge, and we felicitated him for his contributions to the association. What was remarkable about him was that even then we had no inkling of what health issues he was suffering from, and that speaks volumes for his fortitude and grace with which he always conducted himself. I always remember him during the executive committee meetings for his extremely calm demeanor and the way he would put across his point of view without any aggression or without excitement. He always brought about a very calming influence to an often raucous executive committee meeting, and that was one of his greatest strong points, I would say. With his loss, the society has lost a very important member of the association, and I'm sure his patients would also feel the same. Once again, my sincerest and deepest condolences to the family, and I pray to God that his soul rests in peace. Thank you.
Sir, over to Dr. Muralidharan, please. Sir, I think 2 Zooms are on in your place.
So just switch off your phone. I think your phone is also on.
Okay.
It's echoing, sir. I think two devices are on. Zoom, 2 devices are on at your place.
The phone,
In the phone and in the system.
Are you okay now?
Yes. No, sir. It's really going. Meantime, as it sets right, sir, I request Dr. Meherwal to speak a few words.
Okay.
Set it right, sir. Meantime.
Right. Friends, my interaction with Dr. Sundar has been mostly in the meetings, the conferences, and other academic activities. And I used to interact with him as a cardiac surgeon, and he was interacting very professionally. But as an executive member of the IACTS, I have very closely interacted with him on all the occasions. And I found him a very dynamic person. In all the meetings, he used to participate and used to give very positive inputs. And I very clearly remember when you were discussing the IACTS database, he had given a lot of positive inputs. So his contribution, I think, to the society, to the IACTS has been great. And at the same time, I know he was a great surgeon and a great human being. So we have lost a great surgeon.
You lost your audio, Dr. Merwan.
You hear me now? Is it audible?
Yeah.
So I think we have lost a great surgeon and a great human being. It's a great loss to the IACTS and to the whole fraternity and to the society. My heartfelt condolences to the family, and we pray to the God to give strength to the family. May his soul rest in peace. Thank you.
Yes. Dr. Muralidharan, your audio is fine, sir.
Okay.
It's still echoing, sir.
So if you just switch off your phone, I think that will be best. Just switch it off.
We can't hear you, sir. Meantime, I'll invite Dr. Chandrasekhar, sir, as it sets in. Go ahead, sir.
Dear Hirmat and members of President Dr. K.S. Iyer, I indeed greatly appreciate the IACTS for holding this meeting on behalf of my beloved Sundar. If I get emotional during this talk, please, my apologies to that. And can I share my screen, please?
Please, sir. Yes, sir. Darshan, please allow sir to share the screen.
I am disabled actually. So can I share my screen, please? I have a few pictures and slides to show. So yeah.
Darshan, are you there?
Yeah. Pony and Darshana are there. So I just put it on slideshow.
At the outset, let me welcome Mrs. Puni Sundar Ramanathan and daughters Darshana and Madurai for the meeting.
Thank you very much. I would like to show a few slides and share briefly, of course. I can speak volumes about Sundar for our long association of 43 years. So Sundar, as you could say, lives forever in our hearts. He was a very meticulous surgeon on the professional basis, very systematic and methodical. And I am sure he was a great teacher to all of our students. He used to handhold and teach them the steps. No doubt his patients loved him, and it will be a huge void for our department and for the fraternity. I know him from school days, right from my 7th standard. He was 1 year senior to me in school and college, and in Coimbatore Medical College. And we really got close in JIPMA when we did our residency, when we were sharing the next room in Harvey House. He did his MCH from Sree Chitra, then went to UK for his specialty boards. He was one of the few early surgeons in India who got the FRCS in cardiothoracic surgery. He came back to GKNM. Actually, the seed for becoming a cardiac surgeon was planted in GKNM. After his MBBS, he joined GKNM under Dr. Muralidharan as a medical officer. And that is the time he got inspired. Seeing Dr. Muralidharan, he wanted to become a cardiac surgeon, which he achieved with hard work and grit. So he served GKNM for 2 decades after he came back from UK, and appropriately the institution bestowed on him the highest award, the Distinguished Service Award, in 2017. Sundar was known right from his school days for his great oratory skills in Tamil. He was very passionate about Tamil, and the moment he comes on stage, he would be welcomed with a huge applause from the crowd, which I still rings in my ears. And his oratory skills in Tamil, I'm sure many of them who have heard him would know how good he was and eloquent he was. He was an extremely fit person, and he used to love running, and he used to participate in all the marathons, and he was fit as a fiddle. Unfortunately, the disease conquered him. This is He was part of every activity in GKNM, and this is one of our workshops where he is seeing along with Dr. Patrick Perrier. So he was a huge pillar in the founding pillar in the department, and he held the department together. We are a family in GKNM, I would like to say, and we have our annual parties where Sundar is always a great sport. I'm sure many of his friends would enjoy the great sense of humor he exhibited even in trying times. I know he was fighting an illness, and then even in his, when he knew the chips were down, his sense of humor kept him going, and I think we would really miss him, and we really miss him too. Now, I would like to end my brief note about Sundar. As I told you, I can talk for long, but Najayate Mritayeva Kadachin Nyayam Bhutva Bhavita Vanabhuyaka Ajo Nityaka Shashvatoyam Purano Nahanyate Hanyamane Sharire. This is Krishna's statement in Bhagavad Gita, and I'm sure his spirit lives and will continue to guide us, and may God bless him, and I pray for the Almighty to bless his soul and take him with him to eternity. Thank you so much, Sharamat and the association, for giving me this opportunity to share my feelings about Sundar.
Yes, sir. Thank you for those kind words. Over to Dr. Tyagraj Murthy.
Okay, can you hear me?
Yeah, please go.
I really appreciate IACTS coming up with this Zoom meeting today on tribute to Dr. Sundar, who's been a very close friend of mine for the last almost more than 23 years. The first time I met him in a place called Wigan in England, where I was working. And one day I was about to go to my work. I saw another friend, colleague, gastroenterologist, who was coming down the stairs along with Sundar, and that's when Sundar was introduced to me. He said, "Sir, he's also from Coimbatore. He has come to give his FRC." At that time, he came there for giving his FRCS Part 2 for general surgery before going on to become a registrar there. Then after that, I lost touch with him, and then I applied for an interview in Birmingham for the specialist registrar rotation. And there, when I went for going around the Birmingham Children's Hospital, Sundar was working there. I met him there, and since then we've had an ongoing, friendship, almost for more than 20 years now. And since then, we both have traveled quite along, and I have come back, and after a few years, he also came back, and I met Punni and Darshana and Madhurya, who were little kids at that time, and we've been associated with them all the time. And my heartfelt condolences to Punni and Madhurya and Darshana and everybody. I really wanted to see him in the last year or so, but I spoke to him a couple of times on the phone, and I requested him, "Can I come and see you?" But unfortunately, he said he was not in a mood, and he said, "Murthy, I don't want to meet anybody." And even in the last fortnight or so, I requested Ponni, and he didn't want to meet anybody, but his pleasant memories will be there with me. And as everybody said, he has been very meticulous and very vociferous when things are, he will call spade a spade. And if he feels that something is not right, whatever the occasion may be, wherever the stage may be, he will stand up and say, "This is wrong. We cannot do like this." And he's a really guy with a backbone, and he will stand up to anything, any wronggoings and all that. So that sort of a person, when he's a kind of a guy who can be very friendly with everybody, guides the juniors, and very helpful to everybody. And it's a big loss, not only to the cardiothoracic surgery and also to the family and friends, because he was such a young age, and he's got really at least another decade or so of operating skills and everything to go. And he has contributed academically. And all the while, he has been a very hardworking person. And we all know that nothing comes easy in cardiac surgery, and never hesitates to do the hard work and run the last mile. So I'm sure, my condolences to the family again, and we're all there with you. And definitely, that things will go in the right direction for you all. And I pray the Almighty that his soul attains peace. And thank you, Dr. Hireman, for giving me this opportunity.
Thank you, sir. Over to Dr. Muralidharan, please.
Do you hear me?
Yeah, please go ahead, sir.
My first encounter with my dear friend Sundar was in 1987 when he joined as a junior houseman in our department. We were not very big at that time, and he joined us, and working with us, he had at that time itself the potence of somebody who was going to do good and come good in later life. From this initial period with us, he moved on to general surgery, then on to cardiothoracic surgery, finished, went and did his fellowship, and came back and joined our unit, and provided to be moved to be one of the pillars of the department. He was very meticulous. His presentations were excellent. He was always forthcoming in his views, sometimes which seemed a little rough and abrasive to the others, but it was the truth. Never afraid to speak up, at the cost of sounding a little rough to the rest of the people, but he did his point. He was very meticulous, hardworking. His documentation is a treat to watch. I wish some of the youngsters would follow the footsteps of his in the documentation process and working up patient care and patient care. He was an excellent person, meticulous surgeon, and didn't brook any compromises. There was no let us see chalta hai attitude. He was very firm on what he was doing. I left the institution about a year and a half ago, and I least expected that Sundar would leave the institution so soon. This is something totally unexpected. My condolences go to Punni, Darshana, and Madhurya. We are with you, and I think anytime you need any support, we are there for you. I hope you all take this setback in your family life in your stride and hope for the best. And I'm sure he'll be up there showering his blessings and care for you. May his soul rest in peace.
Thank you, sir. Go to Chitra Institute of Medical Sciences. Faculty, I request one person to speak as he had done his post-graduation there.
Thank you, Hireman. Dear friends, it was with a sense of shock and sorrow that we had learned of the passing of Dr. Sundar Ramanathan. True to his nature, Dr. Sundar had chosen to keep his struggles private. An alumni of 93 to 95 batch of MCH at Sree Chitra, he was fondly remembered by his colleagues as an exceptional trainee, an astute surgeon, a perfect gentleman, and an honest man who always spoke his heart out. We have had a pouring in of messages in our group, all remembering his warm and calm demeanor. On behalf of the organizing committee of IACTS Technocollege and on behalf of all the alumni of Sree Chitra, we wish to express our deep condolences and our prayers reach out to the family of Dr. Sundar, that God give them the strength to bear this immense loss. Thank you.
Dr. Bashi is there, sir. 1 minute you can speak, sir.
Yeah. Am I audible?
Yeah, please go ahead, sir.
Yeah, President Dr. Iyer, Hiramath, Punni, Darshana, Madhurya, and members of the IACTS. It's with great sorrow I have to face today talking about Sundar. I know him as a friend, as a surgeon, and an academician, and a member of the executive committee. As everybody has mentioned about all his qualities, one important thing I always remember, he never minced words about anything. What he felt, whether anybody likes or not, he always expressed. In any meetings he comes, whether it is executive committee or academic activities, or an opinion about any patient also, he always stands out and stick to. And he always had a reason to justify that. And he had a lot of patients. I also know a lot of patients whom he has operated, talking very high about him. And other than the academic circles, in his own personal circles, he is well regarded for all his personal activities and his contributions. At this time, my sincere condolences are with the family, and I hope and pray they come to terms with his loss, and God will give the strength to withstand this.
Thank you, sir. Dr. Shivraman is there on board? If not there, then I would.
Yes, sir.
Please go ahead, sir.
Okay. At the outset, I'd like to thank the IACTS for giving me an opportunity to speak in this condolence for Dr. Sundar Ramanathan. Actually, I was associated with him for the 41 years, till from his student days at the Coimbatore Medical College Hospital. He was very enthusiastic and always be taking part actively in all the CMV programs. And he is brilliant, and he is a gold medalist in surgery from CMCH outgoing batch. And following that, we all joined in the government service, and he left his government service and continued PG in Sree Chitra. And followed that, he joined in GKNM after finishing FRCS. On seeing his achievements, actually, he was an enthusiasm and behind my career as cardiothoracic surgeon. And I joined cardiothoracic surgery after that. And I am at present at Madras Medical College, Chennai. And actually, I am very sad on losing two of my cardiothoracic colleagues, Dr. Sundar Ramanathan and Dr. Chitra. Both have gone recently within a span of 3 months. And I deeply mourn. And my heartfelt condolences to Dr. Ponni and the 2 daughters. Thank you very much, sir.
Thank you. Once again, on behalf of the Indian Association of Cardiothoracic and Vascular Surgeons, heartfelt and deepest condolences to the family members. I request Mrs. Ponni Sundar Ramanathan and Dr. Darshana and Madhurya speak a few words. They are here on board with us today.
Good morning, everyone. My name is Darshana, and I am Dr. Sundar's first daughter. Thank you so much for arranging this meeting. I'm joined here with my mother, Dr. Ponni Sundar, and my younger sister, Madhurya. My grandparents, Dr. Ramanathan and Sivagami Ramanathan are also here. Losing Appa is, we all knew he was a great surgeon. We all knew he was a wonderful person. And losing him, even though we've been treating his condition for the past year, his loss is still extremely great for us. But we really appreciate and value the input that all of you have given. We know he was well renowned, but the fact that he's changed so many lives and made such a difference in his fraternity of cardiothoracic surgeons means a lot to us. So thank you for supporting him in his career. Thank you for holding this meeting, and thank you for all your regards.
Thank you. We'll just play a small video, which we have played it in the beginning. And after that, we'll be ending the meeting. Thank you, one and all. We pray that Sundar Ramanathan's soul rest in peace. Thank you. We'll be logging into the ICTS Technocollege CME. 9 o'clock session will begin now. I would like to thank the family members once again. Thank you.
Thank you, everybody, for joining in.
Good morning, everyone. I think we'll start with today's session. The first session is a session on pediatric aortic intervention. There are 3 speakers, and I believe all the 3 speakers do not need any introduction because they are well known both nationally and internationally. The speakers for the session are our President, Dr. Krishna S. Iyer, and the second speaker would be Professor Shunji Sano, and the third speaker will be Dr. Vijay Agarwal. And this session, the discussion for this session will be carried forward by our discussant, Dr. Chinnasamy Reddy. These few words will start the session. Thank you.
So, good morning, dear friends and colleagues. Today's topic for discussion is going to be aortic arch surgery in neonates and infants, surgical techniques. I know the program says surgery for coarctation and aortic arch hypoplasia, but I thought for the purpose of this meeting and especially for the younger colleagues, I would extend it to aortic arch surgery. And because it's a Technocon CME, the emphasis is going to be surgical techniques rather than basic theory. So to start with, I don't have any disclosures. My presentation outline is going to be as follows. I will start off with a brief description of techniques for isolated coarctation and coarctation with arch hypoplasia, but then go on to discuss further the midline repair of coarctation, especially those associated with intracardiac defects, and then go on to further discuss the surgical management of interrupted aortic arch, especially those with associated defects. Now, you're all familiar with classical isolated coarctation of the aorta, and we know classically it's described into 2 different subtypes. The preductal or the infantile type, which the pediatric cardiac surgeons would be more familiar with, which normally presents in the neonatal period and is a duct-dependent lesion and is usually associated with arch hypoplasia. So this is the infantile type of coarctation. And the second variety is the classical adult type or the juxtaductal type of coarctation, where the coarctation occurs opposite the ductus and usually related to the closure of the ductus. And this is usually discrete, and arch hypoplasia is not an associated factor in the majority of these cases. For the discrete type of coarctation, the treatment is relatively simple. You're all familiar with this. It's easily identified on echocardiography, where the aortic arch is normal, and then there is a sudden decrease in the diameter beyond the origin of the left subclavian. That's the aortic isthmus. And the treatment is a fairly simple resection and end-to-end anastomosis through a thoracotomy in a neonate or an infant. Some of the surgical techniques, especially for older patients, are still valid, although by and large, they are largely historical. And one is the interposition graft. This would be required, of course, in an older patient where it's difficult to mobilize the ends of the resected segment and so have to be replaced with a piece of graft. A patch angioplasty was originally quite popular, but has subsequently now been given away because of the high incidence of aneurysms around the patch. And an older technique, again, which is historical, is the Waldhausen subclavian flap technique, where the left subclavian artery was sacrificed, turned down, and used to enlarge the quark segment. When there is arch hypoplasia, as you can see here, then the aortic arch needs to be, in addition, widened apart from the resection of the coarctation. So when you have to do that, you could do that through thoracotomy, but the section of the arch has to be wide and the clamp has to be placed proximal to the origin of the first branch, that's the carotid. And so a portion of the ascending aorta and the origin of the innominate would be included in the clamp so that the incision can go all the way along the undersurface of the arch, and what is called an extended end-to-side anastomosis can be performed. As I said, that this is a view through the thoracotomy approach. It can be technically challenging because placement of that clamp distally can be quite a difficult problem. So the other alternative is to do it through the midline, where the access is better. The proximal portion of the aorta is more easily accessible. And here you could again do it without cardiopulmonary bypass, or more often it is done with the use of cardiopulmonary bypass and selective perfusion to the brain. Now, when there is an associated intracardiac defect, then the surgical options vary. Now, you could, if the intracardiac defect can be managed medically temporarily, then one could just repair the coarctation through a thoracotomy and then wait to do the intracardiac repair at a later date. If it's a large pulmonary blood flow situation, one could then temporize that by doing an additional PA banding in addition to the repair of the coarctation. However, if both require management at the same time, then one option is to do the two procedures through two separate incisions at the same time. That is, do the coarct repair first through a thoracotomy, turn the patient around, and then do a sternotomy and do the intracardiac repair. And lastly, which is a technique which is more popular now, is a single-stage, single-incision technique. That means you do the entire procedure through the midline. But most often this is done using deep hypothermic circulatory arrest or selective cerebral perfusion for repairing the coarctation and the arch hypoplasia. I'm going to describe a technique which we have published, which is essentially to do the coarctation and the arch part prior to the intracardiac repair without going on cardiopulmonary bypass. That means doing the first part on a beating heart and thereby saving both cardiopulmonary bypass time as well as the need for using deep hypothermia circulatory arrest or cerebral circulatory selective cerebral perfusion. So this is what we call the off-pump midline coarctation repair. And this basically is a single-stage, single-incision repair. And the thought is that whatever can be done through a thoracotomy can also be done through a sternotomy. So doing a repair through a thoracotomy without the use of cardiopulmonary bypass, you could do the same thing through the midline, and thereby avoiding circulatory arrest and selective cerebral perfusion. The advantage is that the patient lying supine, both lungs are ventilated, so even in a hemodynamically unstable patient, this can be done. And of course, since you already have the cardiopulmonary bypass circuit available on standby, then that adds a measure of safety. The important issue here is the assessment of the arch. And this diagram shows what all segments of the arch that one needs to look at and the measurements that we need to do. And we need to look at the three arch vessels, branch 1, branch 2, branch 3, and look at the diameter of the aorta at each of these levels. And of course, the length of the isthmus, that is the portion beyond the third branch and the coarctation. Now, what's important is for decision regarding the feasibility of a midline repair is this distance, that is the diameter of the aorta just beyond the first branch. So if this is adequate, and we say adequate, we generally use the formula of weight of body in kilograms plus 1. So if the unit is 3 kilograms, and this segment should be at least 4 millimeters in diameter, then it is possible to do a midline repair without use of cardiopulmonary bypass. So for example, here in this situation, there's a fairly significant hypoplasia of the distal arch in addition to the coarctation. But you can see that the diameter beyond the origin of the first branch is quite adequate. So when you have this sort of situation, this patient is quite suitable for a midline off-pump repair. The key surgical steps are a right radial or brachial artery cannulation through a mid-stenotomy. Then you do a mid-stenotomy, an extensive dissection of the arch vessels and descending aorta after division of the ductus. Aortic and right atrial purse strings sutures are placed, and cardiopulmonary bypass is kept on standby, but heparin is administered only after the coarct is repaired. You do the coarct repair first without cardiopulmonary bypass, followed by intracardiac repair on standard cardiopulmonary bypass. So here are videos showing the technique, an extensive dissection of the proximal aorta as well as its branches, followed by dissection of the descending aorta. This is after division of the ductus or the duct ligament. And you can see there, the descending thoracic aorta, taking care not to sacrifice the intercostal vessels, and the descending aorta can be dissected almost up to the mid-thoracic segment. After that, the clamps are placed both in the descending aorta and the proximal aorta, and the coarct segment is excised. You can see that's the distal stump after excision, and here is the coarct being excised proximally. You can see that the proximal aorta and the origin of the subclavian artery. And the suturing is started from the posterior wall. You can see that the two ends are quite clean. There's a wide anastomosis between the proximal and the distal segment, and that's the subclavian artery orifice, which is also preserved at the same time. And that's the end result, a nice wide anastomosis performed through the midline. The patient is still not on bypass, it's a beating heart and fairly stable. And now one can proceed to go on bypass and do the next stage. Now, instead of using a clamp proximally, which can slip and it also occupies space, one can also do what is called a purse string snugger. So precisely locate the area where you want to occlude the aorta and pass a superficial purse string all around the aorta, just going through the adventitia so that the purse string remains in place. One can then snug it and then proceed. So this is useful in situations where one wants to do extended arch repair. So here is a patient who has got a distal hypoplastic arch. So after doing that, we've snugged the aorta proximally using a snugger and distally using a clamp. We divide the aorta beyond the coarct segment, getting an adequate length for us to anastomose and having a clean cut edge. And then make an oblique incision under the arch so as to have a wide opening of the proximal segment, and thereby also opening up the arch. So the use of a purse string clamp saves space as well as allows a greater exposure of the transverse and the distal arch so as to enable an extended end-to-side anastomosis. Now, depending upon the level of narrowing and the level or extent of the anastomosis to be done, the clamps are placed in the following manner. So if it's a discrete coarct, then you just need to clamp between the carotid and the subclavian proximally, occlude the subclavian separately, and put a distal clamp, excise the segment, and do an anastomosis. If there's distal arch hypoplasia, then one needs to clamp between the carotid and the innominate, and then clamp the carotid and subclavian separately, and then one can do an extended end-to-side anastomosis, which involves the undersurface of the origin of the carotid. But if there is narrowing between the carotid and the innominate, then if there is enough space here beyond the clamp, one can extend the extended arch enterocyte anastomosis to the undersurface here. Or if that is not feasible, then another alternative technique is to clamp between the innominate and the carotid, clamp carotid and subclavian separately, perform an extended enterocyte anastomosis to the undersurface of the arch, and then further enlarge this portion by doing a side-to-side anastomosis of the carotid and the subclavian artery. This way, the entire arch can be enlarged and you get a final result like this. You can also do an augmentation of the arch by putting a patch. So the same way, one can clamp between the innominate and the carotid and enlarge this area with a patch of either pericardium or other material. So I'll go on to interrupted aortic arch. In interrupted aortic arch, a few important guidelines for a good surgical repair, what I will enumerate. As you will see subsequently, imaging is most important, and a diagnostic imaging so that one can plan the surgical procedure. Here's a 3D CT reconstruction for patient with an interrupted aortic arch. You can see here that's the ascending aorta giving rise to the innominate and the carotid. And the left subclavian is taking off from the distal segment. Here's a large pulmonary artery giving rise to a ductus arteriosus, which is then continuing as the descending aorta. So that is the level of interruption. So this is a type B interruption. So in patients with interrupted aortic arch, especially those with associated intracardiac defects, the preoperative imaging is very important. So they have a good anatomical diagnosis and a good base for planning a surgery. Therefore, a CT as well as a 3D reconstruction of the CT is a very important preoperative tool. One has to meticulously plan how you're going to cannulate and take the patient on cardiopulmonary bypass. The main aim is to try and avoid deep hypothermia, circulatory arrest. Of course, one would usually require a period of isolated cerebral perfusion, but the aim should be to try and minimize that period of isolated cerebral perfusion. And along with that, you would also minimize the period of lower body ischemia. And therefore, it's important that when you have an interrupted aortic arch as well as intracardiac defects, that the planning of the sequence of the repair is very important, because your movement of the clamps and the sequence of isolated cerebral perfusion and lower body ischemia is going to be important. So I'll show a couple of examples here to illustrate what I mean. So this first case is an interrupted aortic arch type A with an AP window and a ventricular septal defect. And this is the video showing the cannulation technique. Now, you can see here that this is a patient with the interruption of the aortic arch. I'm dissecting the aortic arch, and you can see that that's the level of the AP window. In many of these cases, it might be useful to suture a graft to the innominate, especially if the ascending aorta is narrow, so that this gives a secure site for proximal aortic flow. And usually in these cases, it's a good idea to do a 2 cannulae perfusion, one cannula perfusing the innominate and the upper body, and the other cannula perfusing the lower body through the ductus arteriosus. So here we have cannulated the ductus arteriosus, and after giving cardioplegia, the branch pulmonary arteries are snugged before the cardioplegia. One has opened the AP window, and the first step is a repair of the AP window using a sandwich patch technique. So after the AP window has been repaired, then now we can proceed with the repair of the interrupted arch. So at this stage, one resorts to distal body ischemia. So the distal cannula is removed, a clamp placed on the descending aorta, and the ductal tissue is excised widely so that you have clean aortic margins devoid of ductal tissue. And now the innominate is clamped at its origin, so that now you've got isolated cerebral perfusion. The carotid and subclavian are snugged. The aorta is cross-clamped and cardioplegia has already continued. And you open the undersurface of the distal ascending aorta into the carotid. It's important that this incision is placed on the posteromedial aspect, so that when the anastomosis is done, it lies in alignment and it does not twist. If this incision is made in the anterior wall or even the lateral wall, then because the descending aorta is lying somewhat inferiorly in a posterior direction, then likely to be a kink of the anastomosis. So it's important that that anastomosis lies well. So now the clamp is released after the anastomosis. You can see that the anastomosis is lying well. The vessels are filling well. And subsequent to that, the third step is the closure of the ventricular septal defect. So the cardioplegia continues, the VSD is closed. After that, the clamp is removed and the surgical procedure is performed. Now you see the advantage of having the innominate artery cannulation done through a graft. It keeps the field quite free and uncluttered, and one can do the entire surgical procedure without too much difficulty. So the next example is going to be one of interrupted aortic arch type B with a truncus arteriosus. Now here, as you can see the anatomy, there is a common trunk, large one arising from the base of the heart. That is the ascending aorta, and this is the common pulmonary trunk, giving rise to the ductus and descending aorta. Again here, I'll show you another way of cannulating the two cannulae, one in the ascending aorta just close to the innominate and one in the PDA. And after giving cardioplegia, the aorta is transected completely, the truncus actually. And then the proximal stump is shortened because it's a very wide proximal stump. So it's obliquely closed. And at this stage, we do a Lecomte maneuver. So the ascending aorta is brought down and the aorta is reconstructed. Now, I will go back a bit and to show how after that stage, the innominate artery cannula is slid into the innominate and snugged. So once that is done, then we can open the ascending aorta and perform an anastomosis of the ascending aorta to the descending aorta. And you can see this repair of the interrupted aortic arch. After that, the truncus repair can continue. You can see the conduit. The advantage of the Lecomte maneuver here is that it allows for the ascending aorta to move backwards and reduces the tension on the suture line of the repair of the interrupted arch. And the conduit can lie nicely in front without the right pulmonary artery getting jailed or narrowed, because if the interrupted arch is repaired with the right pulmonary artery in situ, then very often leads to narrowing of the right pulmonary artery. So to conclude, a thoracotomy approach is adequate for most cases of discrete coarctation and distal arch hyperplasia. A midline approach is better for proximal arch hyperplasia. And when you go through the midline, repair is feasible without use of cardiopulmonary bypass in most cases. But it's important that the surgery is planned very carefully preoperatively, especially when complex arch repairs for interrupted aortic arch are done, because sequencing of the repair and the conduct of cardiopulmonary bypass is most essential to have a favorable outcome. Thank you very much. Questions are welcome.
So this is Dr. C. Reddy here. Thank you for your excellent presentation, Dr. K.S. It was very informative, and you have emphasized on various techniques, and the videos were really excellent. And I think we'll take the questions after the session. That's what I've been told by the admin. Is that okay, Sree?
Yeah. We have the discussion session right in the end of the whole thing. So we can have all discussions at that point.
Yeah. So then we will move on to the second talk by Dr. Sano. It's about Wazaki procedure in pediatric, monocuspid and bicuspid stenotic aortic valves. So we'll call upon Dr. Sanu to go ahead with his presentation.
Dr. Shabri, we are not able to hear.
Yeah, we'll just get back to you. There's some technical thing. I'll just get back to you. What is the audio? Okay, then I will ask Dr. Sree. There's some problem with the audio.
Oh, can I speak?
Yeah. Please go ahead, Professor Sano.
Yeah. Good morning. Thank you for inviting me to annual meeting of Indian Association for Cardiovascular and Thoracic Surgeons. It is a great honor for me to participate in a Zoom conference. Can you move this one? Yeah, I have no disclosure. This is the anatomy of aortic valve. A normal aortic valve has 3 cusps, and the anatomy of aortic valve is simpler than the mitral valve. Aortic stenosis is mostly either congenital or rheumatic, and aortic regurgitation is either the congenital or acquired, such as infective endocarditis, aortic prolapse associated with VSD, rheumatic, and regenerative. There are many surgical options in aortic valve disease. However, options are limited in children. Today, I focus on relatively new technique, so-called Ozaki procedure. Dr. Ozaki started this new procedure using patient own pericardium to treat aortic valve diseases since 2007. He published his first report of 88 patients in 2011 at Interactive Cardiovascular and Thoracic Surgery. Dr. Ozaki's second report was at Circulation Journal in 2015. This procedure became popular in Japan, and we have established a Japanese database of Ozaki procedure, and I became our first chairman of database committee. As a committee, in addition to collective data, I talked to Dr. Ozaki how to popularize this technique and extend indication to children. So we have created a special Ozaki instrument set and added 13, 15, and 17 millimeter sizer and template in a pediatric instrument set. These 3 size is not included in adult template. So his third report was published at JTCVS in 2018. There were 850 patients, and more complex congenital aortic valve anomalies were included in this report. As Dr. Ozaki is an adult cardiac surgeon, most of his series were adult, and mean age at Ozaki procedure was 68 years. In isolated Ozaki cases, the mean aortic cross-clamp time was 107 minutes, and the mean cardiopulmonary bypass time was 150 minutes. 15 patients required the operation, and mostly due to infective endocarditis. Mean follow-up of 54 months, and the freedom from reoperation in 8 years was 96%. And the freedom from recurrence of moderate mitral moderate aortic regurgitation in 8 years was 93%. Echocardiographic evaluation of peak pressure gradient after Ozaki at 1 week was 20 millimeter mercury, which declined to 50 millimeter mercury at 8 years. Advantages of Ozaki procedure is maintain single valve disease, applicable to any valve anatomy, reproducible because of the size and template, and growth potential of aortic annulus, and deep coaptation surface. Ozaki procedure preserves a natural movement of aortic annulus, and this may lead to less stress to the aortic cusps and less calcification on the cusps. In aortic valve replacement, annular movement is completely lost. Ozaki is not normal, but it's a near normal movement. One of the most important pitfalls is accurate sizing of each cusp. Sizing each cusp and the creation of equal sized 3 cusps is not easy, especially in bicuspid and unicuspid valve. These complex congenital aortic valve diseases are more advanced cases, and special techniques are required. In pediatric, the actual operation in especially like tricuspid valve, a cusp, the similar technique used is congenital in the pediatric cases. In the pediatric instrument set, however, the 13, 15, and 70 millimeter sizer and template are added. The Boston Children's Hospital invited Dr. Ozaki and learned how to do Ozaki procedure in 2014. And since 2015, they have an Ozaki experience in 90 patients, and 57 patients are through Ozaki procedure, and 33 are single or double leaflet reconstructions. There is one patient less than 1 year, and the patient was a truncus arteriosus with severe truncal valve regurgitation. Valve anatomy was unicuspid in 16, bicuspid 35, tricuspid 46, and the quadricusp in 3. Other than congenital aortic valve disease, 4 patients are truncus arteriosus, 5 endocarditis, 2 rheumatic, and 4 connective tissue, and 5 TGA after the arterial switch operation. Leaflet size was from 13 to 29. Mean cardiopulmonary bypass time was 155 minutes, The mean cross-clamp time was 129 minutes in an isolated Ozaki procedure group. Although the maximum follow-up time was 3 years, the result in pediatric cases are encouraging. According to recent personal communication, the cases using photofix or cardiocell patch have been increasing reoperation after 2 years. We now focus on complex congenital aortic diseases. There are a trick and pitfall in the monocuspid, bicuspid, and the quadricuspid aortic valves. Until 2012, the native cusp attachment line and the Laffey were retained and used due to their increased tolerance for stress. This configuration resulted in a major discrepancy of cusp sizes. Due to this size discrepancy of the cusps, the motions of each cusp was different, and the stress was distributed unevenly among the cusps. It is clear that post-operative infective endocarditis occurred more in patients with bicuspid and unicuspid compared to tricuspid, and all the infective endocarditis occurred until 2012 cases. So therefore, since December 2012, they changed their technique and tried to create equal-sized 3 cusps, whatever the anatomy is. In most of the cases, native commissure exists between non-coronary cusp and the left coronary cusp. When complete tricuspidization, a cusp reconstructed, another pitfall is to adjust the cusp height to the native commissure. Several technical modifications are required to a patient with unicuspid and bicuspid aortic valves. These include individualized sizing and creation of equal-sized cusps, accurate creation of commissure height based on native commissure and the location of coronary arteries, and the neo-commissure reinforcement to optimize coaptation, because the 2 cusps and commissure is not the native. I will show you a short video of Ozaki procedure. The 19-year-old female, severe aortic stenosis, unicuspid aortic valve, and the mean pressure gradient was 52 millimeter mercury. This is the preoperative echo, the unicuspid valve, and the gradient was 52. Here the aortic valve, the left-hand side, there is a native commissure, and the right-hand side is not like a true commissure, and like a Lafayette. So we check the coronaries and they put on the sizing after cusps are excised, and the suture was placed to native commissure between the left coronary cusp and non-coronary cusp, and measure the cusp size, and we found that the 23, 23, and 25 millimeter size cusp is a fit. And the marking to the middle of each cusp and new commissures. And the cusp was treated with glutaraldehyde for 5 minutes in children and suture smooth surface in an LV outflow tract site. The left coronary cusp was first sutured, and then right coronary cusp, and then the non-coronary cusp. All three cusps suture is very much similar. So it's not difficult when you are accustomed to do it. It's starting from the bottom and the sutures coming up, and then the first 3 or 4 sutures 3 to 1. There is like a marking spot in template, so you can mark where you should put a stitch. So now 3 cusps were sutured, and then we do the reinforcement of the commissure, or three commissures. Put the stitches and pass and through the outside of the aortic wall, and fix with the pressure. As I told you, the important thing is to keep the commissure height, 3 commissure height, equal. Or the same level. Here the reinforcement stitch is passed from the cusp wing to the outside of the aortic wall, and reinforced with a pressure. Now the check the nail cusp, and we think the shape is like a Mercedes-Benz figure is okay. So the post-operative transesophageal echo showed the trivial aortic regurgitation and a mild aortic stenosis with a gradient of 15 to 20 millimeter mercury. And the post-operative course was uneventful, and the patient discharged home with aspirin and post-operative transthoracic echo at 6 weeks demonstrated no aortic regurgitation and mild aortic stenosis with a mean gradient of 9 millimeter mercury. We have performed 5 Ozaki procedure to unicuspid, bicuspid, and quadricuspid aortic valve since 2019. The mean aortic cross-clamp time was 149 minutes, and the mean cardiopulmonary bypass time was 178 minutes. And the patient number 2 had a different sized cusp due to a coronary position and an IE. One patient required reoperation and 15 months after initial repair due to a left coronary cusp tear, and the left coronary cusp was only replaced to a new autologous pericardium. So take-home message, the Ozaki procedure has an excellent mid-long-term result in adult population. Professor Ozaki did 1,100 cases during 12 years, and the freedom from the operation in 12 years was 96%. And he did 20 pediatric patients in 9 years, and there is no reoperation. But all 20 patients is the teenage. And the Boston Children's Hospital experience of 57 patients using autologous pericardium or Photofix. 96% of patients had less than moderate aortic regurgitation in 2 years, and the less reoperation in autologous pericardial patch cases. And I think the advantages of this procedure is annular growth and less reoperation compared to other procedures, and no need of anticoagulation.
Dr. Seno, thank you for your excellent presentation.
Yeah,
we enjoyed your presentation. We had a very illustrious presentation. We do have, we do have done about 30 odd pediatric Ozaki procedures. I always used to say, I think Ozaki pediatric is actually a boon because they're small aortic root. There are not many options are left with them. So I think Ozaki makes a lot of difference in pediatric population. And the questions I think we'll take at the end of the session. And then we'll move on to the next speaker, Dr. Vijay Agarwal. His talk on aortic root translocation, the surgical tips and tricks.
Good morning, everybody. Today's topic is aortic root translocation, surgical consideration and pitfalls. I'm not going to go into the details of long-term literature review, etc. I'll stick to the surgical consideration and pitfall. Before I start, I want to thank the Technocollege ICTS for giving me this opportunity to speak on this platform. So thank you so much for that. There are very few slides. What is the indication for either an aortic root translocation or an aortic root and a pulmonary root translocation? Just to summarize, you can actually operate patients of TGA VSD PS or DORB VSD PS or CCTGA VSD PS, where the other modalities are either not possible. For example, a REV or a Rastelli is not possible or not desirable, then we can use it as one of the alternative operations where we can offer a root translocation. Otherwise, the only option left would be a single ventricle repair. The advantage is that of the root translocation is that it works even if the RV is slightly hypoplastic. The inlet in an inlet VSD or distant VSD where routing is not possible by the other modalities, or there is some degree of straddling which can preclude a Rastelli or a REV. Again, very nicely put by his Camp et al. The theoretical advantages of the Kaido procedure is that there is no volume reduction of the RM. as in, for example, like a baffle, which may be required in Rastelli, which can cause volume reduction. And there is no right ventriculotomy in root translocation. And it leads to the placement of a very orthotopic placement of the RB to PA conduit. And obviously it can be done for inlet or distant muscular VSD. This is a very important slide which demonstrates that the alignment of the LV and the aorta after the root translocation vis-a-vis the Rastelli, for example. Look at the pathway which goes like this and then comes here in a Rastelli, and the pathway is relatively straight in root translocation. Therefore, the hemodynamics is proposed to be more efficient, and that has been shown to have better long-term results. Again, the same fact is being demonstrated on a post-operative echo. This is also an important surgical consideration as to what is the size of the pulmonary annulus. If the pulmonary annulus is very small, then you are getting only a very theoretical advantage of doing a root translocation. You get a good advantage in doing in these kind of subsets. That is one. Two is, if the pulmonary annulus is big, then the translocation distance actually increases, and therefore the chances of coronary getting stretched is more. So whenever we are planning a case of root translocation, this diagram can be drawn before, just to give us an idea as to what kind of challenges we might come across. A double root translocation is just an extension of the aortic root translocation. It avoids RB to PA conduit or a transdermal patch, where the patient's own pulmonary valve is harvested, where the annulus is probably not very hypoplastic, and the valve cusp is usable, not very dysplastic or fibrosed. The advantage obviously is that there is growth potential. The other consideration which we are going to see in the ensuing video is about the coronary anatomy. It should not be crossing the RVOT. Some looping patterns can be contraindications for root translocation. But some degree of straddling is not a contraindication, and the most preferred great artery relationship, if it is your first couple of cases, it should ideally be anterior-posterior relationship. But other positions can be tackled as well, as we have demonstrated in one of our published articles. So how to tackle if there is any variation in the great artery relationship, for example, in L transposed aorta. I've already laid down the advantages of this procedure. Technical details, which we'll see in the video and discuss, is whether to harvest the coronary or to mobilize the coronary when we do a root translocation. How to prevent mitral valve injury, which is not been really highlighted in other literature. Rootability is obviously not a contraindication. And aortic regurgitation, and how could we prevent aortic regurgitation? Obviously, this case of root translocation can be quite daunting. And one of the terrible complications could be a coronary ischemia, bleeding. Others are aortic regurgitation, mitral regurgitation. One should have a backup of a mechanical circulatory support if there is no cardiac. In conclusion, it's a good alternative wherein VSD cannot be rooted or is undesirable because of the long baffle. But the fact remains that Rastelli and REV remain an alternative gold standard options. So this is a video of aortic root translocation alone, single root. It demonstrates a couple of points. Obviously, I've just frozen the video because the aortic cannulation is high aortic cannulation, bicaval cannulation, cardioplegia, and cooling it down to 28 degrees routine. One of the important things is to open the right atrium first and assess, as in this case, you can see that this is the VSD. And here you can actually assess about the rootability of the VSD, whether root translocation is feasible or not, and to basically look for any straddling which can preclude root translocation. After that, one can go ahead with transection of the aorta above the sinotubular junction to maintain the integrity of the aortic root, as it is being shown here. Disrupting the aortic ST junction can lead to a higher incidence of aortic regurgitation. Note in this case how the coronary button is harvested. In our initial phase, we had actually harvested both the coronary button. Now we have moved on to just harvesting one of the coronary button and leaving the other coronary button intact. In this particular case, also demonstrate that one of the coronal branches can be ligated. The LED in this particular situation is very, very close, and we were able to tease it off. A ventriculotomy is done about 10 to 15 millimeter from the aortic root, and a complete root harvesting is done, as in this case. Here, the coronal septum is being cut so that the aortic root can be translocated posteriorly. You can see the coronal septum being cut. The aortic root is sized with a Hagar, and a Hagar is put into the VSD so as to assess the width of the VSD patch. Bovine pericardium is used to close the VSD. Here, the aortic root is translocated posteriorly and stitched to the pulmonary annulus using a fibroprolene, and the anterior cuff is hitched onto the VSD. Important consideration is that the height of this VSD should be at the same level as the height of the ventriculotomy, and the coronaries are reimplanted again. The RVOT is closed with a bovine pericardial patch, and the aortic cross clamp is released. Once we are happy with the initial bit of hemostasis on a beating heart, an incision is made on the bovine pericardial patch, which was used to close the RVOT, and a contigra is implanted. The second video is demonstrates another viewpoint. It's again an aortic root translocation, and there's a small coronal branch arising from the separate ostia. You can see here. Again, here this was one of our initial cases, so we harvested both the coronaries. Again, the right ventriculotomy, same principle. Here we wanted to demonstrate that the aortic root which was harvested, we started stitching the aortic root onto the posterior pulmonary annulus, and later realized that the coronaries were not sitting onto the site. So we had to actually undo the posterior stitch again and re-rotate the aortic root. So it is not always necessary to rotate the aortic root complex 180. Here we are undoing it, and we actually then rotated it and then put it to the reverse position and stitched it. And this time the coronary were coming onto the slot properly. Here you can see now it is coming onto the slot. So this case was there to demonstrate that this could be a pitfall. One should not go with a fixed mindset that I will rotate the aortic root after complete harvesting. Of course, we now try to do our root translocations without completely mobilizing the aortic root, with only partially mobilizing the aortic root, almost 2/3. So this case demonstrates an important point that after completely mobilizing the aortic root, one can actually put the aortic root, place it there, and see for yourself where the coronary is going to land. Sometimes the coronary may not land in the button defect, and one can close that button defect, as in this case here, and implant it onto a better site to avoid any coronary ischemia. The third video demonstrates another point where you can just see here that here the aorta is to the left of the pulmonary artery. So the relationship of the great arteries is different here and not exactly anteroposterior. In this particular situation, the aortic root here will move from here to here. So what we propose here is that the right coronary arteries will not get stretched because the aortic tract is going to travel to a longer distance from here to here. Of course, in this case, we had harvested both the coronary arteries, as you can see. Routine transaction, as I said, are slightly above the ST junction. Here we harvested both. But if we get a similar kind of a case now, we will not harvest both the coronary. We prefer to harvest the left. If it's a normal anteroposterior relationship, we prefer to harvest the right coronary rather than the left, because left is more difficult to get access if there is bleeding in that area. So this is another surgical variation, and one has to be very careful with this as well. Note that the RVOT is closed with the white pericardial patch. This is basically for the sake of convenience, wherein you can do the whole route and unclamp and then see if there is any bleeding. Had there been a conduit, RV to P conduit, bleeding would be more difficult to see, and therefore we do the step of RV to P conduit after we remove the cross clamp. Now we move on to the last slide of the single root translocation. Just to impress that again, any anatomical deviation, one should not write it off. This is a case of juxtaposed atrial appendages on the left side, and the coronary from the left side of the RC is crossing the RVOT, but not really hugging the whole annulus. If it's hugging, then it becomes a contraindication. One cannot take. IVC is in the midline. So we were able to dissect away the coronary away from the annulus. Also in this particular case, probably this is the only case where we closed the VHD directly using the anterior cuff of the aortic root. And we obviously harvested only the right coronary artery. So the operation was a bit simplified because of that, but was made difficult because of the right coronary artery crossing partly onto the RVOT. So you see a very shallow VSD, which was closed directly using the anterior cuff of the. So if you have any dextroposition or dextrocardia, but if the anatomy otherwise is suitable for a root translocation, then it is feasible to do a root translocation. One has to be careful of the coronary crossing in an abnormal manner in these kind of situations, but they can be managed. The absolute contraindication in my mind is looping of the coronaries, both hugging the aortic root anteriorly and posteriorly. We go on to the last 3 slides, which shows a double root translocation, which is just an extension of the aortic root translocation. And we harvest the pulmonary annulus as well, because the pulmonary annulus is not terribly hypoplastic and can be used. The advantage obviously is low potential. Even in double root translocation, we have doing only right coronary artery harvesting, button harvesting. The alternative technique is to mobilize the right coronary artery, which a lot of surgeons do it successfully. The problem with, according to me, with mobilizing the right coronary or the left coronary and not harvesting is, if there is a lot of displacement of the aortic root posteriorly or to the left or to the right, there is a higher chances of the coronary getting stretched and therefore higher chances of coronary ischemia. So instead of taking that chance, we explant the coronary button and then we reimplant it at a more convenient, comfortable position, which does not lead to stretching. We have started mobilizing the root only partially. As you can see, the root is 2/3 or more than 2/3 harvested, but we leave the left coronary button as along with the myocardium intact. This also demonstrates how close the mitral valve is, and one needs to be very careful when harvesting the pulmonary root. So here the aortic root is getting, pulmonary root is being harvested. Look at the mitral. If your sutures are taken in a heavy, in a deep manner, you might actually damage the mitral valve. In fact, this particular case actually came out with mild MR, And then in the post-op, 1 year down the line, he had moderate MR. So we have been very careful with the mitral valve, very careful with how close we are to the mitral valve. We'd rather go beyond to the pulmonary valve and sacrifice a bit of the posterior annulus, the pulmonary valve, rather than going right in between the pulmonary and the mitral valve. So this is a very important point one must keep in mind. And then this pulmonary valve, usually they are hypoplastic and need some kind of enlargement. But most of the pulmonary valve apparatus is, again, the principle is the same, and we usually use some kind of augmentation of this pulmonary annulus to make the valve fully competent. It's a very short video which basically demonstrates a very important point where the pulmonary annulus, we have sacrificed almost the posterior annulus as we did not want to enter the mitral complex, which is hugging the posterior pulmonary annulus. And therefore, in my mind, I feel that one should do a double root translocation becomes more safe if there is a coronal tissue in between the mitral and the pulmonary valve. So mostly in a DORV situation where there is a double conus. Now focus here wherein we are harvesting the posterior part of the pulmonary valve, where we are trying to be a little away from the mitral and maybe sacrificing a little bit of the pulmonary valve. This is the leaflet, and here you can see the VSD. This is a part of the aortic root complex, partially rotated, and you can see that the mitral is quite far, and we do not have mitral valve problems after that one of the cases. So the rest of the operation is carried out in a very similar fashion, and without using a conduit, and therefore has better root potential. The last patient is an interesting case. It had a very big VSD, but most importantly, we wanted to demonstrate in this case how to deal with straddling of the tricuspid valve. You can see that the tricuspid valve is straddling and is going on to the left side here. And here you can see that we are detaching the muscle, capillary muscle, along with the chordae, and we re-implant it onto the right side and then close the very big VSD. This is where we are re-implanting or more towards so that the VSD can be closed after sorting out the straddling. So obviously one of the advantages of this procedure is you can handle straddling, which you cannot with the Rastelli and other procedures available. The procedure in this operation went on long, but we didn't have problems coming off bypass, but we were able to extubate on day 2, and then he had an increase in the CEP and was having pleural effusion and distress. He was reintubated, sepsis. Echo showed severe TR and flailed body. And once the sepsis settled, we took him back. Can't remember exactly how long after the first operation, definitely 2 weeks later or more. And we found that this the tricuspid valve muscle, which was relocated, had come off. And we re-secured it properly this time. And a couple of days later, we were able to get him off the ventilator and send him home uneventfully. Apart from the straddling, and this was a complication in this case and quite a learning point for us. So thank you for your time. In summary, single or double root translocation is feasible in a TGA, DORV, VSD, PS situation or CCTGA, VSD, PS situation, where the other modalities are not possible or desirable. It is an operation which can take long and needs meticulous surgical consideration and planning, keeping in mind the kind of VSD, coronary anatomy, relationship of the great vessels to each other, straddling, and obviously bleeding can be one of the complications, and it could be a long operation, and therefore it is preferable that one has a backup of to tackle low cardiac output. Thank you so much for your time.
So thank you, Dr. Dr. Vijay. That has been a nice presentation. So I think we will move on to taking questions. I'll call upon all the three speakers, and then we have some questions. I have a question for Dr. K.S. Iyer. So it's a talk about the neonatal repairs of coarctation in the intracardiac arch. You spoke about the selected cerebral perfusion. But do you monitor NIRS, near infrared spectroscopy for all these patients, or you just as a routine go ahead with selective cerebral perfusion? Number one. Number two, what is the flow and pressure you want in these patients with selective cerebral perfusion?
Thank you, Dr. Chinnaswamy. I think we're not able to switch on our videos. I don't know whether we can.
Yeah, there is some problem.
The control. So anyway, I hope I'm audible. So to answer your first question, no, we don't use NIRS routinely. Basically, it's a cost issue. And secondly, of course, the standardization of NIRS, even from the West, it's not very well standardized. So there is an issue with that. So we sort of assume that the circle of Willis circulation is adequate. And so we don't use NIRS. So that's to answer your first question. The flow rates, we generally maintain around 30 mils per kilo. That was what the, we follow the guidelines which were presented in the paper by Dr. Reddy et al. From Stanford. And so approximately 30 ml per kilo. And then, as we said, we always have a right radial artery or a right brachial arterial pressure monitoring line. So we maintain the sort of same perfusion pressure that we got when we were on full bypass. So, and if you have a perfusion pressure 35 to 40 on full bypass, till the perfusion is to sort of maintain that same level of perfusion pressure. So the flow is as a baseline 30 mils per kilo, but adjusted back and forth in order to maintain that perfusion pressure.
So there is a question by Dr. Prashant. It's about chance of injury to nerves, number one. Number two, the LeCompte in all types of truncus with IAA. Do you do LeCompte in all types of truncus with IAA repair?
Yeah, so injury to the nerves, basically, I guess the concern is the recurrent laryngeal nerve, and it's always identifiable as it takes off on the left lateral aspect, and when you're dissecting close to the pleura and the lateral aspect of the descending thoracic aorta, you're always able to identify the recurrent laryngeal nerve, which is looping around the duct ligament or the ductus arteriosus if it is patent. And it's quite easy to keep that under view and prevent any injury to it either by direct trauma or through cautery. So usually with careful dissection at that, it's quite possible to prevent any injury to the recurrent laryngeal. And the second question is the LeCompte. I think the LeCompte in a truncus with interrupted arch is always a necessity. Basically, because even in a routine truncus, there can be potential problems with narrowing of the right pulmonary artery, compression of the right pulmonary artery under the hugely dilated the truncal segment. So the ascending aorta after a truncus is always quite large, and the right pulmonary artery is prone to compression. So in an interrupted aortic arch, doing the LeCompte has both advantages. One, of course, it frees up the right pulmonary artery, and second, it reduces the distance between the ascending aorta and the descending aorta. So the strain on the anastomosis of the interruption, that becomes less. So it's a double advantage if you do the LeCompte in a situation of interrupted aortic arch with the truncus.
I have another question for you, sir. The question is neonatal coarct repairs are actually known to have a recoarced or restenosis. So do you have any experience in reoperating these patients?
Well, by and large, it's taken care of by the cardiologist. So recoarctations, it's very rare now for the surgeon having to intervene in a recoarctation. But if there is an associated arch hypoplasia which has not been dealt with, and the patient has come back with the recoarctation along with the arch hypoplasia, then that becomes a setting for resurgery. And in that setting, a midline approach is one which is preferred because A, you're going through a little virgin territory, and second, usually the issues with the arch hypoplasia, so it's better tackled through the midline rather than from the side.
Thank you, sir. There is a question for Dr. Sano. Why Dr. Ravi? Question is, what prevents the new leaflets from moving back in diastole? Number one. Number two, the message sent by Ravi, ready-made sizes for leaflet height available. That is question number two. There are many more. The first question is, what prevents the new leaflets from moving back in diastole?
I cannot understand what it means.
Yeah, what prevents the new leaflets from moving back in diastole? I mean, I think what Dr. Ravi means is that what prevents them from prolapsing or that would result in regurgitation?
After the Ozaki?
Yeah, that's it.
But the pitfall is to keep the commissural height at the same level. If the commissure new creating a commissure is different level, then the prolapse.
So the next question was next question. Ready-made sizer for leaflet height available. Is it available?
Yes, if you order the company and Neo AV, the company will sell you the surgical set. That is like a plastic instrument, not metal, true one.
Okay. There is another question.
That is included in the set, but the company doesn't supply the surgeon's unit without learning how to do it. So you need to have you need to learn from the instructor, either Ozaki or in the United States, and I'm one of the instructor. So you should learn 2 or 3 cases how to do it, and then the company will supply all the instrument.
So there is another question by Dr. Ravi. Anticoagulant use after Ozaki. That is number one. Number two, do you routinely transect the aorta for a better exposure? That is number two.
Number one is the anticoagulation is aspirin, the baby aspirin for 6 months, and then no need anymore. And then we have no thromboembolic episode. And I think also the Ozaki experienced, they use like a 6 months aspirin only, and then no thromboembolic episode. And to have a good view, you can have a good view without complete transection. As long as you have but if you need to have a good retractor, the aortic retractor. If the case is very small, and you need to have like a 15 or 17 millimeter cusp, it's better to have to cut completely, because the suture is not easy. The big one is much easier.
So 2 more questions by Dr. Ravi. Any cases where bulk leaflets causing difficult coronary perfusion? That's number one. Number two is the leaflet condition on reoperation after long duration of 5 years. Is the leaflets calcified?
I beg your
One is the
pardon.
coronary issue. The other one is
the coronary issue. I think they are from other from the like a Japanese database. The sometimes you have like a different sized the cusp, and then the small size cusp in the left coronary or right coronary that may obstruct. So that's why we create like an equal sized the cusp to prevent the coronary like obstruction. And the second one is calcification. In 12 years by an Ozaki experience, he had almost no calcification. That's very interesting because I think the annulus is moving like a naturally. So the stress is even, and that prevents like a calcification, the damage of the cusp.
Yeah.
From
I have a few questions. Number one, as you said, adult population is different from the pediatric population. What is your take on pediatric population with respect to the cusp mobility, with respect to reoperations, with respect to the small annulus and the valve gradients?
If they are because of the cusp is, if my understanding is true, the even if you have you use like a 70 millimeter cusp replaced, and then the patient is growing, but because of the cusp is the coaptation zone is very much more than the normal cusp, so that lasts longer. And I think from the Boston Children's the research, the 70 millimeter cusp lasts until three size up. So it's a 19, 21, 23. So if the patient become like a 23, and then that leaking from the center. But it's if the patient like a annual size is only 4 millimeter bigger or 5 millimeter bigger, then the original one can co-op. So no need of reoperation.
So in a redo, what patch do they like to use for Ozaki? In a redo, usually it may not get pericardium, autologous pericardium.
Yeah, I have only one reoperation, which is a tear, and I just changed the same size pericardium from the like a diaphragm side. The Ozaki also mostly replaced just one cusp where there is like an infected endocarditis, and then one cusp only is damaged. They only changed the one cusp. No need of a valve replacement.
Yeah, there are a few questions to Dr. K.S. Iyer by Dr. Shivakumar. The tips and tricks in interrupted aortic arch, if you cannot bring the distal descending aorta to ascending aorta as direct anastomosis.
Yeah, it's somewhat unusual for that to happen, because if you do extensive mobilization of the arch vessels, then usually in a neonatal infant, there is a fair amount of mobility available. But in a situation where it's still not possible, then it's one option is to transect the subclavian artery as distal as possible, turn it down, open out the subclavian, undersurface of the arch into the subclavian artery, and use that subclavian artery to get that additional length. And then, of course, you will have to augment the undersurface with a patch. So you get part natural tissue on the superior aspect, which is the turned down subclavian artery, and then use a patch for the remaining. So you maintain the curvature of the arch as well as get that additional length.
I have a question for you, sir. Now, did you have any chance of doing sliding autoplasty for this, aortic arch hypoplasia? Aortic arch
You're talking about
sliding
the
autoplasty. That is the ascending aorta is transected at the level of the first branch, ascending aorta, then make a cut on the, on the outer curvature and make a cut on the inner curvature and slide it over that. So
that was
did you
the
have
technique
any opportunity to do this?
Technique described by Texas children. So, yeah, I haven't done that technique. No.
So, and then two more questions are there for you, sir, by Dr. Shiv Kumar. Dr. Ayer's views on total body perfusion in IIA using ascending aorta and descending aorta. First question. Second question was views on total body perfusion. Same, I think this same question, repetition.
Yeah. So what was the question in that? I mean.
So the views on perfusion of upper body and lower body using two bicaval cannulation, bi-aortic cannulation.
Yeah. So as I showed, the ascending aorta cannulation, it can be by two techniques. One, you can, if the ascending aorta is of adequate size, then you directly cannulate at the base of the innominate. And at the time that you want to do isolated cerebral perfusion, you slide that cannula into the innominate and snug the innominate. And the second option is to suture a graft to the innominate, and then you can just clamp the proximal innominate. With the second technique, with the graft, you get a lot more working space around the region of the arch in order to be able to get better access to the arch. And the descending aortic cannulation is either through directly onto the ductus, if the ductus is sizable and the tissue is, and the patient is not on prostaglandin something, or you can cannulate the pulmonary artery close to the ductus and slide the cannula into the descending aorta. It's important that both the cannulae have to be the same size, so that then the perfusionist can just maintain the same perfusion pressure and you don't get unequal perfusion. If the cannulae are of different sizes, then you will run the risk of having more perfusion into the area which you're using the larger cannula.
So there is a question to Dr. Sano by Aditya. Dr. Aditya, this is about would you recommend a concomitant root enlargement procedure with Ozaki operation in cases of small aortic root? If yes, then how would you recommend the sizing of the leaflets for ideal root size following a Kuno-Restan?
I think the Boston children did like an enlargement of the ascending aorta and then do Ozaki. And Ozaki also himself changed like used the graft to ascending aorta and then did Ozaki. That I think the same. You can do enlarge the ascending aorta and do Ozaki, the same technique and same thing. You can apply this technique. And also I just done a comment to the cerebral perfusion because I have developed this technique in 1995. As the Dr. Iyer said, there's two options, either direct cannulation to ascending aorta and or graft. But I think the graft is much easier. As Dr. Iyer said, it's much easy to mobilize, and then you don't need to worry about the clamp. And also initially we use the NRS to all the patients to measure, but in most of the cases it's okay. It's same, especially coac or the interrupted aortic arch, because of the cerebral perfusion is only 15-20 minutes. And as long as you cool down a little bit, not the warm, it's protected. But you must be careful if you do like a node, because the cross clamp time and the arch reconstruction takes a little bit more time. And
so another question, sorry to interrupt you, sir. Another question is use of PTFE membranes for Ozaki procedure. Use of PTFE membrane, 0.1 thickness membrane for
PTFE?
Yeah, PTFE.
No. Never used.
So then there is a then there is a question to Dr. Vijay by Dr. Ganapati. Do you see any role of double root translocation in TJ-VSD-PS with pulmonary regurgitation, non-PS situation?
Ganpati, I've never come across this kind of a situation with TJ-VSD pulmonary regurgitation. I would imagine that the patient would have a good annulus in that case, in that situation. Obviously, if switch is obviously included in this scenario, and if your valve is hypoplastic, then it's more likely to be stenotic. But in an unusual circumstance where you have a hypoplastic annulus and it is regurgitant, then you can actually go ahead and do a double root translocation, but you need to make that valve competent by using monocusp or bicusp, or using the same cusp, which is a remnant cusp. I haven't come across the situation, but certainly it is a very interesting thought. Yeah.
Dr. Vijay, I have some few questions for you.
Yes.
Do you reserve this aortic root translocation only for the set of defined indications, or do you plan for as a routine procedure?
No, obviously, if I feel that in a TJ-VSD-PS situation, if my tunneling is going to be long, then I would rather go for a root translocation, because my philosophy is better to do things extracardiac than intracardiac. You are actually causing a straighter tunnel through a smaller VSD patch if you do a aortic root translocation, vis-a-vis if you do a Rastetti. So I would be a little biased towards a root translocation if I feel that the intraventricular tunnel is going to be very long. Because in a root translocation, I can actually achieve a more straighter tunnel and a smaller size of the patch. And it is mostly going to be an extracardiac effort. So you're going to make an extracardiac effort so in order to make room intracardiac.
No, don't you think in a case of rootable VSD and somewhat pulmonary annulus, something like G-score of -3, -4, pulmonary root translocation is a better option compared to the magnitude of the procedure of root translocation, the morbidity, mortality involved in this? Don't you think pulmonary root translocation, or for that matter, even the RAVE or Rastelli is a better option?
I agree with you. I mean, if you can do a REV or Rastelli, which with a rootable VSD, which does not have a long tunnel, I would prefer that option. Coming to the pulmonary root translocation, it definitely reduces the morbidity and the mortality and the magnitude of the procedure. But if you believe in the philosophy that you want a better hemodynamics of a straighter LV to aorta route, then that philosophy is not being satisfied with the pulmonary root translocation. You are just covering that area of pulmonary root with a pericardial patch. So you are not meeting that kind of an endpoint. But certainly, it's about a surgeon's individual philosophy. And definitely it's a good attractive option for video translocation. Dr. Chitra.
And I saw your videos. Most of the time you are detaching the coronaries.
Yeah.
Do you think actually in the series, in Victor Moral series, actually independent risk factor for development of AR is detachment of the coronaries?
Yeah.
Right?
Yeah.
So do you have any experience with intact coronary arteries or only with with the coronary arteries detached? And what is your incidence of AR compared to you have already seen the Victor Muller series, he has an incidence of aortic regurgitation.
Yeah, so that's a very interesting question actually. I don't mobilize the coronary arteries because whatever I have learned in the very beginning was from Christian Guizar, who always used to explant. And I kind of agree, and I've been through the literature. Whatever cases of coronary ischemia in the literature, either by Dr. Hu or Dr. Nikaido series or Victor Moral series, are where the cases where they had mobilized the coronaries and not explanted it. So the risk of stretching and the patients going on ECMO and mortality is much higher with that. So I always feel it is safer to explant the coronary artery.
Of course, you have a counter argument about it increasing the risk of aortic regurgitation. We have not had aortic regurgitation because I believe that that is not the only factor which contributes to aortic regurgitation. There are other factors like disrupting the sinotubular junction, how close you are to the annulus when you're taking the stitches, and so forth. So, of course, when you expand the coronary button as such, you are disrupting some bit of the thing, and that may contribute. But I don't believe that that is the only step which actually contributes to increase aortic regurgitation. What I am more worried about is the mitral, which has not been addressed in most of the series which are published, except one or two, because the pulmonary route is very, very close to the mitral valve. But aortic regurgitation incidents are usually very, very low in most of the series, actually. It is definitely highlighted as one of the problems of aortic, but we haven't come across that problem.
I think
neither of coronary ischemia.
Yeah. What makes the difference is, of course, no doubt, in Nicardo series itself, all a series is all intact coronaries with intact aortic root, posterior root translocation with intact coronaries. And you are virtually, say, grade 1 to 2 are in only 9 patients over a period of mean follow-up of 11 years or so. Yes. So in a series, absolutely no patient with moderate to severe aortic regurgitation compared to Marvel series. And I do accept with your this one, what actually increases the chance of developing AR is disrupting the sinotubular junction. That's what actually, I think your way of selectively mobilizing from the sinus itself, only button take it, that actually makes the difference. Yeah. My last question to you is, what is your long-term outcome or results number one, complications and reoperations in your series?
Yeah, so we've sent that for sent the articles for publication. So we have had one case of heart block. That was one of the initial cases of heart block. One case of mitral regurgitation, which we picked up at the immediate post-op. And in the follow-up, in 1 year, we found that to have moderate MR. And that is when we realized that we are actually very, very close to the mitral valve, and we started taking precautions. And I feel that, if there's a coronal tissue in between the pulmonary and the mitral, that is probably a better subset for doing a double route, especially where you're harvesting the pulmonary valve as well. So when there is no tissue in between, I think that increases the risk of mitral regurgitation, especially where in an older patient where the aortic annulus could be very bulky, and you're putting a bulky aortic annulus onto the pulmonary root annulus, which is very close to the mitral. In that kind of situation, I would rather kind of leave a bit of pulmonary annulus tissue there if I have to do one, rather than going close to the mitral valve. We never had any incidents of coronary ischemia or putting patients on mechanical circulatory support or so. I feel that if the displacement in aortic root is a lot, you have a real chance of causing the coronaries to get stretched and causing ischemia, which could be subclinical but may cause problems later on. So I think given the fact that yes, there is a concern that you harvest the coronary and you increase a little bit of chance of aortic regurgitation, but you are actually safe from coronary ischemia point of view, which is a very, very real risk. Also, one must remember that the relationship of the aorta and the pulmonary artery is not always anteroposterior. So your coronaries are not going to move posteriorly if the aorta is well transposed or any other position, in which case the aortic root has to move in left or right direction, and the coronary stands a very real chance of getting stretched and kinked. And therefore, I feel that mobilizing the coronary, obviously Victor Morrell and others have done it very well, but we feel safer with explanting the coronaries because it gives us more play.
So, Dr. Baiju, as any questions, Dr. Baiju and Dr. STR?
Good morning. First of all, I would like to thank all of you on behalf of Department of Cardiovascular Surgery in Sree Chitra for this excellent involvement and the excellent discussions. So just to take the discussion forward, my question will be to Dr. Vijay Agawa. Dr. Vijay, think that like you got a half-turn truncal switch where you can rotate it en bloc, and maybe you have the advantage of putting the coronaries in a more favorable position compared to a double root translocation. So what's the take on that? If you got a case which the pulmonary root is say around 35%, 40% of the aortic, which can be used, will you think of a half turn truncal switch, or will you still go for a double root translocation? And if you're not doing a half turn, what's the reason for that?
Okay, yeah. So I actually started with double root translocation, and I have heard and seen videos of half turn truncal switch. I feel it is a better operation, half turn truncal switch, although the operation are for the same diagnosis, TG, VSD, PS. But I was just doing double root translocation. I wanted to stick to that. But I felt that one of the advantages of a half turn truncal switch is that you don't disrupt the anatomy, the connection between the aortic root and the pulmonary root. You move it in block. Whereas in a double root, you harvest the aortic root separately, you harvest the pulmonary root separately. Therefore, you disrupt that connection in between. And that would probably influence probably long-term results. So I think that has an advantage. But I think of it, but because I am now becoming accustomed to the double root, I would rather stick to it. On the other hand, I feel that if you have an anatomical variation, the advantage of double root is probably much higher than half-turn truncal switch. For example, L transposed, if the aorta is L transposed, then I fail to imagine how you would be able to do a half-turn truncal switch in that situation. Probably a half-turn truncal switch would be ideal for anterior-posterior great relationship and probably superior. But if the aorta and the pulmonary annulus relationships are very different, I would be more comfortable to take out both the roots individually and place it according in a convenient position. So I think that is where the theoretical advantage of DRT would lie, although I would not have any first-hand experience of half-turn truncal switch. But I definitely feel it is in that respect, it is 1 point superior. Yeah.
Dr. Vijay, I think we were overshooting the time. And then I think I thank all the speakers, and Dr. Iyer, Dr. Sano, if they have any want to say anything, sir.
Well, I just want to say that it's wonderful to catch up with Dr. Shunji Sano. It's been many, many years, although it's on Zoom now. But for those who do not know, Dr. Sano and I worked together in Melbourne way back in 1989. So it's a very, very long association. And I'd like to thank him for his contributions to the Indian Association. He's been always very, very prompt whenever we have requested him to join in our deliberations. So it's wonderful to have him in our midst. So thank you very much, Shunji. And I hope you're doing well in California.
Yeah, thank you.
And far away from the fires at the moment, I think.
Yeah. We have a cold summer, only in Bay areas.
But rest of it,
summer will come in September.
A lot of forest fires there at the moment.
Yes, at the 100 kilos inland.
So I think I thank all the speakers for the excellent presentation and discussion. I think we'll close the session now. Thanks.
Thank you.
Thank you, everybody.
Dr.
Thank you.
And thank you to all the speakers and delegates. I think after 5 minutes break, we'll move to the next session.
Healthium, a leading global player in medical devices, creating access to precision medtech for every patient globally. Our passion for R&D, stringent quality control, and sharp focus on next-generation technology has resulted in 52 patents in India and the US, and enabled us to get US FDA, CE, and ISO approvals. We are the largest independent manufacturer of surgical suture needles in the world, the first in India to manufacture bioabsorbable implants and contribute to 50% of India's suture exports. Across the globe, surgeons use a Healthium product in 1 in 6 surgeries to ensure superior surgical outcomes. This is our legacy, born from passion, precision, and a quest to create medical devices that simplify usage for surgeons and benefit patients globally. In our quest for innovation, we have created products of superior design by combining our key understanding of the market with new generation technologies. Presenting the next generation endo cutter stapler from Healthium that combines precision articulation, single-handed operation, and versatility of using one handle for all types of cartridges. Healthium endo cutters create an optimal B-staple formation, even in varying tissue thicknesses, and ensure optimal hemostasis, support wound healing, and prevent necrosis by ensuring adequate perfusion to the edges of resected tissue. The strong titanium staples withstand pressure under situations of high tissue load. The sequential staple height cartridges ensure calibrated compression, low tissue stress during compression and clamping, and enhanced perfusion to staple line. Lateral tissue fluid diffusion during compression results in less force to fire. Healthium endo cutters offer optimal wound healing even in organs with variable tissue thicknesses. Healthium endo cutters use a unique technology that ensures optimal B-staple formation at the near, mid, and far end of the stapler, regardless of tissue thickness, and hence offers superior staple line integrity. The sturdy and ergonomic handle ensures single-handed operation, precise articulation on both sides, and a simple loading mechanism ensures a superior user experience. Healthium Next Generation cartridges come in 3 different types and 24 variants to address all tissue types and organs. Look for our ordering information. Guns in 3 sizes and straight and articulating reloads in different sizes. The result of precision and design excellence, Healthium's new generation linear cutters for superior surgical outcomes. Healthium linear cutters ensure optimal hemostasis, support wound healing, and prevent necrosis. Healthium linear cutters offer uniform staple compression, resulting in an optimal staple line with well-formed B staples, irrespective of tissue thickness and/or structural complexity of the organ. Healthium linear cutters fire with uniform firing force across the staple length, ensuring well-formed B staples. The floating cartridge and inbuilt mechanism prevent accidental firing. Healthium linear cutters offer easy and confident firing action with an ergonomic handle, secure grip, and an adjustable ambidextrous firing knob. Healthium linear cutters offer the highest 5 variants of stapler cartridges in blue and green to address tissue length and thickness. Look for our ordering information. Healthium's new range of next-generation endo cutters, linear cutters, and reloads are complemented by our circular and hemorrhoid staplers. Across 18,000 hospitals in India, these products bridge market need gaps and continue to make life easier for surgeons, assisting them to provide desired surgical outcomes. This is what we call precision with a purpose. Healthium.
Good morning, everybody. Welcome to the IACTS Technocollege 2021. At the outset, let me thank the organizers for giving me an opportunity to present this elegant topic, which is difficult coronary translocation. As you know, coronary translocation is part of a procedure in the treatment of TGA, Thoracic, Bing, and others. But I'll stick to the context of TGA alone in this presentation. As you know, unusual coronary patterns increases the technical complexity of the surgery and can lead to suboptimal outcomes in the unusual coronary patterns, especially with intramurals, as we'll see. Now, before we start, just a word on the embryology. You should remember that the coronaries don't grow out like the roots of a tree. Instead, coronaries develop on the surface of the myocardium and then grow in onto the aortic or the pulmonary sinuses, the facing sinuses. So we don't know the exact reason why the coronaries always home in onto the facing sinuses, but it's believed that the neural thrust cells which are involved in the septation of the aortopulmonary trunk sort of create a attractogenic field to which the coronaries home in. But the real reason why the coronaries home into the facing sinuses is still a mystery to be solved. Now, with this basic embryology in the background, few inferences can be made that, like coronaries take the shortest possible course, that coronaries never cross each other, and there's never a situation where three orifices arise from three sinuses, and 99% of coronaries arise always from the facing sinus, irrespective of the position of the great arteries. Now, classifications, we know that there are several classifications. Most of them are surgical, the Shahar and Padu, which is pathological, but they all use a combination of alphabets and alphanumerics to denote the coronary origins and their course. But when it comes to complex and unusual coronary patterns, it's possibly a good idea that you give a descriptive sentence about the coronary anatomy. Now, one thing that we're familiar with is the Leiden Convention, and you should know that the Leiden Convention has been modified in 2018. They've been updated to include all coronary patterns, even in adults, even with bicuspid aortic valves. So those interested can read up on this article in 2019, where there's a 3-step way to classify every coronary possible. Almost 99% of the coronaries can be classified by this method. Going on to the predictors of abnormal coronary origins in TGA, as we know, it's higher in VSDs. It's always higher in any position other than where the aorta is right and anterior. And whenever there's a commissural malalignment, there's a higher chance for unusual coronary patterns. That's fairly self-explanatory from the embryological aspect. Now, in evaluation, we know that echo is the mainstay of our diagnosis, but you should know, even in the adult side, the diagnostic angiography may be eventually replaced by CT with the advanced imaging protocols. This is a pilot study from Japan, where they have evaluated in neonates less than 2 weeks, and they have shown a good predictive value of the CT in diagnosing the coronary origins and their course. Now, coming to the exact mechanisms that cause problems in unusual coronary patterns, it's easy to remember. It's either a kink, a stretch of the coronary, or the formation of a slit ostia, or a combination of all these. So we'll come to this as we deal with each coronary pattern. Now, if you look at the whole spectrum of the unusual coronaries, the most common is the circumflex arising from the RCA, which is found in 15% of the cases. The next most complex variety is unusual variety is the looping coronaries. Now, the looping coronaries can arise either as a single coronary with anterior and posterior loops, or anomalous origins of either of the branches, like inverted coronaries or LAD from RCA. The next most complex variety is the intra-arterial coronaries, where it can be a single coronary without intramural component, or the intramural types with either dual ostia or single ostium, and the very rare coronary from the non-facing sinus. Now, this is increasing technical complexity as you go from above down. Now, coming to the general principles of coronary translocation, especially in difficult coronaries, the most important thing is to develop a 3D orientation of how your coronaries are going to be situated after you complete the switch. So this is best done just before going on bypass, when both your great vessels are full and you're able to decide on the level of transection and the site of implantation, and possibly visualize how your coronaries are going to move from the aorta to the neo aorta. So that's the most important part of the surgery, actually. And the second most important is, planning the site of implantation. Then when you come to the technical aspects, things like taking a large button, you can detach a commissure if it's juxtacommissural, mobilize the coronary loops longer. If you find a small branch or maybe even a reasonably sized branch on a conal branch which is hampering your transfer of the coronaries, you can divide it. Coming to the other principles is that implant a translocated coronary higher, use a trapdoor flap or a tissue or pericardial augmentation to lengthen the coronary button. You should split and de-roof intramurals. We'll come to this as we discuss these cases. Use of innovative flaps, and in the last resort, use of an atrial switch or a DKS plus VSD closure and an RV to PA conduit. Now, coming to the instrumentation, always remember to use low cautery settings like 6 to 8 fulgurate. Use a low crest factor which reduces the thermal injury of coronaries. Needle tip cauteries can be used for very fine mobilizations. It's not a good idea to leave a probe inside the coronary while dissecting the coronary. Rather, it's better to pass the probe intermittently or give cardioplegia intermittently to know the course of the coronary. And you can use these fine clamps that are available like baby mixture or Oshner's clamp, which can be used to skeletonize the coronaries. Now, coming to the most common variety, which is the circumflex from the right. This is usually not a troublemaker, but for a newbie, it can cause trouble if you don't know the basic principles. The most important thing is to release the circumflex around the pulmonary artery, and the second most is to implant it higher. We'll see that mechanism later. And the second important thing is to avoid LV distension after the clamp removal. This is almost a common pattern in almost all looping coronaries where immediate LV distension post clamp can stretch the coronary and compromise perfusion. Now, just looking at this diagram, that's the basic anatomy showing the circumflex from the right. And if you translocate it directly, what is going to happen is it's going to kink the circumflex and it's going to stretch the RCA. So the ways to relieve it is in one dimension is to use a medial trapdoor, whereby the angulation is improved and the kink on the circumflex is reduced. The coronary is a three-dimensional structure. So in the other dimension, what you need to do is you need to implant the coronary at a higher location. So when you implant it at a higher location, again, the angulation is reduced. So that's what happens when you implant it higher. If you don't release the pericardium reflection from the PA to the circumflex is going to kink at that point. So that's why we need to release the circumflex circumferentially around the PA. And coming to the next coronary pattern, which is single coronary with a looping course. Basically, a single coronary by definition is when a coronary arises from any one sinus with one or two ostia, maybe even three, doesn't matter. But the fact is it should arise from a single sinus. And the sinus 2 variety of single coronary is much more common than sinus 1. And the red flags in single coronary looping courses is that if you have a posterior looping course or a side-by-side great arteries, these are sort of more dangerous than the regular ones. So as expected, the thing is posterior loops will kink and anterior loops will stretch over the PA. The basic way to remedy it is to mobilize the loops extensively, and especially in posterior loops, implant it at a higher location. So usually in single coronaries, when the coronary ostia is situated right in the center of the sinus, the distance to translocate is much less, and it's usually it's almost like a regular coronary to do. In fact, sometimes when we see a single coronary, we are happy because we have only one anastomose to do. But the real problem arises when the coronary is situated far away and it's situated juxtacommissural. So that's when it becomes difficult. That's when you need to use some flaps, more mobilization, and this is one of the techniques that's been described to make a tube out of the sinus walls. And not a good idea to use pericardium to create a tube. So preferably use native PA or aortic wall to create the flap so that the growth is continued. And this is another form of single coronary with interarterial course. So this should be considered. It's not similar to the looping pattern. So it should be considered like intramural coronary arteries, and this may need treatment just like intramural coronary arteries. Now, this is a long-term follow-up of patients who had a single coronary artery. Is from France, and they've shown that single coronary per se, the ones with the looping pattern, are not increased risk for mortality in the long run. So coming to the next level of complexity, it is the inverted coronaries. And by looking at it, it's a marriage of total inconvenience. This occurs when the right arises from sinus 1 and the left from sinus 2 without LAD. So the thing is that you have both an anterior and a posterior loop, and this leads to the right one stretching and the left one kinking. So by now you know how it is to be dealt with: more mobilization and higher implantation. And coming to the last one, which is the intramural variety. The intramural is definitely the most challenging. It's still associated with higher mortality, both immediate and long term. And in the case of intramurals, misfortunes, they come in a battalion, as we say. So it's usually associated with single coronary. It's juxtacommissural. Usually the LMCA or the LAD is the intramural component. The only saving grace is that most of them don't have VSD. And the general characteristics of intramural is that most of them, they arise from the wrong facing sinus. They cross the commissure, and whenever it's from its own sinus, it's intramural because it's arising high up. So that's when you need to be careful about your division of the aorta. And they are intraarterial. They usually have 2 ostia, and the single ostium is usually very rare, non-splittable variety. And one very important thing to remember is that they almost always have a normal epicardial course, so external inspection is not a good confirmatory method. So as we said, the left main as intramural is the most common, followed by LAD as the intramural component, and almost equal of both RCA and both left and right being intramural. So coming to the general principles of management of intramural is to transect the aorta safely. It's always better that you transect the anterior part and then visualize the coronary and then complete the transection. Detach the commissure, don't worry about the pulmonary regurgitation. In most cases, you can split the ostia. Deroofing is the most critical component of the intramural segment. Wedge-shaped portion should be removed because it's almost always stenosed. And you should take care not to exit the intramural component because it'll open up the coronary completely. And beware of stenosis at the exit point. So that's, if it is there, you will have to deal it with a patch. And remember that improper translocation can create an angulation at the exit point. I'll explain that. So the intramural component is sort of fixed on the button and the rest of the coronary is freed. So if you place it lower down, it's going to cause an angulation at that point. So it's important to place it higher up. Now this is a picture showing a splittable intramural coronary with the LAD and the RCX button. And the green line shows the course of the LAD, which is interarterial. And the blue line, dotted line, shows the course of the circumflex, which is going behind the pulmonary artery. And the way to deal with this is, of course, to split the coronaries. The LAD is split and it's deroofed, and the LAD is augmented with a pericardial patch and reattached. So the next variety, or the worst of the intramurals, is the non-splittable one. Now this is a typical picture of a high single origin with intramural LMCA and the right coming off. And the only way to deal with it, there are two ways to deal with it actually. The one is a single button relocation. So I've just shown this picture so that it's not done anymore, because all series have shown a higher incidence of coronary events with this sort of translocation. So it's better to avoid this technique. And even if you have to do it, make sure that it's better to do a conduit so that the conduit doesn't press on the reconstructed coronaries. Now, the way to deal with this is to use some flap techniques. The original technique was described by Aubert in 1971, wherein he created an aortopulmonary window and it was patched using a pericardium. But the problem with this was that it led to stenosis of the patch and the long-term coronary issues. So this was they tried to solve it by using free aortic wall flap. This was later modified to the IMI technique, where a DKS-like anastomosis is created between the aorta and the PA, and the free wall of the non-coronary sinus is sutured to create a pouch. Now, once you do this, it's likely to cause a stenosis on the RVOT. So make sure that you place a good pericardium over it so that future RVOT is prevented. We have our own technique described from India. That's a Murthy-Cherian technique, which is again another innovative flap technique for single coronaries. Now these are some of the papers that are showing the results and techniques with intramural coronaries. So some of these recent papers have shown excellent outcomes. Now, this is not official classification, it's sort of a informal thing, but you should know that even if the coronaries are arising normally, but the different positions of the aorta can give trouble to the proper translocation. Now, anterior and side by side, we know how to do it. But when it comes to right posterior or left anterior, they can be really troublesome. This picture is actually, it looks like a normally related great arteries, but it's actually posterior TGA. So when you see the picture, you can see the LAD arising from the anterior wall, and that's after harvest of the right and the circumflex coronary artery. So you see the right and circumflex artery has to be taken all the way to the new neo-aorta. So it's the neo-PA is right in the way of the RCS circumflex button. So should you do a Lecomte or should you do a RV to PA conduit? So, we were on our toes whether to do it, how to get this done. But with extensive mobilization of the PAs and coronaries and tighter reconstruction of the PA, we could achieve a proper translocation. Now, this is another situation where you have a left and anterior aorta, wherein you have LAD and the RCA arising from sinus 2 and RCA LAD looping over the aorta and circumflex from sinus 1. And you can see the LAD there. So it's almost quite difficult to bring the LAD over to the aorta, which is lying posterior. So the only way to do this was to split the coronaries. Luckily, it was too austere, so we could split the coronaries, mobilize the whole length of LAD, which is the anterior loop, and bring it posteriorly and suture it to the circumflex to create a new button. And that's the neo aorta and the RCA button on top. And we could reimplant it with a medial trapdoor based flap, and the RCA button could be reimplanted, and the patient did well. Now, postoperatively, it is important to remember that if you're not in the practice of placing an LL line, if you've done a difficult coronary, it's a good idea to place an LL line. Make sure they get the aspirin at least for 3 months. I would safely recommend even a year. The most important thing is to have a rigorous follow-up, starting with Holter, angio at 1 year, or a CT, a perfusion scan later on. So it's very important to follow them up in the first 2 years, because that's where coronary events occur. So all large series have shown that, the more comprehensively you follow up, the more the incidence of coronary issues are detected. The take-home message is that almost all coronaries now can be transferred with no immediate mortality. So except in the intramural coronary arteries, you need to tread with caution. And the most important thing is, rigorous follow-up is needed to prevent sudden deaths in unusual coronaries. Thank you.
Thank you, Dr. Thomas. Can you hear me?
Yeah, I can hear you.
Yeah, that was excellent. I really enjoyed. So I will have discussion at the end of the session. I request Dr. Amit Mishra to go ahead with his talk. Can we load his presentation?
First of all, I would like to thank the organizers for giving me this opportunity to present my experience of this rare congenital heart disease. As name suggests, the Al-Kappa itself is a very rare congenital heart disease, constitute nearly 0.01% of congenital heart disease. I will be discussing my topic on the following headlines: that Al-Kappa from non-facing sinus, anomalous origin of left coronary artery from right pulmonary artery, anomalous origin of the circumflex coronary artery from pulmonary artery, left main coronary artery atresia. These are a few echo images of the patient where the coronary artery is arising from the right pulmonary artery. Usually it is not picked up by the cardiologist, but if they are experienced enough, they can see the flow reversal in the coronary arteries, and this reversal of flow is going up to the right pulmonary artery. That gives a high index of suspicion, and then the CT scan will confirm that the anomalous artery is arising from the right pulmonary artery, or say this image is showing that the circumflex coronary artery is arising from the right pulmonary artery. These are VRT images, which again confirms that the right pulmonary anomalous artery is arising from the right pulmonary artery. A brief about surgical steps. It is standard for the Al-Kappa, but few things which are very important when you are expecting some unusual anomaly. Number one, the collaterals. Collaterals will give you some idea. Is it a normal Al-Kappa, or is there some expected abnormality can be there? If you find the collaterals between the ascending aorta and the right pulmonary artery, there is a fair chance that you may get the Al-Kappa, that is the anomalous artery arising from the right pulmonary artery. I prefer to dissect the branch pulmonary artery, ligate the ligamentum, divide it, standard caval cannulation, and cardioplegia through both aorta as well as the pulmonary artery. One very important point which I would like to tell here, that after the division of anterior half of the main pulmonary artery, one should try to locate the origin of the anomalous coronary artery, whether it is arising from the facing sinus or non-facing sinus, or it is not at all arising from main pulmonary artery, or it is arising from the right pulmonary artery. This is the point when you can find out from where exactly the coronary artery is arising. Otherwise, if you divide the main pulmonary artery, then you can get into the problem if it is arising from the right pulmonary artery. So this is a very important point which I learned over a period of, and then you can transect the main pulmonary artery. I'll start with the non-facing artery, which is arising from the pulmonary artery. And as all of us know, the Takayasu is a well-known technique for the transfer of the coronary artery Earlier, it was used for the facing sinuses also. Then it was very popular for the non-facing sinuses also. But it has its own limitation. In fact, I have never done this technique. I have never used this technique. This is one of our patients who had a coronary artery arising from the non-facing sinus. This infant, we could easily harvest the left coronary artery, then dissect it from the epicardium, and using a medial base flap technique, we can relocate the coronary artery to aorta without any stretch. And this patient did very well. Though my experience in the coronary artery from the non-facing sinus is very limited, I only did 3 cases, including 1 adult. But all the time I could relocate the coronary artery to aorta without any stretch or strain, and all of the patient did very well. The second and a very important subset of anomalous origin of left coronary artery from the right pulmonary artery. As these figures are suggesting, it starts immediately after the origin, immediately at the origin of the right pulmonary artery. It starts from the right pulmonary artery, then immediately it goes into the aorta, and then it continues intramurally in the aorta, and then comes out through the normal path of the left coronary artery. This is the same figure, the operative photograph showing the aorta, main pulmonary artery. This is the right pulmonary artery, and this is the alcarpa, that is anomalous coronary artery arising from the origin of the right pulmonary artery and entering into the aorta. If I present the same thing in a little bit more diagrammatic way, so if you transect the aorta, you can see the left coronary artery entering into the aorta, continuing vertical intramural course, and then coming out through the normal origin of the left coronary artery. We have published our experience of intra-aortic course of the anomalous left coronary artery arising from the right pulmonary artery in 2017, and we compiled the cases which are presented till date. There are total 36 cases has been presented till date, and of the 36, almost 10 cases they have done the relocation of the coronary artery, and rest of the cases they have done unroofing of the coronary artery. These are a few images of our patient which we have presented in this article. Immediately after arising, the coronary artery is entering into the wall of the aorta, traversing vertically. You can see here it is traversing vertically in the aortic course, and these are the CT images of the same patient. Now, echocardiography invariably fails to identify just because there is a high origin of the left coronary artery and it runs parallel in the wall of the aorta. And these are the high points where one can suspect the alcarpa, presence of perpendicular course, and it is coming out perpendicularly through the junction with the aorta. Now, surgical techniques there, as I have already told, that there are the 2 well-known techniques. One is reimplantation and another is unroofing. The reimplantation problem is that one has to excise the button and turn it by nearly 180 degree to relocate to the aorta. And the other thing, the intramural course remains inside the aorta for lifelong, which can cause a problem, especially if the aorta is hypertensive. Whereas unroofing is simple, and one can just find out the way, one can probe it, find out the course, and just can unroof it. There is a difference if you know the diagnosis before, and if you come to know the diagnosis during surgery. By the time you are proceeding for the alcarpa, and then you come to know that it's alcarpa. Other thing, if you know already the diagnosis, you can transect the aorta, can transect the pulmonary artery, can open the pulmonary artery and see where exactly it is entering into the pulmonary artery, identify its course, unroof it, and once you unroof the coronary artery, you can re-endothelize it. And that's all. You will find a large opening of the left coronary sinus at the sinus of Valsalva at the lower end, and then you can re-endothelize. This is the figure showing the origin of the left coronary artery from the right pulmonary artery, and from here it is entering immediately into the right. Now, it is not that always you get the intramural course only. There are reports which represent that these coronary artery can have an extramural course also. So this is one of our patients who had an extramural course of the coronary artery. And here you can see the coronary artery is going extramurally, but it cannot be dissected into its entire course. So we have dissected it extramurally partially and used as a button technique. So we reimplanted the coronary artery onto the aorta. Now, some other variants of alcarpa, like this is one of the patients who had hemitruncus, and in CT scan, we came to know that the anomalous left coronary artery is arising from the origin of the right pulmonary artery. Technically, it was simple. I just have to disconnect the right pulmonary artery beyond the origin of anomalous coronary artery, and then I have to reimpart onto the aorta. This is the same patient where the anomalous artery is arising from the origin of the right pulmonary artery, Alcarpa with hemitruncus. This is again one of the very interesting case. I was operating this patient for the aortopulmonary window, and while opening the aortopulmonary window, I realized that the left coronary artery arising from the pulmonary artery side of the window. I just use a patch to divert, to close the window in such a way that the coronary artery is committed to the aorta. Very few cases are reported of this entity, Alcarpa with aortopulmonary window. This is again a rare entity, Alcarpa with double left anterior descending artery. There are two left anterior descending artery. One is long left anterior descending artery, which is coming from the right coronary artery going up to the apex, and another is a small left anterior descending artery. This patient had mild MR and mild left ventricular dysfunction, and we find there's a short LAD which was arising from the main pulmonary artery, and we have transferred this to the aorta. This patient is still awaiting surgery. He had coarctation VSD with anomalous origin of the left circumflex coronary artery from the mid of the right pulmonary artery. We have not yet operated this patient, and soon we will be operating this patient. This is again one of the entity, we can't call it as a variant of Alcarpa, but this resembles a lot with the Alcarpa. And when I saw this entity for the first time, I was not even knowing that there is something called left main coronary artery atresia also. First time when I was operating, I didn't find any Alcarpa. There was no coronary artery origin from the entire main pulmonary artery, from any of the sinus, from right pulmonary artery, left pulmonary artery. I saw below the pulmonary valve also, there was no coronary artery at all. In fact, I closed the patient, shifted to cath lab, and then we identified that the left main coronary artery is ending blindly. Before we could do something, this patient has succumbed. And after that, I was fortunate enough to get the two cases of left main coronary artery atresia. I operated both of them. I have my own technique of doing this, and one of them survived, was on follow-up for 4 years, and after that he is lost from the follow-up. I'll suggest that one should always suspect the left main coronary artery atresia if in a case of Alcarpa you are not able to locate the left coronary artery. And just behind the main pulmonary artery, you will find there are a lot of collaterals, and if you dissect in between these collateral cauteries, and if you see the collaterals, you will find there's a left main coronary artery stump. It has got a bulbous end. There is a classical bulb-like end is there, which is just 6 to 8 millimeter away from the ascending aorta. So you dissect this bulbous end, cut it, and once you cut it, you can create an opening into the ascending aorta, and these two things can be sutured together. The wall is thick walled, though there will be a lot of collateral blood coming through this left main coronary artery, and you have to use Nixter blower, and with that you can transfer this coronary artery to the aorta. It is a rare entity, but you usually present as a Alcarpa, and one can get it as a surprise anytime. Now with the diagnostic modalities are so good that one can pick it up before the surgery, but it is possible that when just cardiologists will always show the reversal of the flow in the coronary artery, and they will suspect the Alcarpa, and when you go, there is no Alcarpa inside. So these are 3 cases I did. One patient survived, other 2 could not be survived. Now a word about left ventricular function. So basically, whenever we talk about the Alcarpa, the left ventricular function becomes a very important factor. But what I have observed in early infancy, and if you operate, there is a minimal improvement in the left ventricular function by the time you discharge patient from the hospital. And if you operate the patient in the late infancy, say after the 6th month, there is hardly any improvement in the left ventricular function at the time of discharge. There's a lot of factor. It depends on the age at which you are operating, but scar tissue burden, presence of left to right shunt. If there is a VSD or there is a large PDA, AP window, there's usually these patients do very well. But I have observed that there's a gradual improvement of the left ventricular function even after 8 to 9 years of the surgery. I was not very supportive for doing mitral valve repair in patients with Alcarpa till 2012. And then after that, I started getting patients with back to me with mitral valve dysfunction, severe MR and all that, which I have left during the previous surgery. So now routinely I am a bit aggressive and try to repair the mitral valve, even if it's a moderate MR, especially the patient which is on the late infancy. Early infancy, say 2 months or 3 months of age, I'll accept the moderate MR, but late infancy, I'll invariably repair the mitral valve if it is moderate or severe. Even if the moderate MR or severe MR remains as a moderate MR, a posterior base annuloplasty will help you a lot in the ICU post-operative recovery. And most of these patients will do well. And most of these patients will not require, if you've done a good annuloplasty, will not require the reoperation. To conclude, a couple of things which I personally believe is important for this entity is first that once you divide the anterior half of the main pulmonary artery, try to locate the opening of the anomalous left coronary artery. It is very important. Keep your incision just below the origin of right pulmonary artery. And once you identify it, then only one should transect the main pulmonary artery. Other important thing, if there is a sudden unexplained ventricular dysfunction in any case of anomalous origin of coronary artery from pulmonary artery, one should always suspect the Al-Kappa. It is sometimes missed in the diagnosis echocardiographically, and because there's a left to right shunt and we just miss it. I have seen these things also. And thirdly, I would like to say the lifelong surveillance in these patients are mandatory, as they have diastolic dysfunction, longitudinal systolic dysfunction, and LV torsion remains impaired. So all these patients who underwent Al-Kappa repair, even if their ejection fraction is good, MR is mild, they need a lifelong surveillance. Thank you. Thank you very much.
Thank you, Dr. Amit. It was excellent. Really enjoyed. All the complex coronaries seem to be homing on to you. We'll have Dr. Shivkumar's presentation and then have the discussion at the end. You can go ahead with Dr. Shivkumar's presentation. Is it?
I would like to thank the organizing secretary for the 2021 IACTS Technocollege CME program, Dr. Shabrinath Menon, for giving me the opportunity to make the presentation on a rather rare cardiac lesion of coronary cameral fistula. The coronary cameral fistula comes under the larger classification of coronary artery fistula, which is a communication between one or more coronary arteries with the cardiac chambers. The lesion was first described by Crosser in 1865. Subsequently, early reports were made by few others. Maud Abbott published the first pathologic account of this condition in 1908. Bjork and Crawford performed the first surgical repair in a patient with a preoperative diagnosis of patent ductus arteriosus. This is a rare anomaly which occurs in 0.2 to 0.4% of all congenital heart diseases, and it occurs in incidence of 2 in 100,000 of the general population. And the incidence of it being picked up on a coronary angiography is 0.25% and a CT angiography of 0.9%. Coronary cameral fistulas are thought to arise as a persistence of the sinusoidal connections between the lumens of the primitive tubular heart that supply the myocardial blood flow in the early embryonic period in the absence of outflow tract obstruction. If it occurs in the presence of obstruction, then it will be termed as a coronary sinusoidal connection. Most of the coronary fistulas originate from the right coronary artery and drain mainly into the right heart structures with single fistula. Very occasionally, they can be multiple fistulas. Taking a look at the various angiographic images, one can appreciate the heterogeneous morphology of the fistulas and the challenge related to the management. Taking a look at the various angiographic images as an illustration, according to the site of the drainage, the ones that drain into the cardiac chambers would fall under the category of coronary cameral fistula. The coronary cameral fistulas commonly originate from the right coronary artery. The most common involved chamber is the right ventricle. They can be classified into an arterioluminal variety where there is a direct communication with the cardiac chambers, an arteriosinusoidal anomaly, which is an indirect communication with the cardiac sinusoidal net. High pressure flow in the arterioluminal type leads to the aneurysmal dilatation of these vessels. A coronary cameral fistula into the left heart causes left ventricular hypertrophy, and that drains into the right heart leads to pulmonary hypertension. Arterioluminal types can be treated with surgery, but the arteriosinusoidal varieties are usually treated conservatively. Coronary artery fistula is associated with other congenital heart lesions in 20% of the cases. Associated anomalies include tetralogy, atrial septal defect, ventricular septal defect, and PDA. The most common anomaly associated with this is pulmonary atresia with intact ventricular septum. And in these cases, where the sinusoids occur in at least 50% of the cases. More than 90% of the fistulas are congenital or sporadic. Acquired fistulas can arise as a result of any form of cardiac lesion or following any procedure to the cardiac coronary arteries, or electrophysiological studies, or post-transplantation. Very rarely it can occur as a result of trauma. Patients with a small coronary cameral fistula will remain asymptomatic. Spontaneous closure occurs in 1 to 2% of the cases. If untreated in childhood, they will progress to develop symptoms in adulthood. From the studies published by Libyatson et al. And Shamsundar et al., the older the age at presentation, the more the symptoms will be noted from this condition. Hence, many asymptomatic younger patients will need some intervention at an older age, and this warrants close monitoring of the asymptomatic patients. Untreated large fistulas will lead to heart failure and arrhythmias. Coronary complications do occur due to the Steele phenomenon. Endocarditis is a known complication which can be difficult to manage once established. Extracardiac complications, if the fistula ruptures exteriorly, can lead to hemopericardium, or the flow onto the right side can lead to pulmonary hypertension. Several investigations are available for diagnosis and treatment of the coronary cameral fistulas. A selective invasive coronary angiography is still the gold standard. Besides the diagnosis, it can aid in therapeutic embolization. However, it is an invasive procedure, and in comparison to all other invasive procedures, has procedure-related complications. The CT angiograph is currently gaining popularity as a modality of investigation. It involves shorter acquisition time. It can be used as a guide for even complex anomalies. The only drawback is the radiation exposure, which can be mitigated by low dose of radiation. A treatment for the coronary cameral fistulas can be challenging, as it is uncommon, and various modalities have been described for the treatment. It is best that these lesions be discussed in a multidisciplinary team meeting, which involves the surgeon, the cardiologist, and the interventionist. When operative repair is contemplated, it is of paramount importance to know the exact angiographic visualization, which is based on the Sakakibara classification. A Sakakibara type A lesion involves the proximal coronary segment, which is dilated. They have a side-to-side pattern of communication of the fistula. The type B is the distal type, where the coronary artery is dilated in its entirety and have an end-to-side pattern of communication. The treatment options available for dealing with such lesions are a direct ligation without the cardiopulmonary bypass support, or ligation and closure under cardiopulmonary bypass support. An occasional coronary artery bypass grafting can be indicated if there is a compromise to the distal perfusion. And last is the transcatheter closure, which is gaining popularity. The principles of surgery include performing the surgery through a standard median sternotomy, and after a proper assessment of the coronary anatomy, the fistula is identified and mobilized. Ligatures are placed around the coronary artery proximal to the fistula, and before tying, one needs to observe for any changes of or ischemic signs on the ECG and any wall motion abnormalities on the TE. The ligature is tied, and is preferable to reinforce with a second ligature and divide the fistula. Cardiopulmonary bypass is indicated in inaccessible fistulas when there is a huge aneurysmal dilatation of the fistula or there's any other coexisting intracardiac repair needed. The cardiopulmonary bypass is conducted through a aortobicaval cannulation with a cardioplegic arrest. In some cases, one need to consider giving a retrograde cardioplegia. When cardioplegia is instituted, it's good to temporarily occlude the fistula to make sure that there's adequate perfusion of the plegia into the native coronary arteries. This schematic representation of the fistula involving the right coronary artery draining into the right atrium and the right ventricle. This is more of the Sakipara type A lesion with a side-to-side configuration. These lesions are best ligated and divided. Sometimes it is not possible to perform a direct ligation. In that case, it is possible to use projected sutures which are placed to occlude the fistula. These lesions preferably is best to be divided because division will completely prevent any recurrence. And this is called the epicardial approach. The distal type fistula can either enter into the cardiac chamber or have intramyocardial tunnel, or sometimes present as a huge aneurysmal segment. In this type, endocardial approach is performed by opening the fistula, and both the entry and the exit points are closed, and the enlarged coronary arteries are resected. Alternatively, one can access through the chambers of the heart and close the exit point with a pericardial patch or direct suture. This is done especially when a concomitant intracardiac repair is contemplated. Management of a multiple fistula can be pretty challenging. In these kind of cases, if there is just a double fistula or a bilateral fistula, one can resort to a simple ligation and division. At occasions, these fistulas can all drain into a lake of fistula. In that kind of situation, the individual fistula has to be identified and ligated. Occasionally, it is impossible to close all the fistulas. In this kind of instance, the exit point of the fistula are identified in the chambers of the heart, and they are closed en masse with a pericardial patch. Giant aneurysms can occur in a long-standing coronary artery fistula. If that happens, one needs to excise these aneurysms through an endocardial approach, and then closing off the entry and exit points, and then obliterating the aneurysmal segment completely. Occasionally, a concomitant coronary artery bypass grafting may be necessary. In the recent years, transcatheter occlusion has been gaining some ground in the management of these lesions. There are various kind of devices that can be used, of which I wouldn't want to go into the details. But there are contraindications to this procedure, especially when you're contemplating to use them in young patients, and in those fistulas which have a large and wide neck. And in conditions where you need to perform a concomitant surgical repair, it is always better to close the fistula via surgery. This is a patient who had multiple fistulas, which looked small, but on doing hemodynamic assessment, the shunts were significant. These kind of multiple fistulas are difficult to be closed via surgery. So in a multidisciplinary meeting, the decision was made to close this via catheter guidance. And these individual fistulas were occluded using coils, and we were able to get good results. Our treatment algorithm for coronary cameral fistula are, if the patient is having a small fistula and it's in a proximal type or the distal type, we will do no intervention, but just continue observation. If they have a proximal fistula, which is large or medium with symptoms, in that kind of case, we will intervene by either a surgical ligature or a transcatheter closure. All these patients will have a 1-year treatment with antiplatelets. Medium-sized coronary artery fistulas with symptoms will undergo intervention, and all these patients will be on antiplatelet therapy. Alternatively, they will be followed up for a period of time. And in that case, we will put them on antiplatelet therapy for indefinite period. But large symptomatic and asymptomatic fistulas will warrant immediate intervention, and all these patients will have an anticoagulation therapy with heparin and warfarin. The warfarin is for 6 months to 1 year, and they will have indefinite period of antiplatelet therapy just to make sure that they are, for the residual coronary dilatation, they don't develop any thrombosis. The results have been pretty encouraging from the surgical point of view, wherein Chong and colleagues in their long-term results found that 96% of the patients in their series remain asymptomatic at a mean follow-up of 9 years. The recurrence rate was only 10% in this study. Valente and colleagues showed a complication rate of 15% in their series and a residual fistula of about 30%. The predictors for adverse outcomes from surgery are those patients who have a fistula length with tortuosity, an advanced age at the time of intervention, and those fistulas draining into the coronary sinus. And the recurrence rate is high if you just do a simple ligation rather than a division. So it's of paramount importance to identify the timing for this intervention in order to get the best outcomes. Look at the overall surgical outcomes from the various series that have been published in the past. They have shown no mortalities and a lower freedom for pre-operation, a fairly long-term follow-up. And surgery will remain the treatment of choice in the current era. However, there are some reports coming out with the comparing both the surgical and the transcatheter techniques, and these have actually shown equivocal results, though the follow-up for the transcatheter closure is pretty short compared to the long-term follow-ups of surgery. So in summary, asymptomatic coronary cameral fistulas probably just need surveillance and need to be followed up on a yearly basis. And once they develop symptoms, they need to undergo some kind of a treatment. Cardiac catheterization or a CT angiogram will be the gold standard to assess prior to reconstruction. Surgical versus catheter intervention, the jury is still out there. Both can be considered, but it has to be made on a decision in a larger forum. A direct ligation should be accompanied by division. If distal perfusion is compromised, a concomitant coronary artery surgery is needed. All these patients after surgery will need to undergo a lifelong antiplatelet therapy in the long-term follow-up. Thank you very much.
Thank you, Dr. Shivakumar. That was excellent review of a fairly rare condition with sort of equivocal long-term results. Can we have the expert panelists on board, Dr. Brijesh, Dr. Devaguru, Dr. Ashish Kateva, Dr. Kanchana Singampuli? So, first we'll have a discussion on the few questions that have been popping up. First question to Dr. Thomas. What are the tips and tricks for a damaged intramural coronary artery? So if you open and you are damaged intramural coronary artery, what would you do?
Yeah, the two options that are available are, even in a neonate, one is to directly implant the coronary back using either a pericardial augmentation. Directly, you can implant it back to the aorta. Or even in the worst case scenario, you can use a femoral, you can use a internal mammary artery, or even take down of a subclavian. So these are the ways in case you've gone out into the coronary and split open the coronary, you can patch it up.
So basically you patch it up or use an internal mammary or subclavian artery turned down to manage it.
Yeah.
So do you recommend CT in all cases for planning a switch? When you suspect through echo that something could be amiss?
No. Because CT, it's being it's coming up as a new modality. Unless you have the latest protocols with it, you're not likely to delineate the intramural part of coronaries. So for most cases, till now, echo remains the standard, gold standard for diagnosis, and a higher suspicion during the surgery. In case you find interarterial course of a single ostium, even if they don't say that there is an intramural, you better assume that there could be an intramural and plan accordingly. So that's possibly the best way. CT, as the imaging protocols improve, CT will probably become a diagnostic method.
Okay, so it's something which we have to be prepared to handle as an emergency basis as surgeons. So
yes. Sometimes even the single ostium that I had shown, it turned out to be an intraoperative surprise. So
yeah, most of the time we are caught by surprise. It's very rarely that we have a pre-operative knowledge of intramural coronaries.
Yes.
Okay. So we'll have some question to the panelists. Dr. Devaguru, what's your experience with adult Al-Kappa? And what's your take on that? How do you manage an adult Al-Kappa?
Adult Al-Kappa we rarely get, but when we get, we use the same translocation technique only, RVS the coronary as much as possible. And I think it is quite simple compared to putting a Lima to LAD or doing other things. So I'm more comfortable in translocating the coronary back to the aorta.
Exactly, agree with you. So I came across an adult who had presented with MR. So on opening, I found the RC was dilated and there were no other associated things. So then this lady turned out to have an Al-Kappa who presented as an isolated MR. And then I went ahead and did a direct translocation. I think as pediatric surgeons, we are more happy translocating rather than putting a Lima LAD.
Lima LAD. It is wonderful to see Shiva, Amit, and Matthew and Ganpati.
Yeah.
Good morning, everyone. Good afternoon to Shiva.
Hi, good afternoon, Dr. Deva.
I just make a comment here about adult Al-Kappa.
Yeah, sure, sir.
Yeah. Very often, as you said, that it can be a surprise on the table. Sometimes it may not be, but in adults, you do also tend to find a lot of collaterals, much more than you do in a neonatal infant, and bleeding can be troublesome, especially from the posterior wall. So the Takeuchi is a very useful option in adult patients because here there's not much concern about having late pulmonary artery obstruction because these are huge pulmonary arteries and dilated. So the Takeuchi can be more conveniently done, less risk of bleeding, and for an adult patient, there's less risk of any long-term complications.
Thank you, sir.
Could I ask a question to Dr. Thomas?
Yeah, sure, sir.
Sure, yeah. Dr. Thomas, I really enjoyed your presentation on the various varieties that you have shown on the coronary anastomosis in TGAs. My one question is regarding the side-by-side anatomy, because you see in a natural setting, the aorta is usually at a higher level than the pulmonary arteries. So when you are doing the the coronary transfer, you tend to put the coronaries at a higher level. But as the anatomy goes a bit more to the side by side, or sometimes the aorta does go to the normal relationship of the pulmonary arteries, then the height of that coronary anastomosis going to the neo aorta probably may not be as high as what we actually anticipate. In these kind of circumstances, would you bring the coronary anastomosis lower down? That means even to the level of the sinuses, or you will still try to aim your anastomosis to be kept higher up above the sinotubular junction? This is something that is always comes as a dilemma, especially when you have more of the complex lesions with the side by side or the near normal relationship of the great arteries.
Yeah, in side by side, there is always an issue that in any other malposition other than the anteroposterior location, it's difficult to raise the coronary. That being said, the most important reason to raise the coronary is not just a prerequisite that you have to raise it up higher. The important thing is to see that whether you're getting a kink, whether you're relieving a kink or not. That's the aim of raising the coronary higher, other than the theoretical possibility of a neo AR in the long-term future. So even if you're not able to raise it, there's no contraindication in placing it at the sinus level. And sometimes what we've seen in the side-by-side vessels is that the coronary may not be able to place the button vertically. Sometimes you may have to slant it, or sometimes in some of the things it goes way down horizontal. So there could be a twist of the button, which you should try to avoid. In fact, when you place a twisted button, there's a higher chance of formation of a slit-like ostia and coronary ostial atresia and acquired atresia. So whenever possible, try to place it higher. But in case you can't, of course, you'll have to go to the sinus level.
Would you have any difference in your preference between a closed technique and an open technique if you're going to some selective cases? I see that your preference is more towards the open technique, but if a surgeon is, very religious about doing one technique over the other, is it a better option to kind of keep that option open?
Yeah, between closed and open technique, I don't know. It's more of a preference. And in case you're having a difficult coronary, even the proponents of the closed technique have suggested that you can do a open technique with a trapdoor, a proper trapdoor, when you face difficult coronary situations. So possibly it is better that when you're facing real abnormal patterns, to possibly use an open technique with a trapdoor.
Thank you.
Can I have a question to Thomas?
Yeah, sure.
Yeah. Hi, sir.
Hi. The commonest complex coronary we get is the circumflex coming from the right. Yes. So the problem is the circumflex getting kinked most often. So yes. The one thing is to stay close to the ostium on the circumflex side and keep away from the ostium on the RCS side. So we don't want any length on the circumference side, but we want some length on the RCS side. That is one. And the second thing, as you said, you place it higher. The third thing you said is to keep it away from the pulmonary artery. Do you dissect it that long, circumflex?
Keep it away in the sense you don't skeletonize the circumflex, but what you do is the visceral pericardial reflection between the circumflex and the P. That is just separated. That is just
take it off. Okay.
Actually, all around the PA. Not so, because when you implant it higher, you don't need, even if you don't do it prophylactically, when you implant it higher, if you see a kink between the free portion of the circumflex and the fixed portion of the circumflex, if you see a kink, it's better that you release it circumflexion. It will provide an unkinked course for the circumflex.
Okay, I got it. Thank you.
Another point is to separate the circumflex and the right coronary artery so that they move independent of each other. The little epicardium between them, if you can dissect and separate them, then the sort of kink can be avoided. So this one technique, sort of, which I realized recently can be of use. Not just for this, but any big branches, you dissect them individually so that the little epicardium between them is cleared off.
Skeletonize them.
So I can add one more comment on that, with the permission.
Yeah, sure, sir.
Yeah.
Sure, sir.
Yeah. One, of course, to re-emphasize what Matthew has said, to dissect the circumflex from the back wall of the pulmonary artery. That's, I think, a very crucial step. The second point, which I want, there also needs to be an axial rotation when you implant the button. So instead of putting it exactly in the same position, you need to rotate it by about 30 degrees in the long axis. And that allows for a better lie of the circumflex, because once you move it a bit higher, then you're again likely to kink the origin of the circumflex if you don't provide that axial rotation. So in combination with implanting it higher, we need to rotate the button clockwise by about 30 degrees in order to prevent that kinking.
I would like to ask the expert panelists about their philosophy of doing the switch. Is it iota first or trapdoor, or can I ask this question to Dr. Brijesh?
I am actually more comfortable in doing the close technique because I've been brought up, trained in a way doing the close technique. My take up on it is that, see, especially if you have a TGA VSD where the pulmonary artery is going to be dilated, once you do the close technique, it also gives an idea about how much higher you can, because once you do the close technique, do the aortic anastomosis and release the cap, it gives an idea of amount of dilatation which can happen. So compared with the TGA VSD, that is one thing which can help. Second thing which I do is in a normal TGA where it's more deposed, you always see the right button goes at a higher level compared to the left button. But as the anatomy changes, when it becomes an L post aorta, one thing you see is that the left button goes much higher than the right button. So as Thomas has pointed out, the orientation also determines how high the buttons go. And when you have a VSD, when the root get dilated, then you see that transversing above the STJ becomes less and less, and it comes more towards the sinus. So one thing which when I've been continuously doing the close technique, probably a little bit more, it becomes more predictable rather than the skill of identifying the exact point where you need to put in. Will be more in the open technique. So once you are doing close technique, I think it's become slightly more difficult to go back to the open technique and then do it.
The one drawback of the close technique which I found was you tend to, especially in normal coronaries, you tend to go more medially, so that the course lies interarterial rather than more away when you do a trapdoor. So has that been a problem when once you reconstruct the pulmonary artery? Have you found compression on this a little more frequently? This is open to all those who have used both the techniques of open or closed. Can I take opinion from the panelists? Or what is Dr. Kanchana, what's your take on this? Do you use open or closed technique?
I usually use the open technique. I have always used the open technique because I have been trained in the open technique. And I usually, as the button transfer technique I use is the direct button implantation into a puncture hole rather than the trapdoor. But in the instances of difficult coronary, like anterior looping coronary, then I always have a very low threshold to go for a medially based trapdoor, which will give more length to the coronary. That is almost like 50%. I would easily do a trapdoor incision if it is anterior looping coronary. And because of this direct implantation, I usually always mark the site of implantation right after I open the pericardium and fix the stitch the pericardium. The first thing I do is look at the coronaries and look at the lie and mark with the 6-0 pole in the pulmonary artery where I am going to put the coronary, which is usually about 3 to 4 millimeters above and lateral to its original position. And then in my mind, I visualize it being there with the heart full and think whether it will be okay with the branches going here and there, whether they'll be lying in a more comfortable position. But this is always subject to revision once I open. And when I open the pulmonary artery, I always look at where I have marked and see whether I always put it over the level of the commissures. I never sort of go at the level or below the level of commissures, and I look at the position I have marked and look at the mobilization I have done and whether it is very easily coming there with the lie that I wanted. Because sometimes I might move 1 millimeter to the left, or that means posterior, or to anterior, depending on the harvested amount of the coronary. And so it's a sort of a subjective sort of no fixed rule method. But the few fixed things I do is marking the coronary before surgery and doing it always in the open technique, and slightly shifting the point where I have marked, depending, looking at the inside. Sometimes it may be close to a commissure. Then I have to always move it either laterally or medially. And then depending on the amount of coronary the mobilization I have done. Also, the other thing is once the mobilization of coronary, I complete once I have divided the pulmonary artery as well. Because if I need to mobilize the circumflex, once you divide the pulmonary artery as well, not only the aorta, it makes it easier to mobilize the circumflex. And I always mobilize the circumflex when it arises from the sinus too, like Dr. Matthew said, all around the pulmonary artery, so that it is quite loose. And as you said, only on the visceral pericardium towards the pulmonary artery side, so that it is loose and can move easily, and then mobilize it higher. And as Dr. Iyer sir said, slight with a rotation, like about a 2 o'clock rotation in the way, so that it is lying in a more unobstructed and non-kinked way. Plus the anterior looping coronaries, I always mobilize with the regular diathermy probe without using the cautery, just the blade of it to undermine it with the visceral pericardium towards the apex, not damaged, but the visceral pericardium towards the pulmonary artery or the neopulmonary artery always cut, so that the coronary artery finally slides over the neopulmonary artery when coming to the anastomotic site.
Correct.
And almost always very low threshold to make a medially based trapdoor if I think the coronaries are being pulled, especially when it is a LAD and RC arising from the same ostium. I have a very low threshold to go for a medially based trapdoor.
Okay, thanks. We'll have one last discussion in the interest of time, then we'll sort of wind up the session. Dr. Devaguru, have you had extension experience with coronary extension techniques in non-facing in Al-Kappa when they arise from non-facing sinuses?
I have not done. Maybe in case the worry is the PA pressing on it. So in that case, you directly translocate. Maybe you can extend with the autologous aortic tissue, if at all. The problem is compression of the RVOT. In that case, maybe it will help you to do a LeCount. In that case, if you have a feeling that will get pressed by the PA, then you can do a LeCount. Maybe Amit Mishra can have a word on whether any situation will require a LeCount. For example, Al-Kappa arising from the RPA, does it warrant a LeCount or not? Or does he do it routinely like that?
Dr. Amit, you need to unmute yourself. Dr. Amit, Dr. Amit, can you unmute yourself, please?
Okay. And
yeah.
So far I haven't done LeCount for any of the patient, and I have done only 3 adult Al-Kappa, out of which 1 it was arising from the non-facing sinus. If you take out the button and mobilize it nicely, I agree there will be a lot of collaterals. And if you create a medial base in situ trapdoor, I try to create for non-facing sinus without dividing the aorta. I try to create a trapdoor, and I try to keep visualizing that the final coronary anastomosis is going to be around 7 o'clock position. So that will be far from the pulmonary artery, and it won't compress. So I haven't done anything. Anytime means I have to do the LeCount for any of the patients. I could manage, I mean, non-facing sinus without LeCount.
Sure. Ganapati, I will add a point on it.
Yeah.
See, we have actually published 4 cases of Al-Kappa arising from non-facing sinus, where all cases were done by direct anastomosis by doing the LeCount maneuver.
No. Never.
From Amrita and say.
Okay, sorry.
We have published, and only thing you need to look at, we were able to do direct anastomosis in all the 4 cases. Only thing you need to look is in a normally related great artery, when you do a LeCount, there is always a chance that the RPA can get stretched around the aorta. So you need to take a little bit of aorta down, or you may have to then put in a small patch in the origin of the.
Yeah, I know that the AIMS people are proponents of this LeCount. They sort of first popularized it. This sort of lays stress on the reconstruction of PA is also important after Al-Kappa, because and I think that is why the concept of Florida patch has also come into being, where you make sure that the RPA doesn't stretch over the coronary artery and compress it. So there are 2 schools of thought where you can completely transect the aorta and then make a trapdoor, or you can do it in a closed manner. But the thing is, when you do it in closed manner, you tend to move more anteriorly, and after you reconstruct the PA, there are chances that this RPA can stretch or compress the coronary artery which is reimplanted. So the PA reconstruction is also equally important. After any complex coronary translocation, and I think sometimes it doesn't get the sort of attention or the respect it deserves. So, Dr. Iyer, any comment on this?
Yeah, I again to re-emphasize that people shouldn't totally forget the Takeuchi procedure. Please remember that in the Takeuchi, the only issue there is a small patch of pericardium in the anterior wall of the pulmonary artery, and the rest of the anatomy is normal. So instead of resorting, I think one shouldn't blindly follow the trail that one should do a direct translocation. Because with a direct translocation, you are distorting the anatomy significantly and then ending up doing a Lecomte and then doing a RPA-plasty. All that is so much more complicated and has so much potential for long-term issues than a straightforward Takeuchi. And I've had patients with 25, 30 years follow-up with the Takeuchi procedure doing extremely well with no problems or complication whatsoever. So I think in a situation where there is a coronary arising from a non-facing sinus, Takeuchi provides equally good results, if not better, than doing a complex repair with the Lecomte maneuver, etc.
Maybe one way to simplify is to just use a 5 mm Gore-Tex tube connected to the aorta and to the ostia, so that it lies posteriorly. And Dr. Balakrishnan has sort of published results of 26 years follow-up with patent Gore-Tex tube used in this position. It's just like a Takeuchi outside the pulmonary artery, so that you you have a reasonably big tube connecting the aorta and the pulmonary and the coronary artery.
Yeah, so natural tissue is always better than Gore-Tex, but yes, that's another way of doing it.
I think, Dr. Shabri, do you have time, or do we need to wind up this session?
The discussion was really good, and even I was listening to all the thing, but unfortunately, I think we'll have to wind up this session because subsequent sessions are still there. Anyway,
sure. It was a pleasure meeting you all, and
thank you.
And we can have more personal interactions later after the meet, and it's been a pleasure being in this session. Thank you.
Thank you, Sabri. Thank you, Gandhi.
Thank you,
Thank you,
Sabri.
Thank you.
Thank you.
Bye-bye.
Thank you, Deva. Thank you.
Bye.
Okay, so we will start the next session after 5 minutes break.
चलो हो गया है। अब ये सब लोग अपने अपने जगह बैठे हैं।
To healthcare providers, patients' healing comes first. But many a times, their own safety takes a back seat. Every day in the OR, the world over, those with the healing touch are doing what they know best, saving lives. But here, a health hazard exists that needs everyone's attention. All procedures require energy-generating devices, and they produce surgical smoke that gets released in the OR environment. The danger is here, in the unseen. Research shows that surgical smoke can contain a concoction of many viruses, bacteria, or hazardous chemicals. The harm it does is equal to smoking several unfiltered cigarettes at one go. These toxic nanoparticles can permeate through masks, making their way down the respiratory tract and lungs. Studies show that these particles distribute rapidly and uniformly in the OR. It takes a considerable time for particle counts to go back to baseline levels. The long-term effects of exposure to surgical smoke can cause both acute and chronic health issues. A danger that is now getting recognized and with widespread recommendations by global and local medical organizations. As your global partner, our mission is to help you minimize your exposure to this surgical smoke. Introducing Megadyne Smoke Evacuator, an advanced smoke management solution. It delivers effective and quiet performance for open and laparoscopic procedures. This advanced system activates automatically by detection of energy devices, both core energy devices like monopolar and bipolar, and advanced energy devices like ultrasonic and advanced bipolar. The Megadyne smoke evacuator filter is designed to capture particulates and microorganisms as small as 0.02 micron at 99.999% efficiency. It is intuitive and simple to use, with many adjustable options for flow rate and runtime. Its combination with Megadyne smoke evacuation pencils can potentially capture 99% of surgical smoke when placed 1 inch from the source. We at Ethicon believe healing starts with a safe OR for everyone. Let's advance OR safety together. Visit our website or contact our representative to know more.
We are Healthium, a leading global player in medical devices, creating access to precision medtech for every patient globally. Our passion for R&D, stringent quality control, and sharp focus on next-generation technology has resulted in 52 patents in India and the US, and enabled us to get US FDA, CE, and ISO approvals. We are the largest independent manufacturer of surgical suture needles in the world, the first in India to manufacture bioabsorbable implants and contribute to 50% of India's suture exports. Across the globe, surgeons use a Healthium product in 1 in 6 surgeries to ensure superior surgical outcomes. This is our legacy, born from passion, precision, and a quest to create medical devices that simplify usage for surgeons and benefit patients globally. In our quest for innovation, we have created products of superior design by combining our key understanding of the market with new generation technologies. Presenting the next generation endo cutter stapler from Healthium that combines precision articulation, single-handed operation, and versatility of using one handle for all types of cartridges. Healthium endo cutters create an optimal B-staple formation, even in varying tissue thicknesses, and ensure optimal hemostasis, support wound healing, and prevent necrosis by ensuring adequate perfusion to the edges of resected tissue. The strong titanium staples withstand pressure under situations of high tissue load. The sequential staple height cartridges ensure calibrated compression, low tissue stress during compression and clamping, and enhanced perfusion to staple line. Lateral tissue fluid diffusion during compression results in less force to fire. Healthium endo cutters offer optimal wound healing even in organs with variable tissue thicknesses. Healthium endo cutters use a unique technology that ensures optimal B-staple formation at the near, mid, and far end of the stapler, regardless of tissue thickness, and hence offers superior staple line integrity. The sturdy and ergonomic handle ensures single-handed operation, precise articulation on both sides, and a simple loading mechanism ensures a superior user experience. Healthium Next Generation cartridges come in 3 different types and 24 variants to address all tissue types and organs. Look for our ordering information. Guns in 3 sizes and straight and articulating reloads in different sizes. The result of precision and design excellence, Healthium's new generation linear cutters for superior surgical outcomes. Healthium linear cutters ensure optimal hemostasis, support wound healing, and prevent necrosis. Healthium linear cutters offer uniform staple compression, resulting in an optimal staple line with well-formed B staples, irrespective of tissue thickness and/or structural complexity of the organ. Healthium linear cutters fire with uniform firing force across the staple length, ensuring well-formed B staples. The floating cartridge and inbuilt mechanism prevent accidental firing. Healthium linear cutters offer easy and confident firing action with an ergonomic handle, secure grip, and an adjustable ambidextrous firing knob. Healthium linear cutters offer the highest 5 variants of stapler cartridges in blue and green to address tissue length and thickness. Look for our ordering information. Healthium's new range of next-generation endo cutters, linear cutters, and reloads are complemented by our circular and hemorrhoid staplers. Across 18,000 hospitals in India, these products bridge market need gaps and continue to make life easier for surgeons, assisting them to provide desired surgical outcomes. This is what we call precision with a purpose. Healthium.
A very good afternoon and a warm welcome to all attending the session on challenging case scenarios in COVID. All cardiac surgical units are looking for ways to continue services in these difficult times, and a discussion on what is troubling us will help us reach common consensus in treatment. Without much delay, I would like to invite Dr. Dhairishil Kanse to share his experience from Pune.
Hello, everyone. I'm Dr. Dhairishil Kanse. I'm a cardiac surgeon from Pune, working at Tirunal Mangeshkar Hospital. I'm going to present a case of COVID-19, a post-operatively developed COVID-19 in a case of Bental with total aortic arch replacement with frozen elephant trunk, followed by TVAR. Our patient was a 33-year-old Marfanoid female with 30 weeks of pregnancy. She had undergone an aortic valve repair 10 years back for a query-infective endocarditis, the details of which were not known. Now, during pregnancy, on follow-up 2D echoes, she was incidentally diagnosed to have a large descending thoracic aortic aneurysm with type B dissection, which was extending beyond the left subclavian artery up to the left renal artery. She also had an aneurysmal dilatation of ascending aorta with moderate to severe aortic regurgitation and moderate aortic stenosis. These are the CT images where you can see the ascending aorta was dilated. The sinotubular junction was nearly 5.2 centimeters, and this was the descending thoracic aneurysm with type B dissection. This image will show the extent of the aneurysm with dissection. Now, an emergency LSCS was done, and she was taken up for surgery on 10th post-operative day after LSCS. The surgery performed was Bental procedure with total aortic arch replacement with frozen elephant trunk. This was a stage 1. Here you can see the image where we replaced the ascending aorta arch, and we had placed the frozen elephant trunk segment to cover, with an intention to cover the dissecting flap. But post-operative T was showing some endo leak. So patient was taken up to cath lab, and here we can see the endo leak, which was persistent. So for endoleak, what in cath lab, we were attempting a TVAR while the TVAR sheath got stuck at the iliac level. So the proximal aortic patient was shifted to OR again, and a proximal aortic control was taken, and aortofemoral graft had to be placed. Electively on post-op day 2, we went in again and did TVAR to cover the endoleak. Here you can see the image where the stent was covering the endoleak. Now, post-operatively, patient had a longer ICU stay because of multiple minor issues. But nearly after 10 days, she had a massive perrectal bleed with hypotension and she had to be reintubated. She was resuscitated and was shifted to colonoscopy in emergency. The bleeder was clipped. She was hemodynamically stable now, and as this event had happened at the height of the first wave of COVID, we suspected COVID-19, as we had seen a similar presentation of COVID-19 in one of our CABG patients with a perrectal bleed. Now, patient was extubated after 2 days, but she persisted to have breathlessness, and she was requiring NIV. The RT-PCR report came out to be positive. Infectious disease specialist team was involved, and she was treated with high frequency nasal cannula with the oxygen of nearly 50 liters with steroids and remdesivir. She was showing significant leukopenia. The counts had dropped down to 1,160. During the same time, the right groin wound showed some gaping. Electively, a faciocutaneous flap was done to avoid exposure of the aortofemoral graft. While this was being done, she showed improvement and her O2 requirement significantly decreased. But now she had mild fever. The blood culture had grown Acinetobacter. Antibiotics were stepped up as per sensitivity report and after discussion with infectious disease specialist. Patient now showed further improvement and was maintaining good saturation on room air, was shifted to ward. Next day, immediately after shifting to ward, she developed a massive secondary bleed from the femoral graft site. Pressure was applied and patient was shifted to OR in emergency. The aortofemoral graft had to be excised and the right axillofemoral bypass grafting was done to re-establish the limb circulation. After this, she still did persist to have low-grade fever spikes. So the antibiotics were stepped up after a group of infectious disease specialists discussed and planned the antibiotic management. Following this, her fever subsided and her total leukocyte count normalized. Patient was later discharged, but was on antibiotics with continued antibiotics for 3 months following discharge. With the graft in place, the antibiotics were continued for a longer time. Now, the antibiotics have been stopped for nearly last 4 months. Patient is doing well. And now it is nearly 7 months since discharge. These are the CT images which were done 3 months after the discharge, which shows, the left one shows the Bental with frozen elephant trunk graft and the TVAR stent in place. And the right one shows the right axillofemoral graft with the good lower limb perfusion. The take-home message here is that we have to have a high degree of suspicion. COVID is a difficult situation and has brought in newer set of post-operative difficulties with newer complications. We need to keep improvising to overcome these complications. But finally, the only thing I would say that persistence pays. Thank you.
I invite Dr. Simran to share his presentation.
It is indeed a pleasure and an honor to be back to Chitra for the IACTS Technocollege 2021, albeit virtually. I would like to extend my gratitude to the folks back at Chitra for giving us an opportunity to share our experience of cardiac surgery in the times of COVID. I have no disclosures for the same. Now, we are a dedicated COVID center as per the Municipal Corporation of Greater Mumbai. Out of the 770 beds, 200 of our beds are dedicated to COVID. 50 ICU beds, 150 ward beds. This is not including the beds catering to the staff or the staff's relatives of the hospital. But the problem is we don't have any pediatric COVID beds. According to the Municipal Corporation, the pediatric cases are to be managed only in the 3 or 4 dedicated pediatric COVID centers. So our pediatric COVID cases are being managed in isolation in the general ward or a non-pediatric ICU. So our experience with COVID has been pretty modest. We have managed about 9 patients with COVID. Out of them, 3 were elective scenario, 1 ASD, 1 ARCH and 1 VSD. We did the RT-PCR as a pre-op routine investigations, found them to be positive, discharged them, called them back after 21 days when they were negative after the isolation period. 4 were urgent. Out of those, 2 TAPVCs, 1 ARCH and 1 TGA. We kept these kids in the hospital in the general ward along with the parents. The ARCH required a balloon dilatation to tide over the interim period, and the TGA required a BAS. The 2 patients who developed COVID post-operatively, unfortunately, both of them expired. And today we'll be discussing one of those patients. So our patient is a 4-month-old infant diagnosed to have congenital heart disease on a routine checkup. The child was syndromic with microcephaly and had delayed milestones. The child had complete AV canal with severe AVVR and balanced ventricles. The child was admitted and worked up for surgery, and along with the routine investigations, RT-PCR done preoperatively was negative. The child underwent a standard 2-patch repair correction with routine time on CPB and routine cross clamp time, came off on dopamine, milrinone and calcium, and nothing was off during the surgery. The child came off with a heart rate of 145 with the pressures of 61/32. PA pressures were well within range, CVP of 12 and an LA of 10. Echo post repair showed good biventricular function, no residual shunt, trivial right AVVR and trivial to mild left AVVR and no LVOTO. The child did well on the evening of the surgery and was extubated early in the early hours of post-op day 1. Post-op day 1 echo showed good function, only mild valve regurgitation and no residual shunts. But by evening, the child started becoming tachypneic, and as routine, we managed the child on Hudson CPAP. But within 2 hours, the child had a bradycardic event. CPR was instituted, and we had return of spontaneous circulation within 2 minutes. By now, X-ray had shown bilateral congestion. Echo was showing mild dysfunction and moderate right valve regurgitation. Thinking this was infection, which we face with pretty routinely because we get very late referrals for all our patients, the antibiotics were upgraded. The child started developing arrhythmias and was started on adenosine. Over the subsequent days, the child's X-ray worsened and the child got re-intubated, but the gas exchange was good. The story continued for about a day and a half, 2 days, and we repeated the RT-PCR heading nowhere, which turned out to be positive. As per the institute protocol, the child had to be shifted to a COVID ICU. Since we do not have pediatric COVID beds, the child was shifted in isolation with 1:1 nursing. And to highlight the point again, it was a non-pediatric ICU. The child was started on remdesivir, methylprednisolone and Clexane, which was the evidence at that moment in the management of COVID patients. The child started to have episodes of PA crisis with moderate right AVVR. LV was moderately dysfunctional. INO was added and the inotropes were upgraded, and the child seems to settle. The cardiac output was well maintained and the gas exchange was good. But by post-op day 10, the child's X-ray was improving and the inflammatory markers were settling down. The child had multiple episodes of bradycardia and was paced. We were not informed about this development, and by evening the child pacing was not capturing.
The child developed a bradycardic arrest and could not be revived. This table shows us the inflammatory markers of the child. On admission, the CRP was well within normal, and even through the entire process, the CRP didn't go up much. The total counts had an upward trend, but came down towards the later part of the course of the child. The D-dimer also showed an improving trend. The interleukin, which had gone up, also started improving. The ferritin, which had gone up, had also started improving. For those of you who've been managing patients with COVID, you know it's not an easy situation. By the time the child was shifted to the COVID ICU, we had 3 doctors who tested positive and 4 nurses who tested positive for COVID. And out of the 4 nurses, 3 were in the hospital and needed ICU admissions. What we learned from this situation was very unique for us because COVID being detected post-operatively, it was a very difficult subset for us to manage. Difficult not from the point of view of medical management, but from the point of view of logistical management. Now, we rounded on this child twice daily, once in the morning and once in the evening, but we were supposed to be informed about all the developments which happened with the child virtually, but we never got about to doing that because of the way the COVID ICU was swamped with the work. The doctors there had their share of problems to face, and on top of that, they had a pediatric post-op patient who probably they had no clue of managing. The treatment options are very few in this situation. We don't know what we are treating. We're treating a viral infection. Viral infection which affects the cardiac function, viral infection which affects the pulmonary functions in ways which we are only beginning to learn now. ECMO was always an option for this baby, but we never had the baby was never so bad so for us to institute ECMO. And for those of you who've been managing COVID patients, it is a whole different ballgame managing these patients with the PPE and assessing all those parameters through the PPE. It is a different world altogether. But yes, ECMO was always an option. But we never got about to the point that we could institute ECMO for this patient. The biggest hurdle which we had managing this patient was managing this patient in not home ground environment. And that's the reason we lost the baby. Thank you.
The next is a case series from Madras Medical Mission.
My name is Dr. Justin. Along with Dr. Anvarasu, we will be presenting about our early outcomes of COVID recovered patients undergoing cardiac surgery, also with an interesting case presentation. Cardiac surgery in COVID-19 recovered patients has become challenging because of the various complications associated with the novel coronavirus disease. Patients with cardiovascular diseases, diabetes, and hypertension have been noticed to have increased morbidity and mortality. COVID-19 pandemic has caused devastating outcomes all over the world, producing multiple ailments, and most of its outcomes are not well established. Planning and performing cardiac surgeries and the immediate postoperative cardiac and respiratory care remains challenging. So we analyzed all COVID-19 recovered patients who underwent surgery in an institution between June 2020 to 21. Among these, 110 patients who recovered from COVID-19 infection underwent various cardiac surgical procedures in our institution. These are the preoperative variables. The mean age of the patient was around 57 years and almost 86% of the population was male sex. Diabetes and hypertension were the predominant comorbidities in this population. 8 patients had preoperative ICU admission and 1 patient had preoperative intubation. These are the patient status at the time of COVID-19 infection. Almost 87% of the population who had COVID-19 infection was diagnosed by using RT-PCR test. Among this, 10% of the population who had RT-PCR negative status and on subsequent evaluation with the CT chest, they found to have Coraz 5 in the CT chest scanning, and further they have grouped into the COVID-19 infection and managed accordingly. Almost 7.2% of the population were asymptomatic entirely during the infection process. Among this, 39 patients were hospitalized during the COVID-19 infection, and among these 39 patients, 27 patients required oxygen mask during hospitalization, 5 required HFNC or NAV during hospitalization, and 1 required intubation during the admission for COVID. The average duration between the recovery from COVID infection and surgery is 5 weeks. Almost 18% of the population had cardiac symptoms prior to COVID infection, and majority of the population developed cardiac symptoms or diagnosed with cardiac disease after COVID infection. 12 patients was diagnosed to have COVID infection at the time of diagnosis or evaluation for cardiac status. Among the 20 patients who had cardiac symptoms prior to COVID infection, gradually worsened from class 2 to class 3 dyspnea. The other preoperative variables, almost majority of the patients, around 88%, had IgG positive status prior to surgery. IgG and IgM was positive in almost 30% of the population. Around 11% of the population had not undergone IgG or IgM testing status. Almost 15% of the population had mild right ventricular dysfunction, and 5 patients had moderate right ventricular dysfunction. 24 patients had mild left ventricular dysfunction, 33 had moderate, and 15 had severe left ventricular dysfunction. Our initial assessment, we had a COVID team approach, and all COVID recovered patients who were planned for cardiac surgeries were preoperatively assessed and educated by a team of cardiac surgeons, cardiologists, pulmonologists, cardiac anesthetist, intensivist, and infectious disease control physician, microbiologist, physiotherapist, and a good nursing team. RT-PCR for COVID-19, high resolution CT, and IgG and IgM levels for COVID-19 were included in the initial evaluation. Our management strategy involved preoperatively, patients were taught intensive spirometries and good breathing exercises. Nebulizations were started prior to admissions. Intraoperatively, just prior to induction, a dose of methylprednisolone 0.8 mg per kg per dose was given and continued twice daily for 48 hours. This was followed initially and it was later discontinued. Steroids were later used selectively in patients who had low PO2 levels and chest signs such as wheeze. A low dose antiplatelet was given once the patient reaches ICU and kept on anticoagulation for a minimum of 3 days after the shifting out of ICU. Blood and blood products were transfused very judiciously. Our results, among 110 patients, there were 3 in-hospital mortality. Among this, the first patient who had Euro score of 7.4 was intubated prior to surgery due to refractory pulmonary edema and had severe mitral regurgitation for which mitral valve replacement was performed. Patient had a STOMI postoperative course requiring re-intubation and tracheostomy and prone ventilation. This patient was diagnosed to have all these, he developed all these symptoms prior to during the early phases of COVID infection. So this patient, after development of symptoms and due to his poor lung status, he was retrospectively evaluated and the IgG and IgM levels were found to be strongly elevated, suggesting of COVID-19 infection, and he died of post-COVID sequelae, respiratory failure. The next 2 patients, one underwent redo CABG with mitral valve replacement and third patient underwent CABG with mitral valve repair. Both died due to low cardiac output and not because of COVID-19 sequelae. 5 patients who had preoperative normal right ventricular function developed mild right ventricular dysfunction and 1 developed moderate right ventricular dysfunction. 2 patients expired due to severe biventricular dysfunction. 3 patients who had preoperative mild right ventricular dysfunction had normal postoperative right ventricular function. Various surgeries were performed during these patients. Among this, predominant was coronary artery bypass grafting, which included 80% of the total surgery group. Among this, 64 patients underwent on-pump surgery and 25 patients underwent off-pump surgery. Isolated valve repair or replacement was done in almost 10% of the population. 1 patient underwent redo CABG, 1 underwent redo CABG with mitral valve replacement, and combined procedures CABG with mitral valve repair replacement was done in 4 patients. redo valve replacement was done in 2 patients, and Bental's procedure was done in 1 patient. Majority of the surgeries were elective surgeries, and 6 had emergency surgeries. The average duration of the surgery was 4 hours and 20 minutes. Extubation time. In patients who recovered from COVID, our protocol was to extubate the patient as early as possible. Almost majority of the patients were extubated within first day of surgery, and almost 50% of the population were extubated within 10 to 15 hours of surgery. But 2 patients required re-exploration for bleeding. The transfusion, we limited transfusion as much as possible. 40% of the population does not require any transfusion, and even in patients who require transfusion, less than or equal to only 2 blood products were given, and more than 4 products were given only in 4 patients. 2 patients had no neurological complication. Re-intubation was required in 3 patients. The use of NIV was predominantly higher, and almost 20% of the population required NIV. 3 patients developed sepsis requiring higher antibiotics. Postoperative right ventricular dysfunction, mild right ventricular dysfunction was noted in 17% of the population. Moderate right ventricular dysfunction was noted in 4.5% population, and severe right ventricular dysfunction was noted in 2 patients. We would like to present an interesting case who had neurological complication with COVID. He was diabetic, hypertensive. He presented to our ER for further management. His ECG showed changes suggestive of ankylosing ischemia. His echocardiogram showed moderate left ventricular dysfunction and mild right ventricular dysfunction. Chest X-ray had increased bronchosvastular markings. Coronary angiogram revealed triple vessel disease, and he was planned for early CABG in view of his critical lesions. He underwent CABG and shifted to ICU. He was extubated on the first postoperative day. He had an uneventful ICU stay. Was shifted to ward on 3rd postoperative day. Patient developed difficulty in walking, increased weakness of both lower limbs on 5th POD. Neurologist opinion was taken, and they suggested a nerve conduction study. Nerve conduction test showed lower limb nerves were not stimulatable, and other nerves showed severe demyelination with absent effect in all the nerves. Hence, a diagnosis of post-COVID acute demyelinating polyradiculopathy was made. He was treated with IV immunoglobulins, and he gradually recovered. And on follow-up, he is doing well. The cardiovascular manifestations of the COVID-19 include transient and chronic myocardial dysfunction, cardiac arrhythmias, cardiogenic shock, and vascular thrombosis. Patients who recover from COVID-19 infection may have myocardial inflammation, myocardial edema, myocardial fibrosis, and right ventricular dysfunction. It is attributed that microthrombi in the pulmonary vascular system leading to a cascade of inflammatory marker release and exaggerated immune response. This can be postulated as first hit and second hit hypothesis. Inflammatory markers were well pronounced in COVID-19 patients, thereby calling it as the state of first state, which tends to exaggerate following cardiac surgery due to mechanical ventilation, infection, stasis, thrombosis, bleeding, ischemia, hypoxia, blood transfusions, and transfusion-related lung injury, and apart from it, cardiopulmonary bypass, which are the second hits, especially in the convalescent patients, leading to exaggerated immune inflammatory response, ending up with multi-organ dysfunction syndromes. So to conclude, considering above all these risk factors, patients who have having increased risk factors may be channeled for off-pump surgeries or percutaneous interventions or deferring surgery to a later date. In our patients, we preferred off-pump surgeries whenever feasible, so that to limit transfusions, to limit cardiopulmonary bypass, and to reduce inflammatory response. We limit transfusions and prefer autologous transfusions when feasible, use of steroids, early extubation and ambulation, use of non-invasive ventilation, strict asepsis, and aggressive chest physiotherapy. We conclude that cardiac surgery can be performed safely in every COVID-19 recovered patients. Although there is increased morbidity and mortality, preoperative team analysis of the patients planned for surgery, deferring elective surgeries, and even in emergencies, meticulous care will always prevent catastrophic events. Thank you.
Thanks to all the speakers. Can I get the panelists on board, please? I would like to invite Dr. Krishna Manohar, Dr. Varghese, Dr. Hiramat, Dr. Ravindra Shetty, Dr. Subramaniam and Dr. Ganpati to the panel. Before we start our discussion on COVID, there are a couple of questions related to the cardiac surgery aspect of the cases discussed. I think one question is for Dhairashil on why there was an endo leak. If you want to take it now, it will be better we finish it before we want.
Yeah, the thing is, when we saw the CT itself showed a bit longer linear tear. So, and when the measurements were taken, the 15 centimeter Thoraflex hybrid graft, we thought that we could cover it. But after completing the procedure, we had it in our mind that there is a possibility that we would just miss that lower part a bit. So we had preoperatively only planned that after completing the procedure, we'll assess on transesophageal echocardiography that if there is any leak, that we will have to do a TVAR to cover that part. So because of that the longer linear tear, we just could not cover that lower part of the tear. So that is why there was an endo leak.
Seems to have been a difficult case even in a non-COVID setup, but complicated by COVID as well, I guess. The next one in the chat forum is I think, directed to Simran. Simran, they want to know about the antiarrhythmics that you've used in the ICU and why it had to be used. Can you give some clarification on that?
Soumya, hi, I lost you there. Can you just repeat the question, please?
So in the chat box, Simran, there's some question on why adenosine was started and was the child on amiodarone. Some question on antiarrhythmics for the child.
We didn't start the child on adenosine. We gave the child 2 doses of adenosine, and the child seemed to settle with adenosine. He didn't require amiodarone for the arrhythmia.
Okay. If any of the panelists have anything to add to the cases discussed in the cardiac surgery perspective or the vascular surgery perspective, before we go on to discuss COVID, anything? I just want to share my screen at this point and then go to a small presentation that we have on some data that we have collected over the past 2 days. Pertaining to COVID and how each unit is trying to manage the COVID patients they're getting. So one situation or one particular case scenario seems to be different. What is different from the first year of COVID and the second year of COVID is that most units now have come to a pre-admission policy on testing patients with RT-PCR or TrueNat or a CT scan. And then they seem to be having a policy of delaying surgery for 4 to 12 weeks. And if it, particularly in pediatric units, there seems to be a policy of both checking patients and or the child plus the parent to see if any of the caregivers are also positive. So we got some data from some hospitals, just 3 or 4, nothing to overwhelm all of you. So cases done range from 100 to, in Sree Chitra, 1,000 cases. And we found varying numbers like 20, 15, 10, 15, all cases, they have been postponed because of COVID. And we have also had a unique situation where the patients have been asymptomatic pertaining to COVID-related symptoms, or their post-cardiac surgery course has been uneventful, but in the late post-operative course or after discharge, they have come back with some issues. So in this context, I would like to get Dr. Varghese to share some opinion on what he feels is his experience. Sir, can you unmute?
Am I audible?
Yeah, yes, sir.
Okay. Yeah, actually, the corona has totally changed the scene in the initial months, I think. Busy units suddenly sitting idle for months. Most of the units are operating only on emergencies. And the concerns were the safety of the patient and the safety of the system, the caregivers. Initial days, we were operating only with one RT-PCR pre-operatively. had the impact on our system also. We lost one patient immediate after the surgery. Patient was not saturating, turned out COVID positive. And we had multiple close downs in between. Whenever the patient turns positive, immediate post-op or something like that. So we are losing actually the cost to run the unit. We could not generate from the surgery. For months we are sitting idle. Now what we do is we do a 2-test policy. 2 days before surgery, we do an RT-PCR, and after admission we again have an RT-PCR. And whenever there is a saturation drop, we do a CT scan. So now for the last 6 months, actually we are having the same number as in the pre-COVID era. So I think a diagnosis of COVID positive preoperatively can reduce the mortality very much. And I have a question to the third person there who was having from the Madras Medical Mission. They were telling about the situations. If in the COVID recovered patient, the result is same as the non-COVID patients, or is it different? Some studies are there that in COVID positive, if there is a diagnosis in the pre-surgery pre-period itself, actually the mortality and the morbidity is the same. So to have a diagnosis of COVID preoperatively is as good as operating on a non-COVID patient. That is what some studies say. So whether they have any comparison with the non-COVID and the COVID recovered patients like that, they can enlighten us later. You can continue, Soumya.
I think we'll take the question now. Either Dr. Jepsin or Dr. Anbars who can give some thoughts right away.
Dr. Soumya Anbarsu here.
Yeah. Hi, sir.
See this with the COVID scenario, the whole way we practice changed the last couple of years. When the first wave came in, everybody was scared, and we had no clue of how to manage patients when they become COVID positive, or whom to take in, whom to reject at all. So the whole way of dealing patients in an acute MI situation changed. The cardiologist stopped doing any primary PCI. All patients who came with MI were thrombolized, even in our institution. What we noticed that at the end of the first wave, when patients started coming back for surgery, a lot of them had significant moderate or severe LV dysfunction. On an average, before the COVID era, we used to have 2/3 of our patients who used to have good LV or mild LV dysfunction. And because we are a tertiary cardiac referral center, 1/3 of our patients will be severe LV dysfunction or moderate LV dysfunction, or combined procedures like severe LV dysfunction with moderately severe mitral regurgitation, where we have to do a little more high-risk procedure. With the onset of COVID, at the end of the first wave, when patients started coming back, a significant number of them became, what we noticed were with the moderate LV dysfunction or even severe LV dysfunction, the ones who are straightforward, the ones who have a good LV and or a mild LV dysfunction became the minority, and the severe LVs became a majority. Even now, as a policy, MMM has not started doing primary PCI without a COVID test. There are maybe a few centers, smaller centers doing, but MMM, we still don't do a primary PCI without RT-PCR. The earliest we can get an RT-PCR is about 4 hours from the time we take a sample. So there was a question on what is the protocol for emergency surgeries. Honestly, we are not doing emergency surgeries. We postpone the surgery till we get the COVID result, and we have not come across a situation where we have to do a middle of the night surgery who is either COVID positive or without a COVID status being unknown. That's the situation now. I believe with the aggressive vaccination, things should improve. And once the primary PCI program picks up, we should be able to do emergency surgeries in the middle of the night. Sometimes you have a dissection patient, and we may have to go out early. And as long as the patient is not overtly symptomatic with COVID, I think the future scenario is that we will get back to normal at least within a year or so.
Sir, can I ask you one question?
Yeah, please.
What about stroke rates? Post-operatively, have you seen any patient developing stroke? Because one of my patient who was post-COVID, we had operated on day 24th, and he was a CABG went 25% ejection fraction, went off very well, beating heart straight away. On day 4, post-operatively, he suddenly became blind. I have never seen anyone losing vision in that way. That only thing was he had become blind. We did a CT which showed a basilar artery region was hypoperfused. Luckily, after a neurologist, when he saw, he said that they had seen many patients of post-COVID status developing these type of strokes. So they managed the patient, and luckily on day 5, after that, he gained his vision. So, but have you seen any incidences like this?
No, except for the one single case we presented where with acute demyelinating reticulopathy, we've not come across very exaggerated high risk of neurological complication in this last 1.5 years with the post-COVID era. I think we've not done a detailed analysis of the comparison of our COVID and pre-COVID neurological recovery. But by an eagle's eye view, I don't think we have significant increased neurological incidence with the COVID era.
Would Dr. Ravindra Shetty want to add something on his experience or unit experience in this?
I'm Ravindra Shetty. I'm from Narayan Udyala in Bangalore. In the last 1.5 years, we have had a fair share of COVID patients. Pre-op, of course, we have a very rigid workup protocol which we strictly follow. And then when they're all negative, we take them up for surgery. And we have had fair share of patients in the last 1.5 years, post-op, after 4 days, 5 days, in the ICU or in the ward developing COVID. We have had a fair share of our mortality. Regarding strokes, we have not seen much strokes. I think it is because of the patients getting heparin, getting low molecular weight heparin post-op, or if there's a valve patient is getting oral anticoagulation in the form of acetylfoam or warfarin. So this sort of stroke we have not seen, but we have seen lungs getting wiped off, and that causing a lot of problem and causing hypoxia, requiring reintubation, ECMO, prone ventilation, and we have lost some patients also. I think this disease, we have now started to learn how it manifests, how it progresses, and how to treat it. So I think we should be all right in the next few months. Now with vaccination going on, I think we should be all right. But we have to be guarded. We have to strictly evaluate our patients, make sure that they are safe when we take them up for surgery. And that what we do is we do a CT scan of the chest 48 hours before surgery. After admission, 48 hours before surgery, we do a CT chest, make sure it is seen by a cardiac radiologist, and make sure that they are fine. And that is our very important test which we do before we take them to theatre. But in spite of all this, we have seen some patients ending up with trouble post-operatively. But you know, that's how the pandemic is. We just need to face it. We need to be careful and also bold. This is my take on the COVID pandemic.
Can I just ask a question, Dr. Simran, with you? I mean, Dr. Soumya, with your permission?
Yes, sir. Please, sir.
Now, I'm presenting a hypothetical scenario where a child, neonate, not neonate, I mean an infant, comes with a cyanotic spell, tetralogy of Fallot. After admission, gets
Dr. Jagannath, I seem to have lost you there, sir.
Tetralogy of Fallot.
Hello.
7 or 8 months.
Hello.
You hear? Can you hear? Hello.
You are audible, but in between some voice is lost. In between there is some loss.
Okay, so tetralogy of Fallot, 7 or 8 month old child who comes with a severe cyanotic spell, tests positive in the ICU. What is going to be our protocol of management?
We have the data from Sanjeevani. We have operated children in spell. So Subramanian will present it when Soumya agrees.
Yeah, sir.
I was trying the adult data first and then come to the pediatric. So if you could just give us some, we'll discuss. If you want to take that now, I think we can go to the pediatric in a while, if that is all right.
Sure. I'm sorry, I seem to have lost you guys there. Can Dr. Jagannath please repeat the question?
It was about tetralogy of Fallot in spell, and we have kind of decided we'll discuss all pediatric cases
Fair enough.
in a short while. Yeah.
Fair enough.
Well, to Dr. Shetty, I wanted to ask one more question because they have a good number of series of post-COVID surgeries. A patient who post-operatively have developed COVID. The patient which I had mentioned, that I had one CABG case who similar to this frozen elephant trunk patient who had a stercoral ulcer and a rectal bleed. The same situation I had seen in one more patient. Actually, rectum is has a very good blood supply. So generally, routine cases, we have never seen any patient developing a stercoral ulcer and a rectal bleed. Whatever constipation patient develops in our routine CABG cases, but post-COVID, if the patient has COVID, this is our second patient. So has anyone else seen something similar? Any stercoral ulceration and a bleed?
I'm Dr. Ravindra Sethi here. We have not seen any similar situation in the rectum. Majority, or I should say, all our cases were purely lung issues. And that causing, of course, an effect on the heart, and then we losing that. Or they're having a long-term stay in the ICU. So we have not seen any rectal ulcer and rectal bleed.
So may I come in for that question, Darshil?
Yeah.
Hi, Darshil. So like we had two patients with COVID. One was a TAPVC and one was a AV canal. The child with the TAPVC, he actually presented with the PA crisis and a bleed through the ET. And we were surprised because very rarely do we see ET bleeds in PH situation, and that's when we tested the child for RT-PCR, which was positive. So yeah, maybe they're related.
So I'm just going to be sharing some more data that we have regarding in-hospital management of patients who turn COVID positive during the hospital stay. So for this couple of slides that I'm going to be presenting, I want to thank Dr. George and Dr. Praveen Verma and that entire group from Amrita, and also the IJCTS for letting us share some data from their preprint version of this article that's going to come up soon. So this is a study performed in the first half of 2020, last year, not this year, last year. And this is on the early outcomes of cardiac surgical patients who developed COVID infection. So there were 63 centers in this multicentric study with 330 patients. They have reported in-hospital resuscitations, re-explorations, major adverse events, all amounting to around 20%. In-hospital mortality of 14%. Majority of their patients have had uneventful recovery. And 30-day readmission rates number is 47. And also 30-day mortality rate is somewhere around 24. So I think if this current strategy of pre-testing and then operating on patients doesn't exist in this year of COVID as well, we would also be looking at similar numbers in this year. So the causes of mortality they have found was respiratory, multi-organ dysfunction, cardiac and cardiac surgery related causes were only 5.97%, and there were no cases of ECMO in that first year or the first few months of the study. Now that brings us to the next topic on how are we managing these patients in the post-operative period. This again is a very small survey. We didn't have a very great response or elaborate response, and we didn't have so much of time for data collection as well. So the first question that we tried asking was, what is the diagnostic investigation you're performing in a unit to find out if somebody is COVID positive? You suspect your patient is COVID positive, so what test are you doing? So is it an antibody or an antigen or CT scan or others? So from what I understand is most pediatric units are still doing RT-PCR and adult units are doing CT scan. It's like I said, there is no conclusion, but fairly the numbers tend to predict that. Going on to prognostic investigation. So how many units really do prognostic investigations, and what are the investigations they prefer? So in that category, we have some hematological parameters. What is prescribed is leukocytosis, leukopenia, thrombocytopenia, then inflammatory markers like PCT, CRP, ferritin, then coagulation parameters. So what I have been able to conclude is most units take a mix and match what is available in the unit and what is available in the institution, and then try to streamline management with that. And when asked which of the investigations they found useful, most people found a D-dimer in CRP to be a useful prognostic indicator. Like again, the numbers are so small we cannot conclude, but this is just a trend pattern of what was being followed in many centers during this time. And how has the in-hospital course been? It has been either like moderate or severely symptomatic patients. The cardiac symptoms have worsened because of COVID. And there has been, I think, 2 deaths, and many patients have been discharged without issues. So in this context is where I would like to get Dr. Subramaniam and Dr. Krishna Manohar sir to share their experience from Satyasai Sanjeevani. One would be an anesthetist perspective of how to manage patients, and also a perspective on how to manage pediatric cases during this phase.
So very interesting. I think as a cardiac surgeons, we should go back in the history. And when open heart surgery started, there was a 200% mortality risk. What is that? Controlled cross circulation. So COVID came. COVID has also caused 200% mortality, 100% for the patient, and 100% for which of the team member, not the surgeon. The surgeon is absolutely not risky. You take a patient suspected or having COVID to the theater, the only person who is maximum risk is my colleague. Your anesthesia intensive care. We have no risk. No, I don't think any surgeon takes any risk. So he's a person who successfully managed during first wave and second wave. All our experience, thanks to Subramaniam, he will talk about it.
Thank you, sir. Thank you, Dr. Soumya, Dr. Shabari, for giving me an opportunity to elaborate on basically our experience about COVID. So I have a small presentation about how we managed COVID in the last 2 months. With your permission, may I go ahead with it?
Yes, sir, sure, sir, sure.
Yeah. So see, it was during the second wave of COVID, that is from the month of April to June 2021, when our center was recognized as a dedicated COVID care center for pediatrics. For all those, for whom Satyasai Sanjeevani is something new, see, it's a center which is dedicated to pediatric cardiac sciences. So we deal only with children. So the government here had actually recognized us as a tertiary care center for managing pediatric COVID cases. So we started admitting COVID positive patients in our hospital. And during this time frame, we had we had operated on 220 CHD cases from the month of April to June 2021. And we had encountered 30 positive patients, COVID positive patients. Now of whom we operated on 4 COVID positive patients in the same sitting. The rest of the 26 patients were discharged based on the fact that their heart diseases weren't that critical. So we decided that we will treat them for COVID, we send them home, and then maybe, as everybody pointed out, because the concerns with operating a COVID positive child is, one is a COVID infection causing worsening of the respiratory status, or post-COVID MISC is another big risk. So we decided that we will call them after 4 weeks. But these 4 positive children actually were not in a position to be discharged. They had to be entertained in the same sitting. So the basic protocol that we followed was, we had an objective, screening. Basically, it was a questionnaire screening based on epidemiological and symptomatology. And whoever was symptomatic, we decided we are not going to entertain them. Now, whoever was asymptomatic, we subject them to a COVID rapid antigen test, the results of which we get within a span of 5 to 10 minutes. Now, when the COVID antigen test was negative, patients not symptomatic, we assume that they are COVID negative, and then we move them to the surgical department. So when the antigen test was positive, though they were, some of them were asymptomatic, we put them in the COVID care facility. We continue to treat them, and we repeat a COVID antigen test after 72 hours. If they are not symptomatic, we just put them there for observation and repeat a test after 72 hours. Whereas any symptomatic patient undergoes a CRP as well. Now, CRP is an inflammatory marker which we went with during this particular COVID, the pandemic, this second wave of COVID. Now, all these 4 patients had marginal elevations of CRP. So we labeled them as mild COVID disease. None of them had bad saturations to say that they were moderate or severe disease. They were all the 4 patients, among the 4 patients, 3 of them were tetralogies, though their saturations were low, but they were similar to their baseline values. They were not very bad. Their saturations never deteriorated to that extent to say that COVID had really caused a fall in the saturation. So, but then they had marginal elevations of CRP. So we decided to retain these 4 patients in the COVID care facility. And as Dr. Jagannath had pointed out, all the 3 patients were incessantly spelling. They were on maximal beta blockade as per our cardiologist, expert opinion, and they required frequent intravenous beta blockers for their spells. So that was when we decided that we cannot really discharge them. We have to wait for them to become COVID negative. And once they became COVID negative, CRP negative, asymptomatic for 72 hours, they were shifted to the surgical facility and they were operated in the same setting. Amongst the 4, 1 child had to be taken up for surgery the very next day after he became COVID negative. The other 3 children were operated within a span of 3 or 4 days. Now, one of these kids had a very high CRP. That was actually not a tetralogy patient, one of the COVID positive patients. It was a ventricular septal defect. So when the CRP was more than 10, and he continued to have fever for a longer duration. So we decided to go for the tier 2 investigations, which included a D-dimer and a serum ferritin. So we basically went with D-dimer and serum ferritin when CRP levels were very high, and symptoms, were more or less consistent with moderate to severe disease. Now, these were the data of all the 4 positive children. 3 of them had tetralogy of Fallot. 1 was a ventricular septal defect. Now, this particular child, we decided to entertain him because this fellow was 6. He was actually 7 months old, but he was weighing only 2.7 kilos. So he has severe failure to thrive, and every time he goes home, he develops a pneumonia. So we decided that this time we are going to have him in hospital, wait for him to become negative, and then take him up in the same setting. Now, most of these, we took them up for all the 3 tetralogy children underwent intracardiac repair, uneventful. Post-operative course was as normal as that of any tetralogy child. In fact, we were surprised to see that these children sailed through without any events. The average duration of ventilation was hardly, 4 to 6 hours. Now, there was one child whom I would want to bring about in this discussion. This was a case who developed COVID in the post-operative period.
Now, this was a 1-year-old male child who presented to us with obstructed cardiac TAPVC. Child. Now, this was a spray of X-ray. We did a COVID antigen test. COVID antigen was negative.
Dr. Ravindra Shetty, kindly unmute yourself. Dr. Ravindra Shetty, please mute yourself.
Yeah.
Thank you so much.
Yeah. So the antigen test preoperatively was negative. This child was taken up for surgery, underwent a modified Schumacher and Tucker's repair. Post-op echo, well-flowing pulmonary confluence. All pulmonary veins were draining into LA without any issues. Good biventricular function. There was some amount of moderate TR consistent with PAH. Now, POD3, the child developed fever. We antibiotics were escalated to meropenem because the counts had gone up to 24,000, and we sent a blood culture and then we escalate the antibiotics. Now, with under antibiotic coverage, this particular child was extubated, but then within 24 hours, his chest X-ray was something like this. He developed pulmonary edema. It was frank blood in the ET. He got re-intubated. We put him on HFO ventilation. Echo was consistent with PAH. Echo never had any issues with the left ventricle. Intermittently we put him prone and HFO and prone ventilation alternately. On POD11, the interstitial infiltrates never seemed to regress. In fact, they went up. We decided to repeat a COVID antigen test, and to our surprise, it turned out to be positive. This time, the RT-PCR also was done as a confirmatory test that was again positive. A CRP had shot up to 85. Now, I would like to emphasize the importance of these inflammatory markers post-cardiac surgery. Now, any cardiac surgical patient in the post-operative period is going to have an elevation of CRP, D-dimer, and serum ferritin. These are all non-specific markers, so you cannot say that these are all specific to COVID. But then amongst the three, I would rather say CRP and serum ferritin tends to peak by 4th or 5th day following surgery. And then after that, it starts declining. Now, our particular patient on POD9 actually had a serum ferritin of more than 1,000, which probably is explained by the COVID positive status. Amongst these, D-dimer is the least specific for actually COVID, because D-dimer tends to become positive following cardiac surgery, particularly following adult surgeries like OPCAP. They sometimes tend to remain elevated for 3 months following OPCAP also. So, going by D-dimer is not very, not a very wise way of assessing the inflammatory stage of COVID. So POD 11 to 15, you can see the X-ray started improving a little bit. The lung compliance was better on ventilation. We could wean him off HFO. We put him on conventional ventilation. The inflammatory markers started showing a declining trend. All the three started coming down. So we put him on remdesivir, we put him on heparin infusions, steroids, and multivitamins. Tocilizumab was considered, but the child never had any issues of any multi-organ dysfunction. In view of preserved organ functions, we deferred using tocilizumab. POD 12 to 19, the child was managed on HFO. Gradually, gas exchanges was maintained. It was preserved. PO2 started improving. Lung compliance completely improved. And this was the X-ray on POD 20 when almost, I would rather say that the lung mechanics had improved considerably. But then all of a sudden, his PO2 started dropping down a lot. Persistent hypoxemia, we had no explanation. POD 20, he had a sudden deterioration of saturation and raise in PCO2. Chest X-ray had, in fact, showed better clearance of lung fields, but most likely we assume that it could be a diffusion impairment, because COVID is known to cause problems with diffusion capacity in the lung. A recent study which has been published has come out with data of 88 patients, a 1-year follow-up of 88 moderate to severe COVID patients who were not ventilated, but who were hospitalized and given oxygen therapy. At the end of 6 months, almost 50% of the 88 patients had 33% reduction in the diffusion capacity of oxygen. So this is probably, the other possibility is this being a TAPVC child, the child would have developed thromboembolic phenomena in the, the
distal pulmonary arteries, and that could have actually caused impaired perfusion also. Because we felt probably the lung was becoming better, and we realized that we are going to get the child back, but suddenly the child deteriorated and he died. So the other child whom we encountered a COVID positive status in the post-operative period was a 1 year, 11-month-old child, 7 kg child. He was again a tetralogy of fallow. Surgery was uneventful. Post-operative echo was fine. Actually, we had a mild RVOT gradient, but then the child was doing well. The child was shifted to ward on POD10. He developed mild constitutional symptoms. The father developed some fever, and that was when we decided to screen the father. The father turned to be positive. Immediately we tested the child. The child was also positive. So fortunately, the child never had any issues. The child was treated as mild COVID illness, and he recovered without much issues. So a wait for termination of COVID-19 pandemic is unjustifiable in select cases. As Dr. Jagannath had pointed out, a spelling child, we are definitely going to lose the child if we don't address this particular child. So a wait will render most of these patients inoperable or succumb to the primary illness of congenital heart disease. So with whatever experience we have, we are confident that we can conduct surgery safely on children with critical heart disease. If they have had mild COVID illness or asymptomatic COVID illness, we need not really wait for weeks to isolate these children. Because there is no clear-cut guideline as to there is a benefit in giving this long wait. We have decided to take up these patients based on our experience. But definitely, as Dr. Simran had pointed out, post-op COVID is a very difficult entity to treat, because most of us don't know as to how these children are really going to behave. It's just not about respiratory illness alone. It's a hypercoagulable state. These children, sailing through safely is something which is unpredictable. Thank you.
In the interest of time, I think we'll have to take the questions after Hiramat sir's talk in the next session. Thank you all for joining and making this a very interesting session.
Thank you.
We'll move straight away to the next. And I request Dr. Shiva Muthukumar to take over the session, and we'll start the session. Yeah. Dr. Shiva, you need to unmute yourself.
Shabari, can you hear me?
Yeah, you're audible.
Yeah. Good afternoon, everyone. And thank you, Shabari, Vivek, and Sree Chitra team for this opportunity. After a fantastic academic feast for the last couple of days, and we enter the final session of the Technocollege, IACT's Technocollege. We have two eminent speakers, Dr. Hiramat, our young dynamic secretary, head of the Department of Cardiovascular Surgery at Sathya Sai Medical College Higher Institute, and Dr. Lokeshwar Sajja, our junior vice president, senior consultant and director of research at Star Hospitals, Hyderabad. So we'll invite Dr. Hiramat for his talk on protocols for COVID patients in adult and pediatric cardiac surgery. Please, sir.
Good afternoon, dear colleagues. At the outset, let me thank Dr. Sabrinath Menon for giving me this opportunity to speak on protocols for cardiac surgical patients in COVID-19 era at the IACTS Technocollege CME conducted at Thiruvananthapuram. I would like to thank Dr. M.S. Valiyathan for sharing me this photograph, wherein he was doing behind inventing the Technocollege building at Sree Chitra Institute, Thiruvananthapuram. On behalf of IACTS, I welcome you all to Thiruvananthapuram. There are no conflicts of interest. It is challenging to sum up the learning curve of 20 months in just 20 minutes. Let me describe how do I go about in the next 20 minutes. It's mainly on case selection and triaging, surgical considerations, perioperative management, and controversies. Coming to the overview, cardiac and terminally ill patients have taken a hit in these times. The cause of the hit are mainly helplessness of the system, the stunned phenomenon, ignorance of how and what to do to resume clinical practice, misinformation myths in the society. We continue to explore the glass elephant in the dark room. Let's learn to live with the disease in our attempt to save lives. Coming to the reality of the problem, as we see, there are more than 7,000 plus guidelines on PubMed today on COVID-19 and more than 28 articles of COVID in our Indian Journal of Cardiothoracic and Vascular Surgery. Coming to the overview of burden of COVID-19 across the globe and in India. As we see this graph, it clearly depicts that the overall incidence and the mortality is lower in India compared to other countries. Yes, except in the month of April, May 2021 and early part of June, where we definitely had gone up with our numbers. Coming to the census, according to the Commissioner of Minister of Health and Family Welfare, the number of births in India in 2019 were 2.48 crores. Number of deaths were around 76 lakhs. And according to the community medicine statistics, we had around 2.4 lakh and 27.2 lakhs of congenital heart diseases and adult heart diseases. Expected deaths in adult heart disease were around 15,200. And the lethality of critical congenital heart disease were around 1.5 lakhs. The expected mortality from coronary artery disease is around 3 lakhs. Although data of 2020 is not yet out, the congenital heart disease rates for 2020 is sure to go up as couples were forced to remain at home. Unfortunately, hospitals and scanning centers closing down meant fewer avenues for children with congenital heart disease. Coming to case selection in preoperative testing, there is a difference in opinion concerning preoperative testing in the forms of RT-PCR or the rapid antigen test. Our society's guidelines specify preoperative testing in all patients before admission, either it's emergency or elective. Guidelines abroad prioritize testing based on exposure, geography, and pre-test probability. Noting that a majority of our nation's cardiac centers are in tier 1 and 2 cities, we know that patients and relatives utilize public transport and have to tide through high volume areas in order to make it to our centers. Hence, we recommend testing for all patients and accompanying relatives. However, in acute emergencies, if the antigen status is unknown, we recommend the following. Patient to be taken up for routine preoperative testing in the same zone. Patient sampling to be done before admission procedure. Accompanying relative, one allowed, is tested and isolated in the COVID ward. All personnel in COVID designated zones are mandated to be donned by level 2 PPE or even higher. And all patient hospital personnel involved to wear N95 mask. Newborns are isolated from their mothers to avoid the risk of transmission until the mother is RT-PCR negative. Define patients for seriousness based on underlying cause, categorize them as emergent, intermediate, urgent, and low priority to manage natural history and associated morbidity and mortality. It is essential to build a triaging system to contain and maintain profiling of patients. We have case presenting either related to emergency, and in emergencies, whether they are stable hemodynamically or unstable in hemodynamics has to be considered. As we all know, in adult heart diseases, we have the coronaries, whether acute coronary syndrome or left main or acute MI with T of less than 30% or PCA complications has to be addressed. Similarly, with aortic cases, whether aortic aneurysms or dissections or valve-related endocarditis, stuck valve or refractory heart failure has to be addressed immediately. As we all know, the various emergency conditions of congenital heart diseases, whether it is stop with the spell or TAPVC or TGVSDs, coarctations in shock in spite of prostaglandins, hypoplastic left hearts, where BAS is unavailable, systemic to pulmonary shunt thrombosis, Al-Kappa post-medical stabilizations, valve lesions, whether it's hemodynamic collapse or compromise, and critical aortic stenosis, and endocarditis or heart blocks, or conduits, required conduits which have or having conditions wherein arrhythmia set in or RV dysfunction set in, wherein we need to intervene in emergencies. Similarly, emergency thoracic cases, whether it is esophageal tumors, perforations, or patients in sepsis, tracheal tumors, or anastomotic leak with septicemia, infections, and other complications in unstable patients due to bleeding, etc., has to be looked into. While CT thorax may be necessary for staging of any particular disease, the guidelines recommend that HRCT is not recommended in all the cases of COVID-19. Coming to pre-op and PPE protocols, we need to institute a committee comprising of surgeons, cardiologists, nursing, and administrative staff to develop unit protocols and to handle cases. Register protocols to manage triage, limit exposure, raise resources and contingents. Restrict personnel for safety of the team. In case where COVID status is unknown, all staff involved in the site of surgery ICU ward must be in PPE. This includes site of patient transportation and ancillary staff members also. Establish a multidisciplinary workflow, discuss, disseminate, and rehearse the protocols. Coming to pre-op and PPE protocols, as you see, the three levels of PPE. Level 0 is no risk, level 1 is low, level 2 is moderate risk, and level 3 is high risk. And who are the high risk candidates? The one intubating anesthesiologist, any aerosol genetic procedures, intensivists and nursing staff handling COVID positive cases. And in moderate risk, we have operating and assisting surgeons, non-intubating anesthesiologists, scrub nurse, intensivist nursing staff handling COVID negative patients. So these are the levels wherein we need to plan ourselves in order to cut down the cost for the hospital and for the patients to wear the type of PPE kit rather than wearing level 3 PPE kit in all cases. PPEs are to be used based on the risk profile of the healthcare worker. This is very important. Coming to the operation theatre layout, wherein the entry of the OT site area, the OT corridor, scrub donning supplies, operating rooms, the doffing area, shifting patients to COVID positive ICU and also which have a COVID negative ICU, and the doffing and donning area even at the ICU also. And OT corridor has to be thoroughly sanitized as we do it for an operation theatre before resuming any other activities. Few anesthesia protocols, mainly with two goals in mind. One is patient safety and protection from aerosol generation. Only anesthesia team is present for induction and intubation. Ensure minimum and essential members of the surgical team are all lines to be inserted after intubation. Maintain vigilance in movement and modulation of TE probe. Technicians to be at least 2 meters away from the table. Induction is advised in the water circle system with heat exchangers. Conduct of CT surgery has been complicated in matters of time and state of presentation, lack of clarity of COVID status in patients, risk of perioperative infections, risk of critical ill patients in the ICU, risk to clinicians and staff involved actively and passively, conduct of CPB, perioperative planning, emergencies in re-explosions. Perfusion related matters, ensure pump is set up and ready in the donning area before wheeling in. In an effort to minimize CPB tubing lengths, perfusions must be in at least in grade level 2 PP. Ensure perfusions and surgeon are familiar with each other's protocols. Ensure ABG control is in the operating suite area. Pump must be in the OR till the patient is shifted to the IC. In cases of off-pump surgeries, ensure pump is on standby in the donning area to be moved in case of emergency into the OR. Few of the nursing related matters, consider the following scenarios. Instruments inadvertently slip and fall on the floor. Additional surgical or nursing staff are required to scrub. Necessary suture material disposal falls short. Prepare and plan for scenarios to minimize human re-exposures to the theatre. Ensure that additional instrument sets are available in the OR. OR must be prepared with stock of consumables and disposables. Account of fatigue in PPE, adequate manpower must be applied. Anticipate complications and keep a second primed pump set on standby. A decontaminated pump set can be utilized for subsequent case. Ensure availability of enough blood products in the OR and in the donning zone. If the OR falls short, a call for additional products may be made for in the donning room. Use routine prophylactic antibiotic protocols in units without negative pressure OR. surgical team and to enter 30 minutes after intubation. Use cautery mist blower with caution. There are no contraindications for use of blood or blood products in positive patients. Once in the OR, finish your job, avoid returns. Emphasize on hemostasis. Wait in the OR, better to ascertain rather than to return for re-extubation. Seek your anesthetist to communicate with the outside world by phone. As you see, phones are covered in a plastic cover which has to be discarded before you leave the OR. If juniors are operating, call for help if you are stuck. If you are in trouble, control the troubling error. If you have cannulated, go on bypass. If you are unable to wean, stay on bypass. Eat enough, not less, not too much. Wear enough if you are assisting, you are likely to be in PP. Conserve your energy, do not raise your voice. Everyone is just as tensed as you are. Be a team leader. Assure your team of their capabilities. Don't belittle them. Believe in their abilities and work with them. Coming to extubation and transfer of the patient, employ routine weaning of cardiopulmonary bypass and resumption of ventilation. Only anesthetists should stay at the head end during de-airing and bagging. Avoid extubation on table in view of ERS. Why? When sick patients may require re-intubation, which increases risk again. Maintain goal to stabilize patient before extubation in the ICU. Ensure surgical assistant or resident who will wheel the patient to ICU with anesthesia team in level 3 PP. Suppose you have a death in the theatre. Leave the heat moisture exchange filters in C2. Body handles should on level 2 PPE to place body in a body bag and decontaminate bag and trolley before exiting OR. In all cases, parts of the OR complex where the patient is present transiting must be sanitized. Coming to intensive care unit, all personnel to don level 3 PPE. COVID patients to be shifted to isolation in ICU. Ensure ICU is well spaced and beds have a distance of at least 2 meters. Avoid physiotherapy, nebulization till the patient reaches the ward. ET section as and when necessary. ICD care in case of leak, change tubing, connect to wall suction with viral filter or HMEF filters. If a tracheostomy is required, ideal to do in the OR to reduce the risk of aerosol generation in the ICU in the midst of other patients. Use closed suction, double lumen cuff tube is more advantageous. Filter to be attached and cover patient with FFP3 mask. Follow anticoagulation as necessary. ACE inhibitors, ERBs are not shown to affect COVID patients. Ban visitors entry into the ICU. Use technology to provide comfort, help the patients and the dear ones. Repeat RT-PCR every 7 days. Shift patient to isolation in cardiac ward after ICU stay. Ensure sanitization of surfaces every alternate days. Involve the floor staffs and the ground staff in your decisions. Make them feel respected and involved in caring for the patients. Coming to the ICU management guide, maintain regular protocol in salvaging fluid intake and feeds. Post-extubation fluids 2 ml per kg, either normal saline or RL based on blood sugar levels and the serum sodium levels. Restrict IV fluids 1 ml per kg if low EFs or renal dysfunction or when there is suspicion of fluid overload. RT feeds all intubated patients and selected non-ventilated patients has to continue feeding. But always confirm the right tube is in position before you give your feed. And the labs, CBC, RFTs, LFTs, CRP, serum ferritin levels, D-dimer levels, lactate and blood sugars have to be done. If sugars are high, check for acidosis and ABG or do urine test for ketones. Lab regimen for ventilated and non-ventilated patients. Daily routines, as you see, it is a CBC, RFT and urea creatine electrolytes, CRPs has to be done with lactate and blood sugar levels. Once in 48 to 72 hours, repeat D-dimers, LFT, PTINR. And it can be done early if the derangement is there. ABG every 4th hourly, whenever the ventilator settings are modified. Blood sugars every 6th hourly, if on rapid infusions. Chest X-ray once in 3 days, blood and sputum culture as and when required. Coming to drug therapy, injection remdesivir 200 mg day 1, then 100 mg OD for 4 days, maximum 6 doses per patient. Enoxaparin is used 0.5 mg per kg OD if the D-dimer levels are less than 500. 0.5 mg per kg BD if D-dimers are between 500 to 3000 nanograms per ml. And 1 mg per kg twice a day if D-dimer is more than 3000 nanograms per ml for 15 days, followed by apixaban. Alternate to enoxaparin, we can use unfractionated heparin about 5,000 to 10,000 units subcutaneously twice a day or thrice a day can be utilized. Injection dexamethasone 0.2 mg BD, IV or methylprednisolone can be used 1 to 2 mg per kg. Injection pantoprazole 40 mg. Antibiotics piptaz and meropenem in sick cases. Injection MBI and vitamin C, zinc, vitamin D3 has to be supplemented. Tamiflu 75 mg BD for 5 days. We add doxycycline 100 mg BD for 5 days and ivermectin 12 mg HS for 3 days. This is our institute protocol, what I have spoken. Coming to mucormycosis, a new challenge. Its antifungal therapy includes injection liposomal amphotericin B, 5 to 10 mg per kg per day. With a favorable response, we can step down to posaconazole and about 5 to 7 mg per kg per dose daily. Posaconazole is recommended as a service therapy in patients who cannot receive amphotericin B. Monitor renal function test and electrolytes carefully, especially in infants. Surgical deployment in consultation if required as well. Coming to the post-operative ward, maintain a separate isolation unit for COVID-positive operated cases. Enforce strict practice of CAP, that is COVID-appropriate behavior, which is very important. Maintain adequate spacing in wards, minimum 2 meters. Isolate patients who were positive at any time during their hospital stay. Only one person to accompany the patient. Relative to undergo RT-PCR. If positive, admit and treat as the patient. COVID protocols and relative as on patient. ICG removal to be done by the surgeon in level 3 PP. All ward staff to remain in level 3 PP. Staff to be vigilant for symptoms in patients. Obtain RT-PCR on suspicion. Coming to outpatient departments, enforce strict practice of COVID appropriate behavior. Mandate temperature checks before OPD visits. Isolate operated patients from other risk. All OPD personnel making patient contact to remain in level 3 PP. Administrative staff must observe strict practices, wearing N95 and maintain a bubble. Must enter before patients and leave after patients. Cordon OPD, not more than 20 patients in a 50 square feet area. If it is a code blue, see that we ensure availability of PPE and manpower to don and address the issue. What are the pressing issues? Carrying out cardiac surgery in the present state has been cascaded by many logistical issues involving around travel of patients for follow-up, whether stage corrections or INR visits, blood donation scarcity and the fear, ambulance services for acute events, drop in human tissue donations, fear and anxiety, surgical training, employment issues and financial stability, financial viability of units in our socio-economic middle, adequate will but inadequate means. Necessary demands, operationalizing OPDs. This you see our outpatient, how we have planned in these COVID times, having the screen guard, unskilled patient setups, especially when we are doing echos as an outpatient basis. This is how we have planned with level 2 PPE. Surgical pedagogy and training for the due course of COVID has taken a beating, forcing us to look for alternatives to the dictum of each one, do one, and teach one. Academics can be supplemented by online teaching. Research can be conducted with arrangements and self-interest. However, nothing can supplement surgery. All any efforts can only aid in surgical training. Surgical training, online teaching and training, we introduced the ICT's masterclasses, founded on the principles of remote learning and sharing of experiences. Participants and faculty from over 80 nations took part, close to 620 hours of learning, viewership of over 60,000 plus, 3.7 crore viewers hours. An idea conceptualized and curated by a team of 4, our past president, Dr. Yubashi, myself, Dr. Krishna, the current president, and our research associate, Dr. Aditya Rudamani. Online teaching and training, continue with various national and international faculty during this COVID era. How can we do the knowledge transfer? Simulation and innovation in learning has no limits. A case reference from a junior colleague at Satyasai Whitefield, Dr. Sujit. During this COVID time, he came out with the innovation. I have published this here with his consent. As you see, he has used long balloons to do his anastomosis for his hand movements to be continued. It's a small video, and he has used the guitar wires to see that those balloons maintain their stability, and you make a cut at that particular areas of that vessel, thinking that this is a vessel, and do the anastomosis to continue your hands-on training even during these challenging times. And you can position yourself in all aspects of your anastomosis, whether it is an LED, Ramus, poems, or the radiographs, can be practiced during these tough times. This very CME, Technocollege CME 2021, is a testament to that purpose we collectively believe in. Hearty congratulations to Drs. Sabrinath Menon, Dr. Vivek Pillai, and Professor Jay Kumar and the entire team. More ICTS learning programs will be organized in this new normal. The ICTS Masterclass 2 for the year 2021 has already commenced from June 18th onwards. It's been conducted every Saturday at 6:30 p.m. Indian Standard Time. For more details, you can visit our website. The ICTS COVID Committee has brought out detailed guidelines on this topic with more nuances. Practice of cardiovascular thoracic surgery in the COVID-19 era. We had an ICTS COVID task force wherein we have written these guidelines. And I request everyone to read this article in detail, which is freely available on our website. Detailed, up-to-date, relevant and verified resources of COVID-19 are available here. As you visit our website, we have a separate category on COVID-19, wherein you can find all these details. Apart from this, the association has introduced member-friendly initiatives for their maximum benefit. One is the ICTS Fellowship Program for young surgeons interested in CABGs, congenital heart surgeries, minimal access cardiac surgery, and thoracic oncology. And also, the ICTS members group insurance scheme will help to secure yourselves for the safety as you are on the front lines, helping the country to win the battle against COVID-19. For more queries, you can write directly to me or call on these numbers. Well, dear friends, this too shall pass. Let us learn to survive in COVID times. Take adequate precautions and take appropriate care, that is, COVID appropriate behavior. Don't stress out. We're all in one boat. Stuff for everyone. Building a new normal collectively should be the aim. Coming together is a beginning. Keeping together is progress. Working together is success. Thank you.
Thank you, Dr. C.S. Remetson, for a fantastic lecture on protocols for COVID patients in adult and pediatric cardiac surgery. It was clear and crisp, and is going to guide all of us in our practice, right from preoperative workup to surgical precautions, operative, intraoperative, perioperative precautions, and postoperative care. Thank you for the fantastic lecture, sir. And we'll go on for the second lecture, which is on multicentric clinical trials, better late than ever. We have the most appropriate speaker, Dr. Lokeshwar Sajja, who's been pursuing clinical trials and encouraging other surgeons to take on clinical trials and be part of it. Our junior vice president, we invite you, Dr. Lokeshwar Sajja, for delivering the lecture on multicentric clinical trials.
Good afternoon, everybody. At the outset, I would like to thank the organizers of ISCPS Technocollege Cardiac CTCMB for giving me the opportunity to discuss to you on multi-centric clinical trials. The purpose of my presentation today is to infuse some enthusiasm in the younger generation of cardiothoracic surgeons to actively participate in the conduction of randomized controlled trials in cardiothoracic surgery, which is very essential for the synthesis of evidence from the data on Indian patients. A clinical trial is a research study that tests a new medical treatment or a new way of using an existing treatment to see if it will be a better way to prevent or treat a disease. The trials are said to be controlled if the effect of a treatment is measured against a comparison treatment administered over the same period of time under the similar conditions. The types of epidemiological studies are broadly classified into non-experimental or observational, experimental or interventional studies. Observational studies can be population-based or individual-based. Both these population and individual-based trials can be divided into descriptive studies and analytic studies. The analytic studies of individual-based can be divided into several groups like cross-sectional studies, case control studies, and cohort studies or follow-up studies. The experimental or interventional studies can be classified into randomized controlled trials or clinical trials, non-randomized, that is quasi-experimental, field trial, and community trials. The level of evidence varies among the different types of studies. The randomized controlled trials and the systematic reviews or meta-analysis, they have the highest level of evidence. John Last defined randomized controlled trial as an epidemiological experiment in which subjects in a population are randomly allocated into groups, usually called study and control groups, to receive and not to receive an experimental, preventive, therapeutic procedure, maneuver, or intervention. Randomized controlled trial is a study in which the subjects are randomly assigned to one or two groups, one the experimental group receiving the intervention that is being tested, and the other is a comparison group or control group receiving an alternative or conventional treatment. Randomized controlled trials are prospective studies that measure effectiveness of new intervention or treatment. Randomization reduces the bias and provides a rigorous tool to examine cause-effect relationship between the intervention and the outcome. However, the limitations of randomized controlled trials are high cost in terms of time and money, the problems with generalizability, and loss to follow-up. Multi-center trials are needed to recruit necessary number of subjects within a reasonable time frame, may assure a more representative sample of the study or target population. It enables investigators with similar interest and skills to work together on a common problem. The evidence supporting surgical procedures has traditionally been based on the observational studies. This paradigm remains true for cardiac surgery, where a significant reduction in the number of randomized controlled trials have been seen over the last 2 decades. If you look at this graph, the temporal trends in the number of published cardiac surgical studies and the number of randomized controlled trials, which shows a significant reduction in the past period, in the recent times. Studies suggest that RCT design can only be applied to less than half of the treatment questions in surgery. In addition to successful completion of an surgical RCT is complicated by several factors, including differences in the surgeon's preferences, operator expertise, limited funding, general education, and knowledge of the clinical epidemiology in the surgical community. Interventional cardiology trials also share many challenges with cardiac surgery RCTs. However, more questions in the interventional cardiology are addressed by the RCTs. Although registry studies have an important role in reflecting the real-world practice and patient heterogeneity, randomized trials are the only approach to minimize bias and hidden confounders. Most 75% of the studies are in the interventional cardiology side, and cardiac surgical sides about 25%. And most of the trials in the interventional cardiology are device related, whereas in the surgery, these are intervention related. Many of the studies in the interventional cardiology are company industry supported, whereas in the surgery, the investigator-initiated trials are much more than the industry-supported studies in cardiac surgery. If you look at this temporal trend showing that significant number of studies are registered, but not all studies are completed. So in conducting surgical trial, randomized control trials in cardiac surgery has so many challenges we have to meet. They can be related to trial design and then trial implementation and the data analysis. The issues with trial design is equipoise. Equipoise is a situation where there is no clear evidence that one intervention is superior or inferior to the other, and is the prerequisite for the design and conduct of. Individual equipoise refers to individual clinicians, whereas collective equipoise or clinical equipoise applies to the profession as a whole, as expressed in guidelines or recommendations. In surgery, equipoise is more complex than in medical fields, as factors such as competition for referrals, personal prestige, past personal experience, or medical legal concerns may affect surgeons' preferences. For example, the Ruby trial is a randomized on and off pump trial, was designed early in the implementation of off pump coronary bypass surgery to allow inclusion of adequate number of surgeons. The expertise criteria for participation was set at the existing industry standard, yet a high crossover rate in the experimental arm was observed. As off-pump technology evolved, the higher volume thresholds were established by subsequent trials. The tracker trials is an interesting concept, the design of tracker trials that track changes in treatment or clinician attitude. It helps in refinements and changes in the treatment are incorporated in the study by modification of randomization strategy. Sham surgery is the rationale for sham surgery is to enable a double-blind design and minimizes the placebo effect. Sham surgery includes similar anesthesia, skin incision, and tying in the operating room experimental group. One of the examples is a classic study of patients undergoing surgical ligation of the internal thoracic artery to treat coronary artery disease. All the patients submitted to sham surgery reported improvement in symptoms in the trial. Blinding is another important aspect in conduction of RCTs. The expectations of patients or assessors may influence trial outcomes and adjudication. The term blinding refers to keeping trial participants, investigators, and/or the assessor unaware of the assigned intervention. Blinding makes it more difficult to bias results intentionally or unintentionally and increases the validity of the findings. Surgical trials are usually open, although some of them use the blinded endpoint. In our promote patency trial, we use the blind endpoint where the assessment of the graft patency was assessed by the assessors who were blinded to the technique we used in the conduct of the operation. Few double-blind surgical trials have been published. RAPS, the radial artery patency study, a graft patency study, the SSR were blinded, although the appearance of the graft may have unblinded the SSRs. Surgeon expertise is another important in conducting surgical trials. A volume outcome association has been demonstrated for several procedures in cardiac surgery. Because of training and experience, individual surgeons are generally more proficient in particular technique. Eligibility requirements for surgeon based on the minimum volume of the specific procedure have been used in many trials. However, choosing the right threshold may be challenging. If the threshold is too low, surgeons recruited into the study may not have enough experience to perform the procedure safely and correctly. Conversely, if the threshold is too high, it may be difficult to recruit enough investigators and the external validity may be jeopardized. There are several examples published in the cardiac surgery data where divergent results among the trials may be explained by the surgeon's eligibility requirement. Two large randomized controlled trials comparing and off and on pump CABG used very different surgeon experience criteria and reached different conclusions. The difference in surgeon's experience has been proposed as one of the explanations for this difference. In the ART trial, arterial revascularization trial, higher than expected crossover rate from the experimental to treatment group was seen, with the values for individual surgeons varying from 0% to 100%, which has likely influenced the results. Expertise-based trials, expertise-based randomization may enhance the recruitment as surgeons may be more willing to recruit patients knowing that they will use their preferred technique, and patients may be more willing to participate knowing that they will be treated by an expert surgeon. It has also been proposed that expertise-based trials are more ethical than the conventional trials. A few trials in cardiac surgery have used the expertise-based approach. The coronary trial is one example. Similarly, the promote patency trial, what we have done, is also another example. Now, the Roma trial, which is conducted at several centers in the world, is also a study that was based on the expertise-based randomized controlled trial. Adaptive designs, adaptive trials collect information is used at pre-specified time intervals to make decisions about future study revisions. In all cases, adaptive procedures introduce efficiency in the clinical trials. Defining intervention and other outcomes is very paramount importance. Ideally, the definition of intervention in cardiac surgery as it is should follow 3 steps. A clinical description of the intervention should be provided according to the standard practice. A more detailed description should be provided, including the operative procedure and recommended technologies. A clear statement and justification of how this differs from the standard practice is needed. The same information should be provided for the control procedure, so also the post-operative treatments be detailed. Recent examples of trials where more frequent and less clinically relevant components of the primary composite outcome drove the results of the main analysis. They are the Excel trial and the Partner 2 trial. A trial can only be reliably address a single research question based on the primary outcome measure. Therefore, most efforts should be made in defining the primary outcome. Funding is one of the key challenges to the success of any RCT. For surgical trials, obtaining adequate funding is particularly difficult. The Cardiothoracic Surgical Trials Network, cardiac surgery was identified as a gap area by the National Heart, Lung and Blood Institute of the United States in 2004. Together with the historical difficulty in conducting cardiac surgical trials, this led to the NHLBA to establish the Cardiothoracic Surgical Trials Network in 2007. The primary goal of CTSN is to design, conduct, analyze collaborative clinical trials and studies that evaluate novel products, surgical interventions, and related management approaches for the treatment of cardiovascular disease in adult patients. So far, CTSN has got key achievements include 9 RCTs and 3 large observation studies. Recruitment and retention is an important aspect and an important challenge in clinical trials. Majority of the cardiac surgical trials recruit slowly, which may affect outcomes and results in early termination. Barriers to enrollment and retention of patients may be affected by the specific disease under investigation, the availability of adequate therapeutic modalities, and treatment under investigation. And they all fall into 3 categories. One is equipoise, screening, patient and physician engagement. The priori establishment of clinical equipoise is the key for the trial's success. The use of large database analysis and surveys may be appropriate to determine the usual practice. A second key factor is an effective screening process and the adequate enrollment of diverse population. The third key factor is the engagement of patients throughout the follow-up period. Coming to the data challenges in data analysis. Randomization allows comparability of the trial arms for all measured and unmeasured characteristics if the number of randomized patients is large enough, and also allow proper causal inference. During the course of a trial, many factors such as crossover or withdrawals or lost to follow-up disrupt randomization process. This form of non-compliance causes loss of statistical power in the best case scenario, and the serious selection bias after study entry and attrition bias is the worst. Issues with the data analysis. The statistical methodology to mitigate the bias introduced by crossover and loss to follow-up include instrumental variable analysis, imputation techniques that amount for the potentially differential dropout across study arms, the marginal structural models, and other models account informative sensory. The learning curve effect. During the learning curve for a new technique, the trial results may be affected by the degree of expertise and acquired by the operator. During this time, a time-dependent form of confounding may obscure the true results of the trial. The health economics and the cardiovascular surgical trials. Cost-effectiveness analysis provides a framework for comparing the relative value of different treatments, where the metric of comparison is the ratio of the difference in the cost to the difference in the effectiveness. Artists offer opportunity to capture data on resource consumption and measurement of health outcomes, and this can be used to estimate cost effectiveness. I recommend this, one of the review articles well written by Dr. Gardino, which was published in JOC early in this year in the very eminently, very elegantly written review on the randomized controls in cardiac surgery. The Indian surgeons have participated in STITCH trial, coronary trial, ART trial, Restore MB, and we have the Promote Patency trial, a multi-centric randomized study, which were conducted in India. Our experience, we participated in the multi-centric trial exclusively conducted on from the Indian centers, that is a Promote Patency trial. We also participated in multi-center international trials like ART trial, and also the multi-center randomized study is in the process of initiation, the predict from ICMR, which would be starting shortly. This is any trial we conducted, we have to publish the trial results. We have published our Promote trial results in Indian Journal of Thoracic and Cardiovascular Surgery, which is recently indexed in PubMed. So this is one of the great achievements in the further trials that we conducted in India. There are several Indian surgeons participated in the 3 important trials, global trials. The critical pathway of clinical trial is the planning, the protocol, CRF, regulatory and ethical approvals, the documents and materials, the selection of the investigators, initial visits of the site assessments, the patient recruitment, the periodic monitoring, study termination, data entry, data cleanup, statistical analysis, and final report. The pathways for RCTs in cardiac surgery is mainly the selection of the clinical question for the trial, how to design a randomized trial, challenges in the conception stage of randomized trials, choice of primary outcome measure, sample size calculations, and challenges in the randomized trials in the cardiac surgery, the multi-center trial organization and implementation, budget and funding option for the randomized trials. Clinical trials, transparency, accountability, and to increase the public trust in the conduct of clinical research. Clinical trial registration and results reporting would help ensure unbiased public records on safety and efficacy of the treatment. All clinical trials should be registered before the enrollment of the first patient and all results made publicly available. In India, we have to register our RCTs in the Clinical Trials Registry of India. We have registered our predict trial prospectively in the CTRI before we start the trial. With all the challenges, there is another big challenge in conducting clinical trials. We require change in culture needed to increase RCTs in cardiothoracic surgery. An excellent article reviewed and published in the Annals of Thoracic Surgery, written by Gardino, explain all the necessity. What we can change in culture is essential to increase the RCTs in cardiothoracic surgery. To conclude, randomized controlled trials in cardiac surgery in India are yet to take off. There is a need for change in culture for cardiac surgical community to increase RCTs in cardiothoracic surgery. The multi-center RCTs in cardiac surgery in India are very much doable, provided good research teams are developed in every institution. The challenges in conducting RCTs in surgical trial can be overcome if we develop suitable system to conduct clinical research. Thank you for the attention.
Thank you, Dr. Lokeshwar Sajja, for a nice talk on the multicenter clinical trials, enumerating all aspects of clinical trial, right from the criteria, the types of RCTs, funding, the critical pathways. And thank you so much for your talk. We have an eminent panel today to discuss on these two important topics on clinical trial and COVID protocols. We have our president, respected Dr. K.S. Iyer, Director of Pediatric Cardiac Surgery at Fortis Escorts Institute, Delhi, and Dr. Maghirwal, our Senior Vice President and Director of Adult Cardiac Surgery at Fortis Escorts Hospital, and Dr. Bhupesh Shah, Senior Consultant from Ahmedabad, to discuss on these two topics. First, I invite our President, Dr. K.S. Iyer, to give his views on the clinical trials. Sir, like what do you think are the restrictions and limitations for the young surgeons to take up clinical trials, or senior practicing surgeons to take up clinical trials in our country, which will definitely improve our outcomes and show the world that we too have evidence-based cardiac surgical practice?
Thank you, Shiva. Let me at the outset congratulate both speakers, Dr. Hiranmath and Dr. Lokeshwar Sajja, for their excellent and very well presented talks. I think they were in extreme detail and very well presented. So congratulations to both of you. And Dr. Lokeshwar, of course, very eloquently laid out the need for having randomized controlled trials, the way to go about conducting randomized controlled trials, the pros and cons. And of course, he also enumerated on the various difficulties. But as we progress along the field of cardiothoracic surgery in our country, what we have achieved over the last 2 decades is mainly focused on the clinical aspects of our practice. And we have advanced leaps and bounds as far as the clinical care of the patients is concerned, as far as implementation of surgical techniques. And we have reduced the timeline between the development of a new surgical technique and its implementation in our country. Way back in the 70s and 80s, it took probably about a decade before a surgical technique was developed in the West, and by the time it got implemented in our country, which is true for the advent of open heart surgery, and then subsequently the advent of infant cardiac surgery, neonatal cardiac surgery. Now, that timeline has considerably reduced, so that not only is a newer technique which has been described in the West very readily and rapidly implemented in our scenario, but also techniques have been developed indigenously in our own country. So that's one huge area of advance that we made. But where we lag behind, as has been explained, is in basic research. And clinical research has been largely so far observational. And most of our publications have resulted from observational studies, from retrospective reviews of patient follow-up, etc. And the world today relies mainly on randomized controlled trials. And essentially, that's where the publications will receive maximum number of important citations. So if one were to publish an observational study, it's not going to receive as much importance as is going to be a randomized controlled trial. Having said that, unlike in fields of cardiology and other where patient populations are huge, the cardiac surgical populations are relatively smaller. And especially if one is embarking on a new surgical technique, or even trying an established surgical technique to find the superiority or inferiority vis-a-vis another surgical technique, the relative numbers of patients that can be recruited are going to be smaller. And therefore, the need for a larger collaboration of units and hospitals in order to be able to generate an adequate cohort to have a statistically meaningful study. And unfortunately, because the vast majority of our cardiac surgical units, especially The more voluminous ones are in the private sector, in corporate sector. That becomes an added problem when one is trying to conduct a randomized controlled trial study, because the effort has to be entirely on the part of the surgeon to push it through. And the corporate entity or the private hospital that the individual is working in is not really going to be seriously interested in promoting that activity, or may even look upon it or frown upon it if it impinges on their financial balance sheet, or even if they perceive a potential litigious situation that might arise out of this. So there are a lot of background noise which prevents any surgeon from actively embarking onto a multicenter. The second, of course, is a patient issue, because our patients are by and large not that enlightened. And if you take an average patient who comes from a rural background, the moment you mention the term that we would like to enroll you into a trial, the immediate interpretation is that they are being experimented upon. And there's a huge reluctance on this part. And that sort of word very rapidly spreads around and say, oh, you go to this hospital, they perform experiments on you. That's another negative which happens, unfortunately, in our society, which is again detrimental to conduct of research trials. The third, of course, is sometimes I feel that although we have ethics committees and institutional research review boards, which are meant to monitor as well as ensure that the patient's safety is maintained, sometimes I feel they tend to go overboard in terms of the restrictions that they put on the studies, in terms of the type of consent forms that they require patients to sign, and in terms of the liability of the research team towards any potential complication that may arise. I have sat in very many of these ethics committee meetings, and I find that the number of objections raised and the number of clauses put in is enough to dissuade any researcher from trying to conduct. So I think a lot of these issues need to be ironed out, but certainly with people like Dr. Sajja, I'm sure we will make important strides even in this area.
Yes, sir, very true. And we need to get rid of all the difficulties and the negative thoughts about funding among the surgeons. Like Dr. Sajja can definitely promote enthusiasm among the surgeons in taking up, initiating, or at least be part of an existing clinical trial. Thank you so much, sir, for your comments. I invite Dr. Magarwal, our senior vice president, to give us comments on the COVID protocol. Sir, we were discussing about protocols for COVID patients or COVID suspects in the perioperative period or post-operative. Now, like from now on, we're going to have a lot of post-COVID patients in our practice. So what is your advice for young surgeons to deal with post-COVID patients coming for adult cardiac surgery?
So thank you, Shiva. Again, let me congratulate Dr. Hiremath for an excellent talk, and of course, Dr. Lokeshwar for another excellent talk on two different topics. And I'll make a few comments on both the speakers. Answering your question as to what the young surgeons, in fact, no, it's not only the young surgeons. Every surgeon obviously is dealing with the COVID patients and has to see what best can be done for the patient, at the same time protecting the community as a whole, the medical fraternity. If you look at this time, obviously the number of cases are less. Of course, it varies from geography to geography. One area has a lot of patients, the other area has less number of patients. But at the same time, a couple of months back, the number of cases were increasing. So I think we had to be prepared that this scenario probably go on. The number of cases will be less. The number of cases would go up at certain point of time. So the things which you have to keep in mind that one, whenever the number of cases decrease, we still have to continue to take all the precautions, which obviously would be taken in a scenario when the number of cases are high. So the COVID appropriate protocols, which obviously have been laid down by many committees and many associations. And at the same time, every institution probably need to develop its own protocols as well in a situation where the number of COVID patients are high. But your specific question was that how to deal with the patients who are post-COVID. Again, there is very clear data now that patients who have recovered from COVID, they certainly have a little high morbidity and mortality as compared to patients who are not affected with COVID. So in our own practice, what we do that all patients who are post-COVID, they're seen by a pulmonologist, and the pulmonologist will specifically look at the risk based on the HRCT and the clinical scenario of the patient. And then obviously you need to see whether this patient need to wait a little longer. So suppose the patient comes 2 weeks after the recovery and the HRCT still shows significant changes, you discuss with your pulmonologist and discuss if waiting and adding some anti-fibrotic therapies or some other therapies can help this patient to improve, and then you call that patient after a few weeks again to operate. But obviously, if the pulmonologist feels that waiting another 2 weeks or 4 weeks and 6 weeks is not going to help, then obviously you take the patient. But then obviously you have to keep in mind that that the risk may be a little higher. If I look at my own experience in our unit, what we have realized that patients who have recovered from COVID and have undergone cardiac surgery, the ICU stay and the hospital stay has been longer. And it has again mostly been because of their pulmonary problems. So see, these patients certainly need a little longer ICU stay and the longer hospital stay. We have not analyzed our data comparing the COVID recovered patients with non-COVID recovered patients, but offhand it looks like that the mortality, at least in patients who don't have major HRCT changes, is not too different, except as I said, the longer stay in the ICU and the longer stay in the hospital. So we have to continue to, I think, evolve our own protocols, which would be based on your own experience, but at the same time, based on the published literature. So that's my advice for your question. And I'd like to make certain comments on Dr. Lokeshwar's talk also. I must congratulate him and thank him for giving this talk, because I hope there would be some stimulation for our young cardiac surgeons to enter into the area of research, which, as Dr. Iyer has very clearly mentioned, is definitely lacking in our country, in spite of the fact that we have large clinical volume. We all know the importance of the randomized controlled trials, and Dr. Iyer, who has been the editor of our journal for many years, obviously has very clearly mentioned that the highest level of evidence is with the randomized controlled trials. So we certainly should try to get involved as many as possible. But I would also mention here that even the prospective observational studies, they have their own importance. Obviously, the retrospective studies probably will not be that important or will not have the same impact, but the prospectively collected data, so prospective observational studies, particularly the multi-institutional. So multi-institutional prospective observational studies, I think, would also be as important as the randomized trials, which might be relatively easier to conduct as compared to the randomized trials. If you look at the guidelines in cardiac surgery, and for that matter in other specialties as well, a lot of guidelines actually are not based on the level of evidence A. Those guidelines are based on the level of evidence B, because we know that in many situations the randomized trials are not possible for many reasons. So, and secondly, for the young surgeons, obviously, this will give them an experience as to how the trials are conducted, how they can be part of the study, and certainly then they should definitely go to the randomized controlled trials. So I think prospective observational studies at the multi-institutional level certainly can also be an important area of research for everyone. And at the same time, even the registries, I would say, the registries also are important. The ISCTS has started the ISCTS database. Unfortunately, we don't even have our basic data of surgeries conducted in our country. So we don't even know how much is the volume. So I think we probably need to look at everything, the registries, the prospective observational studies, as well as the randomized control trials. The funding certainly is an issue for these trials. And in India, unfortunately, there are not many agencies who will fund. And the other important thing which probably has not been mentioned about the funding, that in India, the government agencies, they scrutinize these trials very carefully from the private institutions to fund. So if the study obviously is being conducted by, for example, 10 institutions who are in the private sector, the funding may not necessarily come from the major institutions who fund or the major agencies in India. So that's something which probably again is not really the best thing to do. And funding certainly, but at the same time, for example, Dr. Lokeshwar has applied to the ICMR for the funding, and obviously, if the ICMR feels that this is a good study for the country, they certainly do it. So I think we have to collectively work together and work in all the areas, starting from the registries to the prospective observational studies to the randomized control trials. Thank you.
Thank you, sir, for your valuable comments. So, Dr. Shabari, I'm not sure whether Dr. Bhupesha is part of the.
I think it's not logged in. I just checked.
Oh, fine. Then, yeah. So, thank you, Dr. K. Zair and Dr. Meherwal, for your valuable comments on these two important aspects in cardiac surgical practice in the coming days. And thank you, speakers, Dr. C.S. Hiramat and Dr. Lokesh Sajja, for fantastic lectures and sharing your experience and motivating surgeons to take up, follow these protocols and the clinical trial guidelines. Thank you so much, sir. I hand over the podium to Dr. Shabari.
Yeah, thank you, Shiva, and thank you to the speakers and also for panelists for the excellent session which we had. I think with this, we have reached the final stretch of the conference, and I would like to express my vote of thanks to everybody. At the outset, I would like to thank ISCTS to allow the Department of Cardiac Surgery at Sree Chitra to organize this today ISCTS Technocollege. And for that, I express my thanks to ISCTS President, Dr. Iyer, and also to all the members of the ISCTS Executive. It would no words can express my gratitude towards our secretary, Dr. C.S. Hiramat, who has been right from the beginning, who has been supporting us all through the way, and has always been encouraging in terms of how to conduct. He's given us a lot of suggestions, he's given us a lot of opinions, and he has helped us right from the beginning. And also our treasurer of the ISCTS, Mr. Umberker, who really helped us out as far as the financial aspect of the program goes. And then I would like to also thank all the speakers, all the expert panelists, and all the discussants who right from the beginning, the moment we called, agreed to speak in this conference. And they were really supportive, and they agreed to speak on the topic that we suggested to them. And for that, I would like to express my gratitude to all the speakers, to all the expert panelists, and all the discussants. Also, I would like to thank all the delegates from all over India and also from overseas who had joined this conference and made this conference a great success. I would also like to thank our organizing president, our teacher, our mentor, Professor Jayakumar K, who was with us throughout this program like a solid pillar, and who encouraged us and motivated us to organize this program. And also the Department of CVTS at Sree Chitra, led by our head of the department, Dr. Baiju Dharan, and all the faculty members of Sree Chitra Cardiac Surgery Department, Dr. Verghese, Dr. Binish, Dr. Sudeep, Dr. Saumya, Dr. Renjit, Dr. Simon, and Dr. John, and also all our residents who were with us for this program. Last but not the least, I would like to express my gratitude. In no words, actually, I can express my gratitude to Dr. Vivek V. Pillai, who right from the inception of the plan to conduct this program to the culmination of this program to this point was with me, and together we took step by step all the steps to conduct this program, and therefore the success of this program should go to Dr. Vivek Pillai. Also, I would like to thank all the sponsors who supported us for this program. With these few words, I would like to end this session. And I once again thank ISCTS to grant us this opportunity. And I hope in future also Department of CVTS at Sree Chitra would get opportunities to organize more academic functions. I think with that, I think it's time to call an end to this session. Just 2 minutes, I would like to invite one of our sponsors from Medtronic to speak few words. And after that, we'll have a national anthem. Thank you to all.
Sir. Thank you, sir, for the opportunity to Medtronic. I'm Ravi Patel. On behalf of Medtronic, I would like to thank you. And I'm product manager for energy-based devices and surgical safety device. I'll just take a few minutes, and then my colleague Lakshay will take a few minutes before we move to the next stage. We are very happy to introduce our latest innovation in ValiLab electrosurgical unit category, that is ValiLab FX8 energy platform. This platform is now launched after the trust and confidence you have shown us in ValiLab Force FX series electrosurgical unit, which was launched in 1995. Now we have upgraded our electrosurgical capabilities with FX8 Gen energy platform. The unique benefits of FX8 energy platform are tissue effect, tissue sensing technology, which monitors changes in the tissue impedance at the rate of 434,000 times per second, and also adjust the energy delivery accordingly. It means you can get your desired clinical effects at a lower power setting. Also, it is having more precision and accuracy and deliver 99.4% of original power setting to your tissue with only 1.75 standard deviation. Also, it has now unique mode attached to ValiLab FX8 energy platform, which was not available in Force FX series. That is ValiLab mode, which is unique combination of hemostasis and dissection. With this, you can decide the clinical effect you want, and you can move the pencils accordingly. So if you move the pencil slowly, it will give coagulation effect. If you will move the pencil fast, it will give dissection effect. It has a cut and coag button, but additionally there is a third button, which is a transparent button called ValiLab mode. It will give more appropriate clinical effects at a lesser thermal spread with a lower power setting. Also, it has continued to have RAM, which is return electrode monitoring contact quality monitoring system, which prevents patient burns. And in addition, it has ValiLab Exchange software update system, which means that you can get the latest performance features as and when released by ValiLab with the software upgrade only. So no need to upgrade overall hardware, and it can be upgraded into your OT only. It also have now sad coagulation and another soft coagulation modes with the touchscreen, three quadrant touchscreen. So enjoy the precision and accuracy with our latest innovation in electrosurgical category with ValiLab FX8 energy platform. Also, we are very pleased to introduce our latest innovation in ultrasonic energy, that is Sony Cision curved jaw cordless ultrasonic dissection system. It is world's first cordless device in ultrasonic energy, where the battery is used to convert the convert electrical energy into ultrasonic energy with the help of a transducer. We believe in cordless freedom because you can't afford to be tied up in the OR. The main changes are it has a now curved jaw, and also it has single button with dual active energy modes. The minimum mode can be used in the first position to have more coagulation effect, and maximum mode can be used in the second position of the same button for more of dissection effect. Also, the one charger can be used to power 4 OT for ultrasonic energy because it can charge 4 batteries simultaneously. It has different battery charging indicator status. This is the real innovation by Medtronic R&D team, where the whole bulky generator can be converted into a small generator which can fit to your palm. We also have rapid smoke evacuator system, which is a universal smoke evacuator system and is compatible with all the electrosurgical unit available in the market with the use of optional accessories. It also utilizes 4-stage alpha filtration technology with which provides 99.995% filtration efficiency at 0.12 micron particle size. Also, the filter life is dependent on the activation time, which is 25 hours activation time per filter, and not on the airflow level. So it means you can have 25 hours of activation time. Also, thank you for your support on LigaSure vessel sealing technology, which has now completed 21 years of research and development, and it is used in more than 25 million procedures now, and it is backed by 1,300 clinical papers around the world. And you can have LigaSure energy benefits with our FT10 energy platform, which is a combination of monopolar energy, bipolar energy, and LigaSure energy, LigaSure vessel sealing technology as well. In future, our R&D team is working to equip the same FT10 generator to have a ablation device like a CardioBled from our cardiac team, also which will be compatible with our FT10 energy platform only. So feel the freedom with cordless ultrasound dissection system called Sonisys and Covjo, and you can reach out to us by scanning the QR code as well. Over to you, Lakshay.
Thank you, Ravi. Hope I'm audible.
Yes.
Thank you, Ravi. So good evening and good afternoon to everyone, to all the delegates who have joined us from India and abroad. So I'm here today to basically take everyone through our portfolio of surgical stapling as well as devices. So starting from the laparoscopic stapling, so Medtronic has had a very, very rich history of surgical stapling, which started from 1990 onwards, and we have innovated, over in our journey of about 30 years now. And we were the first ones to introduce the powered stapling system in 2012, and followed by that various reloads. And then came Signa, which is a very, very amazing powered stapler. Now, the central to our stapling technology is tri-staple, which is actually 3 rows of staggered staple heights, as you can see in this picture. All the 3 rows are staggered, unlike the flat ones, which are there with other companies. So we call it tri-staple, and it basically ensures there's less stress, more perfusion and variability performance in the tissues. Next, for all the cardiovascular thoracic surgeons, we actually have this amazing product, which you can see, which is endo-GIA curved tip reload, which actually helps in stapling on the vessel, especially in the tighter spaces in cardiothoracic surgeries. We also have black for the extra thick tissues of the lung, which is routinely highly used by all the cardiothoracic surgeons in India. Then there is a very, very slim anvil profile of 30 mm to actually reach very, very tight spaces, and if you want to staple on any of the tissue, the ducts or the vessels. And there's reinforced, which are for hypertensive and obese patients. Now, this is our gun, the endo-GIA staple gun. The beauty of this gun is more than 50 loads, any color, any shape, any size, any technology of Medtronic can be attached to this. That's the beauty of this gun. And we just have this one gun globally, which is available in 3 sizes. So the beauty is anything can be attached, any color, any shape, any size. You don't have to buy separate guns as per your needs. And then comes the Signia. Again, any reload can be attached with Signia. This is world's first rechargeable, reusable, smart and powered, fully powered stapling system. Everything is powered. The rotation, articulation, firing, jaw opening, jaw closing. We have some pictures here in the presentation which show you that various cardiovascular thoracic surgeons are actually using this. And then it also has smart tissue sensing and adaptive firing technology, which senses how fast or how slow and how much force I should exert on the tissue, depending upon the tissue thickness and the reloads attached. It shows you different zones right on the OLED screen. That's the real-time feedback. Again, 300 cases, amazing. One gun, you'd have to buy 300 guns. One gun can do 300 patients. A real-time feedback on OLED screen, more than 50 reloads can be attached. As I said, any color, any shape, any size, anything, any reload can be attached to this. We also have endo-TA, which is actually 3-row linear stapler for laparoscopic cases. It basically has found its use in laparoscopic nephrectomies, liver transplants, and cardiothoracic procedures as well. In the open stapling, we have this DST technology, which is our patented rectangular cross section, not a rounded cross section. This is directional stapling, and within directional stapling, there are 2 products that I would like to highlight within the cardiovascular thoracic, which can be used. This is an open linear cutter stapler, and this comes with DST. It's got a lock in it, and it's very convenient to use. Now, this is also very interesting product, especially for wedge resections. You can use this. It's not a very, very costly product. It's comparatively quite cheap product. The reloads are also quite cheap. It places 2 rows of titanium staples, and then there is a knife area wherein across the cutter you can actually just cut it as per your need of the resections. Then comes our trocars, absolutely fantastic trocars, because all of them have same cannula and the obturators can be different. So the cannula technology is the same, so that's why it's called versatility in one, which is called Versa 1. Very, very smooth dolphin nose tip. It's got a ribbed cannula as well, so that the trocars doesn't move. Then comes the main product, I would say, within the axis, which is our Sree sleeve. Now this is going to be of maximum use for cardiovascular thoracic surgeries, wherever you have the incision size ranging from 2.4 centimeters to up to 11 or even 15 centimeters in C-section surgeries. We got 5 sizes. It actually ensures not only there is a retraction while you are performing the surgery, but also there is a wound protection of the peritoneal surfaces. So, and of course, it gives you a great exposure. The material is also 3 times stronger. Another best part is the price is very, very competitive. It will be in the range of 4,000 to 6,000 rupees per case. Now, as you can see, I've just shown a few pictures of certain cardiovascular thoracic surgeries here, wherein Sree sleeve is getting used, and wound protectors have also found as a recommended list of products usage in World Union of Wound Healing Societies as well as by WHO. So the use of wound protectors have been seen to reduce the incidence of surgical site infection. So we have surgeons here who are using wound protectors along with this Signa powered stapling system, and here also you can see them using iDrive, which is another powered stapling system. So that's the Sree sleeve. Moving towards the last product, now this is our EndoClip clip appliers. So this is a premium surgery clip or a clip applier that has got preloaded 20 to 30 clips depending on the model that you have chosen, and it actually offers greater security to the clip, as well as you don't have to take out your laparoscopic clip applier every time and then load a clip and then put it back inside. All the clips are already preloaded in this. Now, this one was for open surgeries. This is for EndoClip. This is for all the laparoscopic surgeries and wherever you have to reach towards the tighter spaces. Amazing product, has an LED at the back, shows you how many clips are remaining, 16, 15, 14, 13, like that. And it also has industry's largest clip length, which is 9.1 mm. And it is available with roticulation here. So the roticulation is also there and it can easily go through a 5 mm space area. Finally, this is the last product. If you actually hate fog while doing this surgery, it actually sort of distracts you from the surgical site, put a few drops of this product and on the lens, and for the next 30, 40 minutes, even 50 minutes, there won't be a film of fog while doing the surgery. It's very, very costly. It's very, very cheap, and it's quite a value for money. It's only for 400 to 500 rupees. That's it. Thank you very much.
Before we move on to the national anthem, I would just like to mention our sponsors. Edwards Life Sciences, Ethicon division of Johnson & Johnson, Medtronic, and BL Life Sciences and Healthium Private Limited for agreeing to sponsor this two-day conference. And in the end, I would like to express my gratitude to Planotech Bangalore, especially their leader, Mr. Darshan, and also Mr. Niranjan, who both of them were right with us. I think they did an excellent job, and we were lucky that we got their name recommended, and we decided to go with Planotech Limited for this conference. So I express my gratitude and thanks to both Darshan and his colleague Niranjan, and also all the other colleagues whom I don't know personally and by the name. With that, I think we can end this program. Thank you, everybody, and we will have the national anthem.
Dravid शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, sir.
Thank you all.
Thank you, everybody.
Thank you. Thank you, Sabrinath and team. Good job.